Very good afternoon to one and all here. And I would like to extend a very warm welcome to everybody for the annual conference by the Interventional Cardiology Council of Kerala. So we would like to start our first session for the Youth Conclave today. The first session will be Understanding My Tools. And I would like to invite the chairpersons onto the stage, Dr. Arshad, Dr. George Koshi, and Dr. Chahid.
Welcome to Icck 2023. Let us start the scientific program. We are starting with the understanding my tool. That is the initial one. And we all know that good angioplasty starts with the optimum guiding catheter. And Dr. Karuna Das from Trichy Medical College, head of the Department of Cardiology, will be speaking to us on choosing the guide catheter. Dr. Karuna Das, please.
Respected chairpersons, senior members of the faculty and friends. At the outset, let me thank Dr. Ashish as well as the whole ICCK team for allowing me to be the opening batsman of a two-day conference. Well, when I am asked how I am going to choose a guiding catheter, various points come to my mind. First is the size, which size I want. You should understand that the size of a catheter is expressed as the outer diameter of the catheter in French units, and 1 French is 1 by 3 millimeter or 0.333 millimeter. The usual guide size that we use is 6 French, so it will be around 2 mm in external diameter. Even though 5 French and other sizes are available, most commonly used one will be the 6 French guiding catheter. Because we can do a standard angioplasty and stenting, the regular angioplasty and stenting, we can take things like a cutting balloon, thrombus aspiration catheters, IVS or OCT catheter, guide extension catheters, embolic protection devices, and even rotabar up to 1.5 millimeter through this. If you see the books, it is written you can do a bifurcation angioplasty, including kissing balloons through a 6F catheter. But I will take it with a pinch of salt because if you are using 2 aux balloons, it may be difficult. And usually I choose a 7 French catheter for a planned bifurcation lesion. A rotabar of 1.75 as well as CTU interventions require 7 French. 8 French is seldom used if the rotabar is large, or for a directional atherectomy, it can be chosen. One should clearly distinguish between the French size of a catheter from that of a sheath, because for sheaths, it is the inner diameter. For catheters, it is the outer diameter. So naturally, a doubt may come, I am going through the radial axis. Can I take a 7 French catheter through the radial axis? It is possible, especially in males it is possible. If you look at the Indian Heart Journal data in 2022, the right radial artery at the conventional axis site taken from multiple areas all over India is around 2.56 plus minus 0.35 millimeters. And it slightly expands as you are introducing the sheath. If you have any doubt, do a Doppler. It's very easy, just keep the Doppler probe there, you can assess the radial artery size. And use special sheets like the Glide Sheet Slender from Terumo. They have reduced the outer thickness of the outer coat so that 7 French inside almost is equal to a 6 French outside. A larger guide catheters, if we are choosing, have the advantages of better support, better opacification, as well as better monitoring of the pressure throughout the procedure, with the inherent disadvantages of ostial trauma, access site complications, and use of excess dye leading to contrast nephropathy. The second point that I look at is whether this catheter is going to give me adequate support. Support may be passive or active. Passive means it is the design of the catheter, the stiffness of the material, the backup obtained by supporting the catheter on the opposite aortic wall or the aortocoronary sinus. Active is actually a manipulation of the guide to confirm with the aortic root or deep engagement into the coronary arteries. The support or the backup force of the guide catheter is decided by 3 factors. One is the size, we already said about that. Second is the angle, the theta angle made by the catheter on the opposite wall of the aorta. You can see that angle here. And third is the catheter's area of contact with the opposite wall of the aorta. Lot of experiments have been done, and it has been shown that a JL catheter, if you take, see the theta angle, it is very small. While the same JL catheter taken through the femoral axis has got a wider angle and a better support on the backside. So the support offered is better if you change to femoral axis. And Icck left has got a better support than JL through the radial axis. Whether you choose the radial axis or the femoral axis, look at the EBU catheter. It has got a large area of contact, a wider angle, both the axes, so it gives very good support. If you look at MPLATS, it has got a large area of contact, plus the secondary curve rests on the non-coronary cusp and gives support. So, in general, if you want a good support for the left coronary, MPLATS left scores over EBU over JL. While on the right side, MPLATS left scores over MPLATS right as well as the JR. You don't need this support for all kind of angioplasties. Only if the vessels are very tortuous, if the lesions are long, calcified, or you want to take devices, you need such support catheters. If you have already chosen a catheter but you want to increase the support, you can change the axis, use a long sheath, you can increase the guide size, and use other maneuvers like a buddy wire, anchoring balloon, or a guide extension. The third point we have to look at is the catheter curve. It should be optimal for a given anatomical configuration, which is decided by the width of the aorta as well as the origin and takeoff of the coronary artery. Usual aorta is around 3.5 to 4 centimeters. If it is less than that, it is narrow. If it is more or 4 or more, it is dilated. You should have an idea about the curve of the catheter. When you say JL3, it means the distance between the primary and the secondary curve. 3.5, it is longer. 4, it is slightly longer. And it is this part that is going to be rather horizontal or rather touching the two walls of the aorta. So if you have a dilated aorta, go for a larger curve catheter. The same with EB also. 3, 3.5 and 4. You see the difference. The second point is regarding the origin of the coronary. Usually you have the LCA, normal origin, RCA, normal origin. Both of them can have a slightly superior and anterior origin. And sometimes the RCA comes from the posterior part, from the left sinus. Then you can have so many different anomalous origins, but these are the common ones. So the right coronary can have 3 types of takes off also. One is horizontal, the other is pointing downwards, the second one, and the third is a superior one with a shepherd's crook curve. So if you have an inferior curve, as you notice from the diagnostic angiogram with the tiger, an inferior takeoff, a multi-purpose catheter will be easy to engage that when you're going for the plasty. On the other hand, if you have a superior takeoff with a shepherd's crook, better will be a MPLATS type of catheter. RCA arising from the left sinus, as seen on the diagnostic angiogram. In the second panel, you can see it was hooked with the Icck catheter, and in the third panel, you can see it was hooked with the JL catheter pushed down. Left coronary takeoffs can be horizontal, inferior, or superior. If it is a superior origin, it's better to choose a shorter curve. Many people think that if it is superior, you need a longer curve to reach that. Instead, you take a shorter curve, it folds upon itself and gets into the artery. As is shown here, you can see the normal engagement of the EBU catheter. A superior origin, the yellow catheter, is a shorter one and it points up, as shown in the third panel here. If it's an inferior origin, actually a longer curve is easy to engage. The fourth point is whether you require side holes for your catheter. Normally, perfusion occurs along the sides into the coronary artery, but if your catheter occludes the vessel, side holes are required to allow the perfusion. This will prevent ventricularization as well as dampening of the pressure, which may be seen if there is a significant ostial lesion, if a large guide is used in a small coronary artery, coronary spasm, or misalignment of the guide. Side holes do have the advantage of maintaining the perfusion, but at a false sense of security because you are monitoring the aortic root pressure and not the coronary pressure. The dye escapes through the side holes so that you have got a suboptimal opacification and you tend to use more contrast. Sometimes your wire comes out through the side hole. Before getting into the coronary arteries, you have to be careful and more chance of kinking out the tip. So in the first panel, you can see a small RCA. When the Tiger catheter was used for diagnostic purpose, there was damping of pressure and a side hole RCA catheter was used and the procedure was completed. An EBU side hole was used in this case because we thought it requires a lot of support, a bifurcation lesion, a 7 French EBU with the side hole was used and the procedure was completed. The fifth point is regarding the length of the guide. The usual guide is 100 centimeters. If you are going for an SVG intervention or a Lima intervention, probably you require a shorter guide if it's a distant lesion, 80 or 90 centimeter guides. Coming to that, for Lima interventions, one could use an RCA guide or use a specialized catheter like the left coronary bypass catheter or the internal mammary catheter, Lima catheter, which has got a very acute bend so that it is easy to cannulate the Lima. Here, an SVG graft is being cannulated with the right JR right on this panel, while this on the second panel, an Icck catheter was used to engage the SVG graft. So, in a nutshell, in the time allotted to me, I will say that selecting a guide catheter depends on the French size of the catheter, the support that you require depending on the type of lesion you are going to tackle, the curve depending on the anatomy, the aortic width as well as the coronary origin and takeoff, whether you require side holes, is there an ostial lesion, a bigger catheter is being used in a smaller coronary artery. If you are going for a SVG or a Lima intervention, a shorter catheter. And finally, lot of anomalous origin of coronary artery may be there. I am not going into that because by itself, it's a very big topic. I think you can read this. I thought there will be fellows here, but I see very few fellows. So that you can read this. There is a good article in Jack Cardiovascular Intervention regarding the selection of catheters and angiographic views for anomalous coronary arteries. They have beautifully described various catheters. I have not seen such catheters, but beautifully described in that article. So let me conclude by saying that a PCI without a good guiding catheter is like a house with a very bad foundation. You are going to land in trouble. So choose wisely. This is from that picture where the Holy Grail, three vessels are offered for taking the Holy Grail. I thought Abhilash is fond of all these cinematic videos, so choose wisely. Thank you for the patient listening.
Very precise presentation, sir. And just I want to ask you one complication of the most dreaded complication of the catheter is definitely the catheter. When we take out some longer balloons or NC balloons or bulkier balloons, in fact, the catheter used to suck in, and which will cause us the catheter into dissection, at least in occasions. So how do you prevent that? Like, what are the anticipatory methods by which you can prevent the gate lane induced the gate catheter induced dissection?
The most important thing is anticipate that. So usually when experienced operators do look at it, but when I see the DM trainees doing, they look at the balloon and start pulling. They are always interested in the balloon. They never look at the guide catheter. So if it's a long balloon, tortuous lesion, difficulty in pulling out, I always say you look at the guide catheter first and then start pulling. Don't look at the balloon, it will come out. That's the first thing. Second thing, a push-pull technique. That is, you just push a bit, pull a bit, then push again. Third thing, we disengage the catheter. If you are unable to do that, take out the catheter and then take out the balloon. Otherwise, then an ostial dissection may be produced.
I think that's very important because when your support becomes very good, the chance of dissection also
Becomes
increases.
high.
That is why you hardly ever get a dissection with a Judkin because it never goes deep and it does not give sufficient support. And with all the BU type of catheters, that is much more. Now the problem is when you engage the catheter before you wire, if there is a dissection, many times you will be in real trouble. That is one point which we should always remember. If you have the wire access, then things are easy. You can stent and all that. Especially with a radial intervention, you have to be all the more careful because you rotate the catheter and the catheter will be pointing up. And if there's a plaque or something like that at the superior aspect of the right coronary ostium, it can just rub there and the vessel can close off. And then it will be very difficult to wire and you will be in trouble. So extremely careful when you use all these catheters which give extra support, but be very careful. And another point, as you mentioned, the radial, because most of the interventions now
What
are
is the radial?
routinely done through the radial, unless it's too complicated or something like that. The 7F slender radial sheath is an excellent option.
Yes, yes.
Because as you have demonstrated, the outer diameter of the 7F slender sheath is similar to the 6F,
6F.
regular sheath.
Almost equal to the 6F.
So
slightly
when
more than
almost similar, there's very, very little
minute
difference.
difference.
Practically no big difference. When you introduce the sheath, it just goes like that. So whenever you anticipate some problem, as you mentioned, though we tell that with 6F sheath, you can take 2 balloons. It is many times
Slightly
difficult when you
difficult.
use the ox balloons. So better to change over to a slender 7F sheath, which ordinarily goes inside, unless it's a very frail, thin lady. Most of the men, it's very easy. Any other comment? Any questions? So thank you. Thank you.
Next topic is regarding the wire shaping. How should I do it? There is none probably better better describe this technique, because we have seen lot of fancy wiring shapes by Vinay Kumar sir. Welcome, sir.
Good afternoon, my dear teachers and dear friends. I was asked by Ashish to present this topic, how to shape the wire to simplify your PCI. We must have some basic idea regarding coronary guidance, because this talk was intended for fellows, and as basically to see wires can be classified in different ways, but I have adopted a simple system that is apt to this talk. Wires can basically have two types, those with a steel core or with a nitinol core. Those with a steel core usually have better torque, shapeability, and pushability. A nitinol core retains the shape, gives better support. Wire has got a shaft and a tip. The shaft continues as the core. Core can reach the tip in a tip-to-core design, where shaping may be a little difficult, or it can stop short of the tip with a shaping ribbon that supports the tip. Again, there's a platinum tip coil of varying lengths with very high radio opacity. The shaft diameter is usually 0.14, except for some special purpose wires. The tip can vary from 0.09 to 0.125. The tip coil can be polymer jacketed or non-jacketed. It can be hydrophilic or hydrophobic, that is silicone coated. Tip load varies between 0.6 gram for the thinnest wire, that is field XTR, to 13.9 grams for the Progress 120, which is the maximum. Then wires can be polymer jacketed wires. Again, polymer jacketed wires, a low tip load can be there like a field XT series. They can be there with a medium tip load, that is field FCs and Whispers. Those with very high tip loads can be there like Pilots, and those with a very high tip load, Progress is polymer jacketed, but the tip is left uncovered. The non-jacketed wires can be again low tip load wires like regular floppy wires or support wires, that is Grand Slam, Ironman, etc. High tip load wires are classically the CTO wires like Crosits, Miracles, Conquest, Gaia. Then high torque wires like the Turn Track, Sion Blue, and all. Then how can we facilitate wire access? As rightly pointed out, a proper guide selection is most important for a successful procedure. You have to get a coaxial engagement as coaxial as possible, as your anatomy permits, and the wire should be selected properly. Then there should be a proper deflection of the wire tip, and again use of microcatheters. Wire shaping, the purpose is to ease off your procedure. It can shorten the procedure time and fluoro time. It can limit check shots and definitely limit the amount of contrast used. It can access branches and help to preserve branches. There is definitely an enhanced accuracy which instills operator confidence. Wires can be available as pre-shaped wires. Some wires are available in both a J-shaped and non-J-shaped wires. They're straight as well as J. For example, these Whispers, Pilots, etc. are available in both pre-shaped as well as straight forms. Some has got a default J, that is a Gaia. Drawback, a default J may not serve the purpose. Now, the wire introducer is compared with the needle. Your needle is more stout and has got a bevel, where the wire introducer is a thinner one with a which is not beveled and it has got a round tip. It is not traumatic to your fingers and naturally not traumatic to your wires also. Using a regular needle, bevel needle for wire shaping is not recommended because it can damage the wire tip. Now, why do you shape the wires? Because you want to traverse branching points, you want to access major vessels, you want to negotiate tortuosities, you want to pierce CTOs, and sometimes you may have to cross into the lumen. Then in certain special purposes like a reverse loop to negotiate acute angles, a knuckle for subintimal tracking, then sometimes you may have to go for some eccentric curves, especially when the takeoff is from some aneurysm or something like that. And here you can see a highly angulated LED origin. It was given a shallow progressive deflection, and that was very easily wired and the procedure was completed. Now, again, coming back to the purpose, pre-shaped wires are available, but they have got a fixed curve. The desired wire may not be available in the lab. They may not match the anatomy. They may not suit the desired purpose, may not retain the shape throughout the procedure. You may note that your wire may go on losing its shape through your procedure. Then you may need a different shape to suit the change, because as you meddle with the lesion may change its anatomy and you may have to change the wire shape. Here you can see a total crush of the RCA with a branch that is taking off. Here I had to go for it's a progress 80 wire, and the wire was taken with a deflection of almost 6-7 millimeters, a J of around 30 to 40 degrees, which could easily take me to the distal lumen. Again, the different tip deflections can be a single J. You can give 2 coaxial deflections to give an angulation of up to 90 degrees. You can give a smooth progressive curve, a U loop for a reverse loop entry or a subintimal tracking. You can sometimes use a J with a reverse tip, and sometimes some 3D curves may be used. Now here you can see the angulation. Again, a highly angulated LED. See the angulation, and that was negotiated very easily with a progressive curve, and the length of the curve is almost 10 millimeters. Now, relevant factors for shaping the wire for branch access. One, alignment of the catheter, because in LMCA, many times your catheter may not be aligned properly and you may find it difficult. So a proper catheter alignment is especially useful when you want to cross into the LAD or LCX from the LMCA. So it depends on the geometry of the main vessel, the angulation of the branch, then the space for rotation of the wire, because many times you may shape the wire, but if the residual lumen is as narrow as say less than 1 millimeter, your wire shape may not help you. So you have to use the opposite wall as the hinge. So the space for rotation of the wire must be taken into account while shaping your wire. So you can see how a progressive curve can be made very easily. It can be made using it is very easy. You just see, the more of force you give, the deflection will be more sharp. So give a gentle but firm pressure, and see the wire is being shaped into a regular progressive curve. Now, if the wire has lost its shape, you can reshape the wire, and I prefer reshaping the wire with my bare fingers, because an introducer needle may not help you to reshape the wire back to its original shape. It's a whisper that has become turned into a U loop. It has been straightened very easily. Now the J tip has got the general shape of pre-shaped wire is a J. It aids to navigate the wire through a desired course. Shaping your J, a J can be shaped from a sub-millimeter to several millimeters. The angle of the J can vary from a few degrees to more acute, close to 90 degrees. So here again, another mid-RCA CTO with a branch takeoff. I used a progress wire here, and people may disagree with me because for selecting a progress for this, because the only wire available for me now is progress. So I have to cross all CTO. So now you feel that there is nothing like wire escalation or anything. You can do any case with the available wire. And it's a diagram. You can see that the wire takes a hinge on the opposite wall, and as the residual lumen narrows, your hinge has to move more and more distally. See, it has to move more and more distally. And once you enter the distal branch, you can go for an opposite rotation so that the branch can be taken towards the lumen again. Now again, another highly angulated LED. You can see the angulation. It is a highly angulated LED, and see the wire crossing that lesion. And at the end of it, this was the result actually. Now again, the length and angle of the J depends on the purpose of scenario. To access a large vessel that is bifurcating, go in for a wide curve, a long J more than the diameter of the main vessel. to enter a branch that is arising from a short, tight lesion, going for a 2 to 3 millimeter J with a sub-millimeter secondary curve in the same axis. If it is a steeply angulated branch, you try for a very small tip deflection, which is more acute. And if it is not possible, you may have to go for a reverse loop wiring. And this secondary curve should be the available residual lumen as well as the length of lesion. See here, there's a sharply angulated circumflex that is there, and the wire is passed into the circumflex. It is going into the atlas circumflex branch repeatedly, and which is prevented by using a microcatheter, and was taken down to the desired level, and the procedure was completed. Again, a steep angulation, you can go for a reverse loop. For a reverse loop wiring, better use a double lumen microcatheter. Or if it is not available, you can use a single lumen catheter. You can maintain the patency of the main vessel using a second wire, and a microcatheter is passed on a second wire, and that is exchanged for the pre-shaped wire. Here you can see the LED that is taking off from the right coronary sinus. A wide, smooth, progressive curve enabled a very easy wiring of the abnormal LED. Again, a smooth wide curve can be useful in traversing into a branch that has got a large bifurcating vessel. It can access a septal artery for retrograde approach or for something like a septal ablation. A 2 to 3 millimeter J ideal to course through tortuosities, preferentially access shallow angled branches, especially when the main vessel lumen is less than 2 to 2.5 millimeters. Then here, see the loop, a sharply angulated LED. The angulation was because of the plaque, and the proximal LED was directing mainly towards the diagonal. So I had to see, as I was not very much bothered about the side branch, I was using a single wire there because see, and after wiring this, I took a second wire for side branch. See, the wire collapses into the main vessel. Here a single lumen, see, because non-availability of a double lumen catheter does not preclude you from making a reverse loop. So when the branch is very acute, better use a double lumen microcatheter, introduce through side port, withdraw gently to collapse into the lumen, and alternatively, you can keep a primary wire to safeguard the donor vessel and pass the pre-shaped wire through a parallelly parked single lumen micro. Now for a CTO wire, generally is a stiff wire with a high tip load, and some are inherently pre-shaped like Gaia. Too much of angulation may compromise the ability to pierce the lesion. A straight wire may not give a direction of control as decided by the operator. Generally, a 2 to 3 millimeter J is sufficient for regular use. Here you can see an aberrant RCA from the left sinus being very easily accessed with, see, initially it is collapsing into the aortic root and is going up. But subsequently, it could be steered into the RCA without much difficulty, and the procedure was completed. Now again, a CTO wire, if the stump is abrupt and a branch is taking off from there, I usually resort to a longer curve like a 5 to 8 millimeter J, because that will be more easily directed towards the tip. 2 coaxial curves totaling to around 70 degrees or more may be required if you want to attempt a re-entry from a false track. When angulation is too much, the wire propagation may be difficult, and you have to control the wire with a microcatheter. Here again, ipsilateral retrograde PCA was, a retrograde PCA was done from the contralateral axis. It's labeled wrongly, sorry. Subintimal tracking, you can take a knuckle or a U-loop, make a small loop to ensure limited dissection, because a wider loop will cause a very large dissection, and a flap and re-entry may be difficult. Now, see, in this case, there are profuse microchannels involving the proximal LED. He had a similar anatomy for the RCA also, and here I preferred not to track with something like a field XT or anything. I just went ahead with a stiff wire. It was a Conquest Pro, and that simply went through the flaps and into distal lumen, and you got the result. A single tip deflection of almost 45 degrees did it for me. And thin, long, narrow, irregular tracks, and sometimes a J always points to intima and may facilitate dissection, especially with a polymer jacket. So a small reverse tip deflection may very easily solve the issue, and this makes the tip always lumen seeking. You can see, if you observe very carefully, you can see that the second video shows a small tip deflection that is against the axis of the primary curve, or you can call the other as a secondary curve also. And you can see how easily The fourth video shows how easily it traverses through the highly tortuous thin channel. Now, coming to the tips to become a good operator, achieve a reasonable success always. Try to avoid complications, minimize your times, that is procedure as well as fluoro times, limit your contrast usage, anticipate and prevent complications, self-assessment, you know where you stand and where and when to stop. Treat complications with confidence because complications are part of the game. And always be masters of wide bore access 7 or even 8F or even more. And write hardware, guide, long sheets, wires and all. And master using multiple wires, you must be able to use at least 3 wires at a time without difficulty. And again, master microcatheters, single lumen and double lumen. Thank you all for the patient hearing. Thank you very much.
While wiring a high takeoff LED, which we use radiological view is preferred.
See, actually, if you can get a good engagement in any view, after that, wiring depends on that guide alignment actually. If you have got the proper guide selection, then wiring is not difficult, whichever be the takeoff.
Sir,
But yes.
if you want to place
But sometimes in some situations, for example, when the OSTM is too distorted or when the OSTM is very tight and all, you may have to see. Sometimes I even float the catheter in the root itself and wire the lesion. That is a bit difficult, but it's possible. You give a shallow curve and you can even wire the vessel without hooking the OSTM at all. There's no need even to hook the OSTM at times.
Sir, in your second last case where the channel is not very clear, especially the multiple channels are there, is it advisable to take a hardware like especially?
See, thing is that for a given case, nobody can say that what one has done is the only way. See, if I am using one CTO wire and succeeding in a case, that does not mean that that wire is the only wire that is for that particular. See, that scenario that wire succeeded, many other wires would again definitely have succeeded. See, in that case, why I opted for this? Because I thought if I try with something like a whisper, see, whisper has a bad habit because it will raise flaps very easy. See, we use a proximal LED. And if it raises flaps, what is going to happen is I will close the LED and maybe in trouble. So I thought I will try to pierce that flaps and go into this lumen. It is very easy actually. It took me very easily into this lumen. And the same was tried on RC also for him. And this person was denied a PCA from all centers. And he was referred to me by my previous HOD, Krishnamuri sir, from UAE.
Thank you, Dr. Vinay Kumar. Due to lack of time,
So thank you, sir.
we are forced to go to the next talk. Thank you very much.
Thank you, sir. Thank
We'll
you.
go to the next talk.
Next we have demystifying IVUS. To talk on that, we have got our own Gary Mins of Kerala. Sir, Sajan Narayan sir. Over to you, sir.
Good afternoon to respected chairpersons, and thanks for the nice introductions. So in next 10 minutes, I'll be talking about the basics of image interpretations and measurements on intravascular ultrasound. So since any intravascular imaging involves introduction of catheters and wires inside the coronary arteries, so the procedure has to be performed under full anticoagulation. You have to give heparin to maintain an ACT of more than 250 seconds. Only guide catheters should be used because if you use a diagnostic catheter, it can create friction and can distort the images. And all the current IVUS catheter systems are workhorse wire compatible. And since the introduction of catheters can provoke spasms, the examination starts with the administration of intracoronary vasodilators. Most commonly used drug is nitroglycerin at a dose of 100 to 200 micrograms. Now, there should be specific IVUS timelines during your PCI procedures at which the operator should perform the imaging. It is not enough that you perform randomly, and there should be a specific protocol, and the operator should strive to meet certain standards learned on by the recommendations to define it as an imaging optimized PCI. So the first run should be before stent, and the points assessed are the reference segments and the lesion site plaque characteristics. The questions asked are whether the lesion needs to be prepared. Sometimes you may not be able to introduce the catheter because of the tightness of the lesion. In such cases, you can predilate with a small sized balloon because predilatation can alter the lesion characteristics. And sometimes you can use arterioablative strategies like rotablation to facilitate the image catheter entry. Now, once the lesion is prepared, if the operator feels that the lesion needs aggressive preparations, it's a good practice to repeat the run after lesion preparation. And the questions asked are whether it is adequate, whether we can place the stent, and what should be the stent size and the length. And after the placement of the stent, the questions to be answered are whether the stent is optimally deployed, whether there is any edge complications, and if the answers to these questions are not satisfactory, you should take remedial measures and repeat the run as and when needed. Now, what is the reference segment? A reference segment is a vessel site which is relatively free of disease. This is the site where it encompasses the area which needs treatment, starts 5 to 10 millimeter distal and ends 5 to 10 millimeter proximal to the disease segment, and should be without major side branches, and it should not have these high risk plaque characteristics. Now I will show you how to select a reference segment. Here, this is the reference segment. Blue, I outline. The first branch that comes from the 10 o'clock position is the diagonal. And the second, this is the diagonal, and this is the septal branch. As you must have noticed, you have a disease-free segment just distal to diagonal. And the selection of proximal reference is slightly straightforward because this is from the tapering segment. So the area where the stent should land is between this green and the blue line. So that's how a reference segment is selected. Now, how to characterize a plaque? This is how a normal arterial structure looks like. You have an IVS catheter. The leading edge is the intima. Black structure is the media, and the white background is adventitious. So the demarcation between the white and the black is very sharp. And this is the area that corresponds to external elastic membrane. So we should remember that the brightest structure in a normal ultrasound is the adventitious, and the darkest structure is the media. So when you encounter a pathological image, you should ask yourself whether this is brighter than the adventitia, whether this is darker than the media, or whether it allows the ultrasound to pass through it. So if you answer these questions, you can define most of the pathological structures. I will illustrate. This is a plaque here. This appears bright, but this is not brighter than the adventitia. And you can see the structures beyond that. So that means it allows the ultrasound signals to pass through. So this is an example of a fibrous plaque. So what is the importance of fibrous plaque? Fibrous plaques are most commonly seen at aortovessel osteums, branch vessel osteums. Sometimes it can be very difficult to crack, so it may need special plaque preparation methods to allow the stent to expand. On the contrary, you can see this plaque is very dark. It is darker than the media and doesn't allow the ultrasound signals to pass through. So this is an example of a lipid-rich plaque. And the importance is that sometimes you can get away with the direct stenting in this case. On the contrary, you can see this plaque is very bright, and this appears to be brighter than the adventitia, and at one point you can't see any structure beyond that. That means this is a calcified plaque. A calcium will not allow the ultrasound signals to pass through it. It will reflect back all the ultrasound signals. So if you have found a significant degree of calcified plaque, it needs preparation. Now, another term used is an attenuated plaque. This is another variety of echolucent plaque. You can see this is a dark structure. Everything is black. You can't see any vessel wall beyond that. This is rich in lipid necrotic core. So important is that if you are very aggressive with pre-dilatation or post-dilatation after stenting, this can protrude between the stent struts and can embolize, and patient can develop no reflow. So that's the importance of attenuated. Now, in some cases of ambiguous lesion, you can diagnose rupture. This is a patient who presented with an NSTEMI. L6 and RCA were normal. Proximally lady had a 20% lesion, so we took a pullback. You can see that there is a breach in the intima, and the cavity is empty. And when you come proximally, there's a black structure sitting here. This is suggestive of thrombus. So this confirms the diagnosis that this patient is having indeed an ACS, not an myocardial infarction with normal coronaries, which is an alternative diagnosis. So you can diagnose ruptured plaque. Thrombus will appear as luminal hypodensities. You can see here luminal floating densities. And you can also judge the age of the thrombus. A fresh thrombus, platelet-rich thrombus will reflect the ultrasound. It will appear white. And as the proportion of RBCs increases, it will appear more black. So if there is a significant degree of thrombus, you have to aspirate it. Otherwise, it can produce distal embolization. So that's how the lesion characterization is done. Now, how to assess the lesion preparation. Lesion preparation is often needed in calcified lesions. You can see this patient is present with acute anterior lesion. My LAD is total occluded. Proximal LAD is heavily calcified. The pre-procedure images showed that there is a concentric calcium. So we prepared it with a non-compliant scoring balloon. And on the image on the right half of the figure, you can see there is an increase in the lumen. And there are calcium fractures at 3 and 8 o'clock position. And at the site of fracture, you can start seeing the vessel wall beyond that. So these are the signs of adequate plaque preparation. And on the contrary, you can see this patient is present with a calcified lesion. After rotablation, you can see a ripple effect. This is because of a polishing of the calcium. Rotablation will polish the calcium. A polished calcium will reflect ultrasounds repeatedly, and then it will be displayed as multiple ripples, which is also a sign of plaque preparation. So increase in luminal gain, calcium fractures, reverberations signify that plaque has been adequately prepared and is ready to receive a stent. Now, what should be the diameter and the length of the stent collected? For that, you have to assess the vessel diameter. If you draw a circle along the border between the black band and the white background, you will get the external elastic lumen vessel diameter. You have maximum diameter, minimum diameter, you have 4.08 and 4.39, so average around 4.2 millimeter. And if you draw a circle along the leading edge of the intima, you get the lumen vessel area and diameter. The average comes to around 3.35, 3.4 millimeter. Now, the plaque accumulates in the media. So you can't estimate the plaque area separately. So for that, you assess the entire vessel area, subtract lumen area from the vessel area, you get plaque plus media area, and you divide by the vessel area into 100, you will give the plaque burden. As I already mentioned, the plaque burden at the site where stent lands should be less than 40 to 50%. Here it is around 37%. So the stent diameter should be sized along the distal reference vessel diameter. If you are going by the EL to EL derived diameter, in the example which I have cited, it was around 4.2 millimeter, downsized by 0.25 to 0.5, choose a stent size which is nearest to that at around 4 millimeter. For some reason, if you are not able to see the EL because of calcification of plaque, you can go by the lumen raised measurement. In this example which I cited, it was around 3.45, upsized by 0.5, 3.95. You choose the stent diameter which is nearest to that, that is around 4 meters. So that's how stent diameter is selected. And proximal part of the stent may be approximate to the appropriate site balloon according to proximal reference segment. Now, length of the lesion is between these two reference segments. Now, once the stent is placed, the questions asked is whether stent is well expanded. There are different criteria. Simple terms, it should be more than 5.5 millimeters squared. But having said that, this may be an oversimplification. Sometimes in a large vessel, this may be inadequate, and in small vessels, it may be very difficult to achieve. For that, you can use by the average lumen area, that is sum of proximal and distal reference lumen area divided by 2. And if the MSA is less than 80%, then you call it under expansion. Now, this is an example, 52-year-old gentleman, acute anterior lesion, long segment lesion LED. We found that beyond this diagonal to beyond this day 2 is the disease segment. So you can see the distal reference lumen area 7.09 and the reference vessel diameter is 3.12 to 3.29. So average 3.2. So downsizing by 0.25 to 0.5, 2.75 millimeters, 10 may be adequate. And proximal reference was 7.7, average somewhere around 3.75. Downsizing, the proximal size should be 3.5. So we thought we'd place a 2.75 mm stent, approximate proximal to 3.5 mm balloon. Now, what should be our MSCs? 7.7 plus 7.09 divided by 2 is 7.4 millimeters squared. 80% of the average is 5.92. So our minimum stent area should be at least 5.9. So that should be the target. Now we placed a 2.75 to 34 mm diagnostic stent, part with 3.5 mm balloon. Distal part was 7.53 adequate, 9.33 adequate, but proximal was 4.9, which is not conforming to our standard. So that is under expand. So we approximate the 3.5 mm non-compliant balloon at very high pressures, and that was the final MSA achieved. So that's how you should correct the under expand. Now this is an 80-year-old lady, long segment LED disease, 2 long drug-eluting stents. When you take a pullback, stent appears to be well expanded, but here there is a gap between the stent and the vessel wall. So this is what is called malapposition. If there is a significant degree of malapposition, you should correct it. Malapposition can happen in isolation, that is stent is expanded, but it's not opposed to the vessel wall. But sometimes stent is not well expanded and there will be malapposition. For example, if you place a 2.5 stent in 4.5 vessel, stent is obviously under expanded, there is a gap. That should be corrected 100% times. But if it's isolated malapposition, if a significant degree of malapposition as defined by distance is more than 400 microns, if the axial length is more than 1 millimeter, then it should be corrected to avoid future subluminal line. Now we corrected with a small semi-compliant balloon at nominal pressures and corrected. Now another feature is the stent edge dissection and intramural hematoma. This is a straightforward case, direct stenting, but after that you can see there is a dissection flap here. So what are the features of a pathological dissection on intravascular ultrasound? If it is occupying more than 2/3 of one quadrant, if it is extending to the media, or if the axial length of dissection is more than 2 millimeter, or if it compromises lumen, this should be fixed. Otherwise, it can lead to stent complication. Now, this is a 52-year-old gentleman with a relatively straightforward lesion, 4 into 28 mm diagnostic stent, proximal part, there was a haziness. Now, this, you can see there is a media here, adventitia here. So, something has separated media from the adventitia. This is an example of an intramural hematoma. And this is the entry site. So, this has to be fixed with a 4 into 20 mm diagnostic stent. So, when you perform an intravascular imaging, these are the questions you should ask yourself. What is the distal reference segment diameter? What is the average reference segment luminal area? Whether plaque is well prepared. And once a stent is placed, you ask yourself what is the minimum stent area, whether it's adequate, whether it's conforming to standards, whether there is significant malapposition, whether there are any net problems. If you answer to all these questions are satisfactory, we achieve these results. Thank you for the patience, and I'm happy to answer any questions.
Such an excellent presentation. In fact, regarding the malapposition, do you correct all the malapposition, or the length of the malapposition which is important, or the proximal versus distal in fact in such, or is the malapposition with the under expansion should be corrected?
Malapposition with under expansion has to be corrected 100% times because under expansion is a very important predictor of stent failure. Now, isolated malapposition, if the stent is well expanded, but with the isolated malapposition, some degree of malapposition gets corrected by itself because of the ingrowth of the tissues and the thrombus and fibrin. But if there is a significant degree of malapposition, for example, for drug-eluting stents varies between 400 to 500 microns, and then it may not get corrected. But controversy is there whether it is a predictor of stent thrombus or not. But if there is a significant degree of malapposition, for example, in the proximal LAD or distal left main, if you want to intervene in that distal LAD for some reason in future, then there is a chance that wire can go behind the stent studs and into it, and then can complicate future intervention. So better to, if it's a significant degree of malapposition, like it is more than 400 microns, in endovascular ultrasound, you can go by the strut thickness. If it is more than the strut thickness of that implanted stent, then it is better to correct it to avoid future complications.
You were telling about the dissections. Overall, distal dissections create more problem compared to proximal. And OCT, we tend to see dissections more often. But any dissection which is seen in IVUS, do you think requires a tackle?
No, there are certain features that tells you that this is a pathological dissection. That is especially if the dissection is extending to the media. Then if you can see blood in the media, then that means that is a significant dissection. Or if the axial length is more, there is no consensus about what is the cutoff, optimal cutoff points. Different studies have used different cutoffs for the axial length. Generally, if it is more than 2 millimeters, the dissection is extensive. That is the definition of an extensive dissection. Then that dissection has to be. I agree that OCT will detect more dissections.
No, I agree with you, but do you think all those minor details can be made out to that extent with the usual IVUS as you make out with the OCT?
So OCT definitely will has a higher image resolution. It can detect more edge dissections than IVUS. But I think HD IVUS is almost equal to OCT in detection of dissections. But clinically relevant dissections can be detected by any imaging modality, provided you are using more than 40 megahertz IVUS.
Thank you, Surgeon. Next, I invite Dr. Harishna, yes, for teaching us the FFR basics.
Good afternoon, respected chair. Thanks to Ashish and team. We know the limitations of a coronary angiogram because it is a luminogram. If you image the artery in different angulations, you will get different levels of severity. And there is a problem of focal narrowing and diffuse narrowing. So we need something to get a correct assessment of the lesion severity, that is by using the physiology. So the physiology assess the epicardial anatomy, the extent of the perfused territory, the microvascular function or resistance, and also the collateral flow can also affect the real physiology. The anatomical severity of stenosis, which we assess by angiogram, is just only one component. So the basis of physiology, you all know that two pressures we are assessing. One is the PD and other is the PA. PD is the distal pressure which we are obtaining from the pressure wire tip. And PA is the pressure which you are obtaining from the guide catheter tip. So that is a PA. So two pressure systems, aorta, a guide catheter, manifold, table transducer, that is a fluid filled interface system. The other one is usually it is a piezoelectric system. So we start with how to prepare the pressure wire. So it comes in a plastic cage. So remove the wire from the package, keep the wire in the wire within the loop itself, flush with saline and keep it for 2 minutes so the wire is adequately wet. Then we have to do what is called a calibration. So calibration is teaching the system what is zero pressure. That is what is calibration. So we should know what is the phlebostatic axis. You know, everyone knows that it is a fourth intercostal space mid-chest, regardless of whether it is the head is elevated or not. And first you fix the aortic pressure, the PA. So open the transducer to the atmosphere. That is where the three-way opens to the atmosphere. That is the plane which has to correspond to the phlebostatic axis. And zero the hemodynamic monitor and zero the PA on the console. Next is zeroing the pressure wire. Keep the wire at the same level as the transducer and connect to the console and zero it. And once you have connected the aortic pressure, you never change the position of the aortic, that three-way stopcock. So this is just, we are just raising 2-3 centimeters at the aortic stopcock. You can see the change in the pressure. So there is a significant change which will happen once you change the pressure. So once you have fixed it, never change it. You may have, because we are assessing a lesion which is a borderline significance. 0.78 and 0.82 will make a difference. So never change the position of the stopcock. Next, you are giving nitrates 200 microgram before introducing the wire to remove any epicardial spasm. And then the next step is the equalization. Equalization is teaching the two systems to be synchronous, the aortic transducer and the pressure sensors. So the one point you should know is that the sensor is not at the tip of the wire, it is at the proximal part of the black portion of the wire. That is the point you have to understand. That is where the transducer is, and that is the one which has to be just outside the guide catheter when you equalize. So once the transducer is outside, just outside the guide catheter, you press the equalize button and the system will synchronize the two pressures and you will show the value as 1. So don't equalize the wire with the introducer in place, or there should not be any Tuhibos leak. So always make sure that Tuhibos is not leaking, because if the subtle leak can reduce the pressure by 10 millimeters, that itself can affect the values which are because we are measuring a borderline lesion. And the one important thing you should know is that flush the catheter before any measurement. So because the contrast is there in the aortic catheter, it can dampen the pressures and it can affect the measurement. So always clear of air bubbles, blood also from the gate catheter, and always flush it with saline before any measurement. And the wire should be placed distal 2 to 3 centimeter distal to the stenosis. This is to avoid what is called a pressure recovery. So it is not the wire tip, it is the transducer which has to be placed distal to the wire. So 2 to 3 centimeter distal, the proximal part of the black portion should be 2 to 3 centimeter distal to the lesion which you are measuring. And the wire position should be such a way that it should be rotating freely and no resistance is felt, because it should be preferably in a segment more than 2 millimeter, because if it gets stuck to some position, it can produce something called a whipping artifact which can affect your values. Hyperemia, nitroglycerin is to dilate the epicardial vessels 100 to 200 microgram, and adenosine is usually given for the dilating the microvasculature. Usually we give intravenous adenosine. You can give intracoronary 200 for LC and 100 for RCA. And it is preferably should be given in a central cannula, at least in a cubital vein you have to give. And cases which in heart failure, pulmonary hypertension, etc., higher dose infusion may be needed to attain a steady state. And caffeine intake can affect the adenosine metabolism, and the history of caffeine intake should be obtained. Preferably, patient should avoid caffeine within 12 to 24 hours of the FFR measurement. Ostial lesions, the equalization should be done in the aortic sinus and distal place, because we cannot place it in because the equalization is done to equalize the two pressures. And ostial lesions always it should be done in it should be done with the intravenous, because you cannot give intracoronary, because it can contribute to the stenosis, and once a partially engaged guide, because of the wedging, you may be pulling it may not deliver the adenosine adequately. Guide catheter related issues, if there's an ostial lesion, make sure that the guide catheter does not cross the lesion. It can can give erroneous values. And side holes, better to avoid side holes, because there can be a flow through the side holes into the guide, which can affect especially when there is an ostial lesion. Wedging of the guide catheter is a very important thing. You should see, this is a pressure measurement happened, and you can see that suddenly the aortic catheter goes into a wedge position, and you can see that the value changes. So it is very, very important. And if you, again, another example of a wedging, you can see that when you suspect wedging, you always look on the aortic pressure. If there is a tendency to wedge, disengage the guide and give adequate nitroglycerin to relieve the catheter-induced spasm. Better to shift to IV adenosine, and always measure disengaging the guide catheter, and especially if it is an ostial lesion. Errors in measurement, the most important thing in FFR measurement is the pullback verification. Without doing a pullback verification, your measurement is not accurate. So always once you finish the measurement, you just pull back the wire to the position where you have equalized, and it has to be 1. If it is not 1, if it is less, the difference is less than 5 millimeter, this should be accounted in the calculation of F4. I will show that when the difference is more than 5, this should be repeated. For example, the FFR obtained was 0.79, pullback is 0.96, and the difference you have to calculate, it is 0.82. If it is less than 0.95, you have to repeat the measurement. So you can see that 0.79 and become 0.82. So there is a significant change. So why we are looking at the pullback measurement? This is because of what is called the drift. Drift is a problem of piezoelectric sensors. There are different mechanisms. I am not going to those details. So what will happen is it is a problem. It is due to the moisture which is going into the system. Many mechanisms are proposed, but you should have in mind what are the clues to the signal drift. So this is called a parallel shifting. The distal pressure and the proximal pressure will looks the same, and both pressures will show the dichrotic notch also. It is said that the wire systems using microcatheter have lesser problem because it is not piezoelectric based. There are patient related factors, for example, scar tissue. For example, I will give you an example. For example, this patient had an FFR value of 0.6. Patient was waiting for a procedure, developed an MI and lost some significant amount of myocardium. Now we can see that the value has become 0.8. So this FFR always equalizes for the perfusion area. That is why you don't get a positive FFR in a small side branch when you do an FFR, for example, after crossing sending across the lesion and all. So always it is corrects for the perfusion area. LV-EDP can affect FFR, so it can impede because it can impede myocardial perfusion. LVH can also affect FFR. So another important thing is the impact of right atrial pressure. So you can see that actually the value of FFR measurement, the formula for FFR measurement includes pulmonary, coronary cardiac venous pressures also. It is actually PD minus PV divided by PA minus PV, because it is, the pressures are normal. For example, PA is 140, PD is 115, RM mean is 5, it will not make any difference. For example, it is 0.82 and 0.814. But when the RM mean is very high and there is low blood pressure, this can change. So 0.81 has become 0.76. So to make it very practical, when the CVP is high, more than 15, and the aortic mean pressure is less than 80, always include the venous pressure also in the calculation. Collaterals can affect from the donor artery can affect. It can give false positive values. So what I will show an example, and then when the collateral grade, Trendrop grade 2 and 3, it can change the value, it can be reduced by 0.1 or more. Grade 0 and 1 may not change significantly. So this is an example of an RCA being collateralized by the LAD. Before, the initial value in the LAD was 0.75. Subsequently, the RCA was revascularized. When the LAD was reassessed, you can see that the value has become 0.84. So when you have a CTO or some vessel which is supplying by the donor artery and you are assessing the donor artery, always it is better to revascularize and then reassess the distal, the donor vessel. Non-hyperemic pressure ratios, because of lack of time, I am not going to that. Resting ratios should be measured in the true state, wait 30 to 45 seconds after contrast, saline, etc. Because contrast is it produces some form of hyperemia. And otherwise, the residual hyperemic effect will be artifactually low IFR values, etc. And diastolic pressure ratios, because coronary flow can also occur in systole, especially in RCA. So the purely diastolic flow ratios can be erroneous, and you know the values, it is 0.89. So diastolic, this non-hyperemic pressure ratio is also important, and it has been shown to be equal to the FFR. There are some other details I am not going to because of the lack of time. Other lesions, like other issues like tandem lesions, left main lesions, post CABG, FFR and Lima, bifurcation, side branch are all separate topics because I am not going to those details. So, ladies and gentlemen, to conclude, FFR or non-hyperemic pressure ratio is a bare number only, and this value may determine the future course of your patient. The only guarantee of these values is that the careful training of the steps of the measurement, which is very simple, awareness of the potential pitfalls and artifacts which I have described, continuous quality control of our practice, and know your patient basically. Thank you.
Any questions or any comments? Roughly what percentage of your patients you do an FFR now?
Now I think 5%, lesser than 5 probably. The significant change in the, because of the new data which has come there is borderline lesion. I don't know. Is there any data like that? I don't there is any data. I am not aware of any data like.
Dr. Ashish, what is your point in the circ?
The SFR value generally seems to be higher compared to other
In?
as compared to the LED and the RT. We look, angiographically feel that the lesion severity is essentially the same or similar. SFR values very often are
Higher.
No,
I think that
I
is
am not aware of-
because the same point which he was telling you, the myocardial supply, the vessel may look big, but the supply may not be that much. That could be the reason.
Yeah, that may be
because
the-
when you
that
tell
may be
the
point.
LAD, even when the LAD is small, it has a huge supply. The OM may look very big, but the supply is, that could be the reason.
Yeah, that could be the reason, probably. I am not aware.
Another thing, tight looking short lesion, comparatively longer lesions. Diffuse disease has
Yeah.
more
Chance of, yeah,
positivity.
we may think that the disease may be innocuous, but actually or the functional severity may be much more. That is the problem of angiographic assessment versus FFR assessment.
Say that you want still to do the imaging.
Yeah, that is what. No, see, if you do more and more physiological assessment, the chance of leaving it for medical follow-up is higher. And imaging, no, we may interpret it as a what is vulnerable plaque, higher risk plaque, etc. So that type of interpretation is not possible with an FFR. So that is why we may end up in more of interventions while you image rather than doing an FFR assessment. I think
No,
it
I
is
think-
complementary. We should say it is complementary. Yeah, but now we have most of the machines have both two systems. No, the non-hyperemic and this thing. We can use a combination of that and see. Yeah, I think pullback measurement is the most important thing. If you have a borderline value, always pull back and see. And if it is, you make sure that it is 1. Otherwise, it is make sure that your measurement is correct first of all.
Thank you, Dr. Harikrishnan. I think we have exceeded the time. So we would like to thank everyone and all the speakers. Let them give them a big hand. I think we succeeded in finishing on time. Thank you.
Thank you to the chairpersons and all the speakers for this engaging and informative session. We would now move on to the next session, which is peripheral interventions. I would like to call the chairpersons on stage, Dr. Ashish Kumar, Dr. Ramakrishna, and Dr. Sunil.
Good afternoon. Now we will move on to next session, that is peripheral interventions. And first session is SFA intervention. We have Dr. Ashraf. Dr. Ashraf, please.
Thank you, Chairperson. I think it's only basic, and I'm not a peripheral expert. I do only less than 1% of what are all cath lab procedures for the last 18, 20 years.
Ashraf, that is simply because you do so many interventions.
No.
You still end up doing a lot of SFA interventions, I'm sure. Yes.
So all the fellows come forward and sit in front because many are back.
And also,
These are
Ashraf,
all
sorry, cardiologist point of view.
Yeah. Yes, when intervention cardiologist point of view, because who are the specialists? The peripheral intervention, the interventional cardiologist, interventional radiologist, and vascular surgeon. When I attend a meeting in Europe, one of the meeting, the person who attend is 90% are vascular surgeons, and the radiologists only 2% are cardiologists. I was actually third person, but I wrote like a radiologist because people realize and they will ask questions. So algorithm should be dynamic. You should know the angiographic anatomy and patient presentation, claudication versus critical limb ischemia, and clinical characteristic and previous attempt. Angiographic anatomy means there are a lot of, just like a vascular surgeon, you should know everything about the peripheral anatomy. And knowing that these are entry vessel, being a coronary intervention or structural or peripheral intervention, you have to know the entire anatomy of the vascular system. especially the lower limb system. And the projection details the different anatomical variations. And claudication versus critical limb ischemia. You should not put stent or angioplasty for all patients. For example, if you take the lower limb occlusions, 50% patients are asymptomatic, and rest 50%, 20% have intermediate claudication. And if the patient can able to walk more than 200, just give the medication. Don't make interventions. And clinical characteristic, you see whether the patient is having some occlusion in and around the joints. For example, popliteal artery or CFA junction. So probably it may be even embolic. So you should know about the cardiac anatomy and cardiac. And if you do anything, that there will be the result will be a suboptimal. The vascular surgeon can do the better job than us, because the size of the occlusion will determine the where to occlude. For example, aortic bifurcation probably in and around more than 13 or 12, 13, and the occlusion thrombus is 14, 50 minutes will occlude that area. So, for example, thrombus, LA thrombus, if it is 7, that will occlude the common femoral or SFA, deep femoral junction. If it is 6, it will occlude the poplite. So, the location is the occlusion is that will determine the etiology. And previous attempt and PTA with the stenting, don't again attempt the PTA, because if you take the vascular occlusion or vascular stenosis, then we have a good alternate, that is vascular surgeon. If the life survival is more than 2 to 5 years, the surgeon will have a better job than the interventional cardiologist. If survival is less than 1 year, definitely PTA is superior than any bypass graft. So this is angiographic anatomy. You have to study even coronary interventionist or peripheral interventionist, they should know the anatomy in detail, the variations, deep femoral artery, or where this one, inferior epigastric artery is originating. And for the fellows, this is very, very important one branch is the inferior epigastric artery and this superficial epigastric artery. Inferior epigastric artery in this area, if you puncture it, you can make there's a complication called RPH, retroperitoneal hematoma. Even last week, even with the micropuncture angiographically with the fluoroguided, I told my resident to do the procedure with the obese patient, because we are going for the complex angioplasty, we need 7 French 10, 7 French guide. The patient ultimately landed with, even the patient is asymptomatic, there is a drop of HB from 13 to 9. There is a asymptomatic RPH. So then we checked again. So RPH, that patient had abnormal variation, like inferior epigastric arteries coming below the inguinal ligament, below the head of the femur. Now, more than 90% cases, it is just above the femoral head. Very, very rarely it can go down and go up. So you should know the anatomical part, aortic bifurcation inflow vessels. Before making attempt to PTA, you should have a CT angio report rather than angiogram. I stopped peripheral angiogram for last 15 years, only CT angio, because afraid of radiation and other suboptimal image quality. And aortic bifurcation inflow vessels more than 70, definitely you can attempt for the crossover. Less than 70, the acute high bifurcation, you have to attempt for the antegrade approach rather than contralateral approach. So that is a 70-degree. There is no that rule, it's my personal rule only. So this patient, even though if you attempt for the contralateral, very difficult, you can see that the angle is so acute. And also there are a lot of lesion in and around, so better attempt the antegrade route even with the fluoroguided or even with the ultrasound guided. Now the antegrade CFI bifurcation 5 centimeter rule again. You know the 5 centimeter rule, that means if there is lesion in the CT angio or peripheral angio from other centers, show there is a lesion in the superior superficial femoral artery, just at only 5 centimeters, less than 5 centimeter, don't attempt the antegrade route. Better will be the retrograde route or retrograde popliteal or contralateral route. So that again one rule. You can see that there is SFA is put just below the bifurcation. So don't attempt the antegrade. You can attempt the retrograde route through the contralateral area. Now comes the antegrade puncture tips and tricks. That means you have to don't put the blindly puncture. Obese patient, you have to be very, very careful. But the ultrasound guide puncture is very difficult, because above the inguinal ligament, that area, good ultrasound the support is needed rather than our own experience. So that you had to know that the wire has to should not go that laterally and just to come down and now come the popliteal axis. If there is lesion in the CFA junction, you can even attempt the popliteal axis. Here again 5 centimeter rule. There is no rule, but we are making for the fellows to remember that 5 centimeter. If there is occlusion disease in and around the popliteal axis, you should not attempt the popliteal puncture. And one issue is here patient has to be in the prone position. Many of the case there will be lesion in the proximal part. You have to make the prone position and you may not attempt to cross the SFA junction, that is CFA junction. So then you have to make the patient supine. So it will be very, very tough practically. And now come the brachial or axillary. You should never attempt from the right side. But if there is, because when you are crossing from the right side, you are crossing the 3 arch vessels. So better will be the ipsilateral, left side brachial or axillary root. Which scenario? If angle of bifurcation is less than 70 degree with the diseased occluded iliac or femoral. So if there is lesion in the inflow vessels or the CFA area, then you can attempt the brachial, especially there is a iliac occlusion, because from above it will be easy to cross rather than contralateral. But one disadvantage, you can't use more than 6 French endols. So hardware, the length will be very difficult to reach below the popliteal segment. So selected inflow vessels or iliac vessels or common femoral disease you can attempt. So the brachial approach again, only issue, you can't use more than 7 French endols. You have to always keep the pulse, there is risk of anti-ischemia for long procedures. Now come the disease iliac and femorals. You can use even combined approach. For example, you have a external iliac disease and also femoral disease. You can't use the contralateral approach. Then only attempt, you can retrogradely, you can open the iliac vessels, you can put the stent also, then get a flow, then you can put the antegrade SFA puncture. So that is first retrograde iliac inflow vessel PT and then antegrade SFA. Other access, the pedal access, axillary, direct transcutaneous and ultrasound guided. So ultrasound guided in our WhatsApp group, there was a lot of discussion. So most of the people are using the ultrasound guided because there are hospital facilities available, radiology facility available, in-house, in-cath lab facilities also available. Primary pedal approach, make sure the pedal vessel is not only the infrapopliteal vessel, pick a straight segment to access, preferably short CTO, and avoid ISR because many of the time ISR there will be some sort of thrombus in and around. And how to proceed SFA intervention. See, when you see many of the patients, you see the calcification and you may afraid to do the angioplasty. And you may see that just like coronary angioplasty will be tough. No. In the SFA, the calcification the medial level, but in the coronary it is the intima. So the calcification process, there is a beautiful book by the British author recently published. Everything about the calcification coronary, everything peripheral. So I read all these things about how it is the calcification being formed the coronary and beautifully narrated. You can go and search in the Amazon. So the calcification, the femoral, there is no need to worry at all because it is a medial and intima not much when compared to coronary. So the how to approach the proximal cap, the favorable cap or unfavorable cap as in the coronary, thrombotic occlusions or calcification or prior CT angio report will make you guide to exact treatment. Now you have to know about the anatomical variation. It's 20 to 30% there will be some sort of anatomical variation in the deep femoral artery and also superficial artery variations rarely. Profunda usually there will be some lot of variation and profunda is LAD of thigh. It's like coronary artery, LAD is most important. Profunda femoral is very, very important for the thigh and lower limb circulation. This is the only vessel that will connect from the above to the lower, below the knee. Especially in case of, for example, patient post-CAB, there will be calcification, PVOD will be there, and there will be lima. And bilateral lima is more dangerous because if there is inflow vessels disease, they are getting collateral only from the lima route. So in that scenario, if you go with the intervention, very, very careful, and you always discuss with the vascular surgeon and the radiologist if there is any other issues related to procedure. And difficult to penetrate proximal cap like flush occlusion SFA. You should not put stent here, only balloon. The techniques are the fishing the cap, use the angled catheter, look at the contralateral CFA bifurcation angiogram. Just like right coronary artery, flush occlusion, and sizing of the stand, you had to look for the circumflex and the LC, LAD. Just like that, there's occlusion there. You look at the contralateral side, and anchor balloon in profunda, as in the coronary, and the loop technique. This is just an example 2 weeks back. This is a flush occlusion SFA. Here, only profunda you are seeing, and this we can contralateral route for the heart wire, termo heart tip, then dilatation, and this is the undergrad route of undergrad. There was thrombus shift to the profunda, make a simultaneous kissing balloon technique, and good result. So that's giving you the importance of keeping the profunda alive, and other than making the patency of the SFA. Loop technique. Now the diameter of the loop should be less than that of the diameter of the vessels, and advance by the pushing than the slicing, and push hybrid up. You can use even hybrid approach or even re-entry technique. Now come the calcified vessel, extremely calcific vessels and occlusion. You can use ultrasound, just like coronary. You can use the IVL, even peripheral IVAS, and transcut a direct puncture if there's difficulty to get the access, because calcification give you the landmark for the puncture. Now standard segment occlusion, again this give a make a clue where the stent is there in the interval, so you can make a puncture with the two orthogonal view and make an access. This is the Safari technique in SFA occlusion, like subminimal antegrade flossing with antegrade and retrograde intervention. And you can use all the coronary techniques like reverse cart, orbital atherectomy. In fact, orbital atherectomy was mainly used in US peripheral and then came to the coronary, and IVAS, IVL, collateral tracking. And you can even hybrid approach like cart. Now the last 2 slides, stent versus balloon. For the last 10 years, the stent usage only 10% of the PTA, and many of the time it is the balloon. And if you take the balloon, instead of semi-compliant balloon, use the dedicated balloon, little bit more non-compliant style, because it can make injury and dissection. And if the residual lesion is less than 30%, rather than coronary is less than 20, the peripheral will be 30%. You can accept it. If there is dissection, again you can inflate for longer time. If with the 3 minutes inflation, if there is dissection, you repeat the inflation for 5 minutes and keep it for long, and again check. And if there is no residual less than 30%, only residual and not much flow limiting dissection, you can avoid stenting. Now come the drug-eluting balloon, and nitinol stents are coming, and with less evidence of fracture. Previously, people are telling a lot of fractures because of the following movements like rotation, extension, abduction, and direct compression. All these can cause stent fracture in previous years. Now you have a beautiful nitinol helical structure. All the technology has advanced, and the fracture rate is only very, very less, only less 2 to 5%, and restenosis is only 15%. Previously, if you are using the stent more than 150, 200, invariably there will be fracture and restenosis. Now the incidence is little less, and the advantage of a stent. And conclude, SFA intervention, the success depends on anatomy, the clinical characteristic, hardware, and the primary access, that is aortoiliac bifurcation, CFA, lesion length and calcification, and distal runoff and distal vessel size. Thank you.
Thank you, Dr. Ashraf, and a beautiful presentation. And rule of fives as well as angle less than
No, there
70,
is not
more
much
than
rule,
70.
just a
Less than 70, okay. I think you have almost covered all areas for a short presentation. I think when you go antegradely to a SFA lesion, you said a 5 centimeters and you do a puncture. If you are repeatedly getting a profunda femoris, how do you tackle that?
So you can have a lot of techniques that many of the time you should not make too bigger sheath, and you can put the wire there and keep it there, and you can put a wire in the profunda, slowly withdraw and make the wire and angle into the SFA.
Dr. Ashraf, very nice talk. Suppose we have produced dissection because of wiring, because of the loop is very more, then we are then flow cutoff. How do you proceed with that? How do you tackle that case?
As if in coronary and all, you can use another hardware, and because which hardware depends for suppose you started the point 24, you can use even 032 or 038 or whatever. So change the wire technique, and suppose you are knuckle type, you can use the harder hand of the wire and you can use it.
Yeah, sometimes it happens.
Actually speaking, before that, daughter started in 1970s, and it is not much advanced, and people are little bit too much aggressive and all. Even if it have something happen, you can puncture, you can compress proximally, and you can make it safe. Not much complication when compared to coronary.
The most common reason why you often go to profunda is a lower puncture. You have to do a slightly higher puncture, and they always use a micro puncture set. Using that micro puncture set, you can do multiple attempts, and you can even check with that little die and check, and use a ipsilateral or a contralateral 30-degree view, so that the angle is where you can easily slide the wire into the main artery.
Basically, if you are obese patient, no, you just imagine people are sitting on the chair. That means the chair, your leg is your iliac artery and coming, and you are this area where you are sitting. Suppose you are sitting, the Sibu is sitting there. Your lower part is actually the iliac artery, and that our patella is at the sweet spot. In an obese patient, that spot little bit lower down. So many of the time you may puncture, as we are saying, that it is a little bit proximal to that patellar area. So you have to think on the three-dimensional view. Like obese patient, the artery is going very deeper and coming anteriorly. Many of the time you may puncture lower part of what we are actually the exact site of the puncture for the antegrade. So in that case, landmark is very, very important.
Excellent talk, Ashraf. For the sake of our junior colleagues, one of the ways is actually you abduct during a puncture, a higher puncture, and abduct your, that is externally rotate, partially flex. So it will gently go into the SFA than to the profunda. And one part of it, the re-entry, it should not be closer to the knee joint.
Yeah.
So if we are not able to re-enter, in the mid 1/3 of the thigh, it's always better to come retrograde. Otherwise, you end up dissecting to the popliteal, and then it becomes very difficult.
And that area, that is very important, because many of the time you may push, and near the knee joint, you are losing the distal runoff vessels patency. So stop there and don't destroy that, because many of the time there is a collaterals from the profunda to the popliteal area. That junction is very, very important. Okay, thank you.
If any questions from the, we'll go for the next talk, Dr. Sibi.
Thank you, Ashraf, for a wonderful talk, as always.
Below knee interventions.
Respected chairpersons, senior colleagues, and dear friends, I'm going to talk on the below knee arterial interventions because it's in leg there will be some overlap. In critical limb-threatening ischemia, the risk of limb loss is very high, if not revascularized, approximately 40% limb loss in 6 months. And peripheral arterial disease is the only independent prognostic factor for amputation. The decision to revascularization depends on Wi-Fi classification system. And W for the extent of the wound, I for complexity of the ischemia, including total occlusion, calcification, poor distal vessel visibility, FI for foot infection. And general factors also to be considered like the renal failure status of the patient, contrast-induced nephropathy, the bleeding risk, the ambulatory status of the patient, life expectancy of the patient. And for wound healing, direct inline pulsatile flow with pressure head is required to the site in the wound-related artery. So that concept is known as angiosome concept. The open artery should ideally supply the wound-involved angiosome. There are certain fallacies for the angiosome concept because not every wound is confined to the single angiosome space. And there are perforating metatarsal branches connecting dorsal and plantar vessels. And if distalmost wound-related artery is diffusely diseased, additional supply through pedal or peroneal branches are important. So if you can't open the wound-related artery, at least one tibial artery should be opened. And complete revascularization is always better than partial opening because the limb salvage rates in open BTK arteries, no vessel 56%, one vessel 73%, two vessels 80%, and if you open three vessels 83%. And most of the non-healing ulcers have chronic total occlusion of the BTK arteries, and if you totally there is no flow to the foot, it's known as desert foot. And for plantar wounds, CT or the PTA, posterior tibial artery with poor plantar arch is very important. Usually that is a problem, and you have to open the vessel, and a good arch formation is required. And this kind of wound healing can be expected. The approach to the below knee interventions, it can be either antegrade ipsilateral femoral, retrograde contralateral femoral, and rarely pedal arterial puncture. What are the advantages of antegrade approach? For CTO, better talkability with wires and pushability with the balloons in antegrade approach. And all the balloons, including coronary balloons, can go beyond the ankle joint in antegrade approach. And definitely working convenience for the operation with less radiation. And very high aortic bifurcation, like this case, is not suitable for contralateral because all the gadgets has to go across the aortic bifurcation. And the tips for antegrade puncture: in obese patients, hold the abdomen manually or by using a tape, and the puncture should be fluoroguided, target near the inferior edge of the femoral head. Use the micro puncture set. It is multiple attempts can be expected, so it's less damaging. Entry to the profunda, you use ipsilateral 30-degree view. There are three situations in which antegrade puncture is not preferred. The significant disease proximal 5 centimeter we have discussed, high femoral bifurcation, extreme obesity, and flabby abdomen. And contralateral femoral approach requires Balkan sheath support. And disadvantage, usual balloons may not reach below the ankle level. You have to take special balloons like advanced LP 170 centimeter from the Cook company. And main hardwares for the BTK interventions, the guide, balloons, and wires. Guides from the contralateral groin, the JR or MBA catheter may be preferred, while ipsilateral antegrade route, better shorter catheters like RDC to reduce the length. And the choice of wires, any wire can be used. It's a committed peripheral wire. Workhorse wire may be owned for 300 centimeter high torque command ES wire, which is hydrophilic polymer wire from Abbott, 3.5 gram, 300 centimeters. And in those with straight channels or when the islands are visible, this is more useful. It has a core to tip design, transitionless fusion. And main thing is it is king resistant, because it's a nitinol wire, while if you take fielder FC and all, it easily get kinked. Disadvantage, is less talkable, and MRP is also high, like 15,000. And most of the patients are in lower economic status group, so it may be additional hardware cost. Other CTO wires are useful like XTA, XTR, Gaia wires, or Congress Pro, which is easily available in our lab. We'll review some cases. A diabetes with a non-healing ulcer. So this patient has got an anterior tibial artery stenosis, significant stenosis proximally, and distal flow is low, and distal dorsalis pedis is not very well seen, while PTA is seen. In such cases, we can take a microcatheter and give an injection, and a small micro channel is visible. So here filter XCR is taken, and sliding technique is used in the microcatheter support. And then we can change to your regular workforce wire, balloon inflation, and finally we get a good flow with a good arch formation. And this kind of healing can be expected with a lot of granulation tissue. This is another case where the CTO of the posterior tibial artery as well as the anterior tibial artery, the distal ATA was crossed with an XTA wire that was ballooned. So the ATA is flowing up to the foot. Now there is a long segment CTO and the posterior tibial artery, and the XTA could reach in the distal one that, but not going beyond the ankle joint. So change to Gaia 2 wire. Gaia crossed the lesion, then balloon, and long peripheral balloon was used to fix, and you get a good result with arch formation. So regarding the balloons, long thin profile peripheral balloons, committed balloons, it's better to use in the peripheries with inflation pressures below the RBP and kept inflated for 2 to 3 minutes. And peripheral balloons can be reused. Better avoid reused coronary balloons, not suitable for peripheral lesions. They have a high chance of dissections. So this is another case, non-healing ulcer of the heel with a CTO, the tibio-peroneal trunk. And fielder XG and Gaia 2 failed to cross the lesion. So Congress Pro 12 wire was taken. Slowly the wire was advanced. However, the wire crossed in a subintimally and not in the true lumen. And the wire was tracked into the true lumen. The wire was advanced, changed to regular wire. And that is the final result. with a direct flow up to the foot. And most of the CTOs in the peripheral cases are very long CTOs. So very important to identify islands in long CTOs. So, and if you can reach these islands, your chances success is high. This is one such case, and started with the XTA, but it has led into, it is not going beyond a point and going to branches. So change to parallel wire technique. The second wire could be advanced, and it crossed the distal cap, and a wire was exchanged to a regular floppy wire and ballooned. And again, long peripheral balloons. We have 220 balloons are available, long balloons, and that is the final result with the flow up to the foot. And again, a case with the long CTO, and the distal filling is seen only in the below the angle level, very fine. In this case, knuckle wire technique was used. Microcatheter injection, no vessel is seen. So the proximal island was dilated. Then Gaia wire was used to go across, but Gaia is not advancing. Then a knuckle wire was made, and it could cross the lesion beyond the ankle joint, checked, and the ballooned. And finally, there is, in all the vessels are flowing, and the foot is well perfused. And this is another case where the antegrade approach failed, retrograde approach. There are two approaches for the retrograde route. One is the transcollateral approach, which is easier, or a pedal plantar loop. You can come through the one artery and go to the other artery through the loop. This is a case where the anterior tibial artery is flowing, while there is a long occlusion in the posterior tibial artery. CTO wire was used. It's not progressing across the microcatheter. Micro injection, no major channels. Congress Pro wire was taken. It has gone to one point, then it is getting bent. So this patient has a connection between the peroneal artery and the distal the posterior tibial artery. So that channel was used, and the wire was crossed retrogradely. And you can see the kissing wires as we do in the coronaries, and the ballooning was done. Then further work was done through the antegrade route. It was ballooned, and proximally and distally, and then a good result. And in certain situations, our usual coronary wires may not cross, like in this popliteal occlusion, the coronary wires getting bent, not crossing the lesion. We can take a thermoglide wire to cross the lesion, and it can be exchanged with the thermo 4 French glide catheter. Then exchange the wire, and the angioplasty was completed. And the last case, or the role of stenting in below the knee interventions, it can be done in flow limiting dissections or residual stenosis more than 30%, especially in a single surviving vessel. So this case, patient had a CTO in the anterior tibial artery. Dorsal speed is visible as a distal target. So it was crossed with again a CTO wire, then balloon, but there is a significant recoil in the vessel, although it is flowing up to the foot. So those areas were stented, and the final result is good. With that vessel is going with a very good so this kind of non-healing ulcers can be there in extremely severe cases, and very important to open the posterior tibial artery with good plantar arch. And in this case, bead therapy was used. These small beads are calcium oxalate crystals. They can be impregnated with antibiotics. So local delivery of the antibiotic is very important, because compromised flow, the IV antibiotics may not reach there properly, and these beads will slowly get absorbed. And this is the progress of the lesion, and finally the wound, such a wound got healed.
Dr. Sibi, excellent talk. And usually when in BTK lesion, whether you straight away go with coronary hardware, or in which case you go with coronary, and which case you go with dedicated peripheral hardwares?
The command wire is actually a very good wire, but most of these patients are very, very tight financial kind of thing, and coronary used wires, CTO wires are easily available in the lab. So in some cases, actually in most of the cases, I use coronary hardwares, and sometimes I prefer command wire because it is not easily getting kinked. While when you take the coronary wires in the peripheral lesions, it get kinked easily. So that is the
So
main.
you should start with coronary. Usually start with coronary.
Yeah, I start with coronary wires, and SFA lesion I start with the thermoglide wire.
But in coronary, we can't use the long balloons and all. For that, you have to go for command.
Yeah, most of the cases I prefer antigrade approach. That is the importance of the antigrade approach. Any balloon can be taken in the antigrade approach. Only when you come retrogradely, then you have a balloon called advanced LP balloon from the Cook, which can even go retrogradely up to the ankle joint.
And what is your experience with the drug-coated balloon in BTK lesions?
I have used only in one case drug-coated balloon.
Thank you.
Again, costly.
Superb cases you have seen, so many cases. If you have got a diffuse disease in both anterior tibial, posterior tibial, especially the distal vessels, you can also still approach with the long balloon dilatations.
Yeah, long balloon dilatation, the main advantage, because in early part of my career, I tend to use coronary balloons because it was easily available, and most of them get dissections. And again, the surgeon will call back and tell that although you have done angioplasty, there is no flow because of big dissections. And after using long peripheral balloons, the results are very excellent results.
Thank you.
Excellent talk, Sibi. One word of caution for the junior colleagues would be the Gaia in a calcific vessel, it just tends to get stuck and unwinds itself. So before you realize, it just keeps coming at the groin. That is one of the disadvantages I've always felt with the Gaia in highly calcific lesions.
In very heavy calcification.
Heavily calcific lesions.
While in very soft calcification, it actually slides across the lesion.
The XTA wires I use quite a bit because it slides and knuckling, everything it helps. And for very hard occlusions, there are two wires from Cook, 18 gram and 28 grams. Approach CTO wires. They are very, very stiff wires. Far more stiff than any other coronary wire available, 18 grams and 28 grams. But you can use it only in the AT and the PT, it goes straight. Any questions from the audience? And the take home for our junior colleagues would be always use a micropuncture in any peripheral intervention because it's an extensive disease and the micropuncture needle is a finer needle. It has a far shorter bevel. So the problem of using a standard needle is you would get a jet, you could be partly on the wall and you could dissect because there could be plaques everywhere unless you are using ultrasound guidance routinely, in which case you can actually avoid a plaque and then puncture. Am I right?
Yes.
So shall we close the session? Thank you, Ashraf. Thank you, Sibi, for those wonderful talks, and we'll close the session.
Speakers. We'll now have a short break, coffee break for about 10 minutes, following which we have a very interesting session on structural interventions. So I request everybody to reassemble here in 10 minutes. Thank you. Coffee will be served in the adjacent hall on the right side. We're now ready to start our next session, which is on structural interventions. I would like to invite the chairpersons on stage, Dr. Bijulal, Dr. Harikrishnan, and Dr. Praveen GK. I invite the chairpersons onto the stage, Dr. Bijulal, Dr. Harikrishnan, and Dr. Praveen GK.
Good afternoon. Welcome back. So we'll go to the structural intervention session. The first talk will be on AST device closure, echo assessment and procedural tips by Dr. Krishnamurthy. Over to you, sir.
Thank you, chairpersons. ASD is now being closed in almost all the laboratories. So closing an ASD is not technically very difficult, but it is the pre-procedural assessment and the post-procedural follow-up that is more important. Patient selection should be very careful because more than 80% of the patients are children. Unlike our coronary PCI, These patients are not very symptomatic, they are not sick, they are running around, and we should be careful in putting device in these patients. They should not have problems. Sizing of the defect and the device should be optimum, should not be mismatch. And the technique, the procedure should be carefully chosen so that patient derives the optimum benefit. There should be no complications or surprises during the procedure. And if we do detect problems, we should be able to minimize the risk, and we should be even able to innovate our methods to mitigate these problems. Imaging is very important in ASD device, in any structural heart interventions. So unlike our coronary PCI, we have instances where these ASD have been closed without the operator seeing the echo himself or herself. We have seen that. It should not be done, because even in coronary, we don't put the patient on the table before seeing the angio. The nature of the stenosis, the length, all these things we assess, then only put the patient on the angio. We decide the stent, everything. Then only. Here also the ASD should be assessed if TTE, if not by TE, and then only we should take the patient for procedure. And which type of imaging, whether it's TTE or TE, depends on various factors like the institutional protocol, the age of the patient. Smaller the children, TTE is sufficient. Morphology is with large defects, multiple defects, we need more of an TEE. Preference of the patient. Patient says sometimes I don't want anesthesia, then you go and go for TTE. And preference of the intervention, how he has been trained. Most of our PGs have been trained for TEE guided procedure. And the availability anesthesiologist, if he is available, GA, and then of course we can do TE guided procedure. Echocardiograph assessment will assess the size of the defect, which is the maximum size available to close, and the space available, which is the space available should be considered as the minimum available space. The size of the defect should be measured in various dimensions, not one dimension. We have to look for the presence of the ASD, the type of it, whether it is sinus venosus or secondum type, whether it is large shunt or small shunt, and what are the associated conditions and how we should go about it. We should confirm there is RV volume overload, because that is the indication for closure. Symptoms are not an indication. PA pressure should be assessed. And QPQS, clinically, ECG and X-ray, and then echo also can be used to assess the QPQS. And then the all important rims. This is a classical picture showing the various rims. The superior, anterior-superior rim, anterior-inferior rim, or the mitral rim. This is the posterior-inferior IVC rim, and which is contiguous here with the posterior rim. So all around the rim should be assessed. A definition of the rims means 2 to 7 is, above 7 is definitely sufficient, less than 7 or sometimes less than 5 is considered deficient. We should be careful in such cases. And deficiency of the superior anterior rim, that is, this part is not an absolute contraindication, but there is controversy whether it produces erosion. This is a patient in subcostal view showing a very good superior rim and an inferior rim. And this is the 4-chamber view. This is the inferior rim, and this is the superior rim. The apical 4-chamber view, we have to assess for AV wall regurgitation, both the tricuspid and the mitral, the size of the ASD, the septal dimension, and posteriorly we should dip in the 4-chamber view to see the posterior rim, the coronary sinus and the IVC part, and anteriorly we should tilt to see the SVC rim and the pulmonary venous rim. The parasternal view, we should look for the aortic rim in the short axis. I'll show the picture. A right parasternal view sometimes can give a good picture as a TE can give, especially in small children. This is a 4-chamber view showing the ASD here, And this is a short axis view, a tilted short axis view showing the aortic rim. And this patient has a poor IVC rim in the subcostal view. TEE can be used when it is available. We start with the horizontal view and then go to the vertical view. These are the various degrees where we assess the ASD. And AV wall regurgitation and pulmonary vein, if not identified on TTE, they should also be assessed. In the 0 degree, the high view, we see the superior part of the ASD, superior part of the atrial septum, and the aorta is seen here. When we come down to the mid-esophageal region, we see the mid-esophageal, this ASD size here. When we go down, we see the lower part of the septum. This is the various views, various cuts through which the superior, mid and lower part of the septum are imaged. In the bicaval view, we see the IVC rim and the SVC rim. This again same. This is a patient who has poor rims in the IVC area as well as in the SVC area. This is a difficult ASD to close by device. In this patient, IVC rim is totally absent. This is an SVC rim, which is adequate. And this is a poor and aortic rim. And this is a patient who has a good aortic rim in the mid-esophageal region, in the TE. And there is a special view to see IVC rim, because IVC rim, if it is absent on TEE, in the initial interrogation, we should not abandon, and we should actually tilt the more posteriorly so that the angle of intonation is larger. And in such cases, we can see a better IVC rim. In which actually it is short, but we can see a good IVC rim patients where the IVC rim actually supposed to be absent. A 3D is a luxury. If it is available, we can use it. In fact, 3D often gives a device size which is smaller than a TEE guided measurement. This is a patient who has a good mitral or the anterior inferior rim. This is the SVC rim, pulmonary venous rim. This is the IVC rim and this is the SVC rim in the 90-degree view. PAPVC should be identified in TTE. Very often it is possible. This SVC, towards the left of the SVC, we should see the right upper pulmonary vein draining into the LA. In this patient, it is not seen. In such cases, we should look at the suprasternal view. An ascending vertical vein may be seen. And of course, PAPVC can be identified on TEE. Here, the right upper pulmonary vein is coming to the upper part of the SVCRI junction. Here also it is seen. Associate conditions very often present are pulmonary stenosis, usually the valvular variety, sometimes VSD and PDA. Specific issues to assess during TE, during echocardiography assessment, or the size of the defect is very large. Should be careful. There are special techniques to close them. If there are multiple defects, then also we should be careful. This is a TT and this is the corresponding TEG. We can do a 3D also, which shows a porous or a cribriform type of device. Various devices are available for this. A malaligned septum. This is a very special situation where the septum goes posterior and goes to attach to the pulmonary artery rather than to the aorta. This requires more careful placement and some other special techniques to close. So these have to be identified. These are not easy to close. A floppy septum is also not easy to close. A word of caution about the eustachian valve. In this patient, we can see this is the the interatrial septum, which comes and connects to the inferior part of the septum here, whereas this is which is placed anterior. This is anterior structure which is sturdy and thicker. This also goes near and is actually attaching here, but this is the eustachian valve. This eustachian valve should not be mistaken for a posterior part of the rim. If a device is placed here, it is a catastrophe. You can see here, a device is placed here. The anterior part, this eustachian valve is actually outside, whereas the posterior part, that is the actual interatrial septum, gets caught between the two discs. A coronary artery should be assessed by TTE. If not possible by TTE, a TEE should be done to assess the coronary, because there have been instances of acute MI in children after placement of a device because a retroaortic circumflex that arises from the RC and goes posteriorly can be affected. This is an example in the TE, a retroaortic, and this patient in the angiogram shows the circ arising from the RCA and going towards the left side. This has to be confirmed. So all patients, just like a tetralogy, coronary interrogation is very important in ASD also. And now, the skills to be required are, of course, the hardware, and we should be ready to embolize, retrieval of the embolized device. We should have the necessary hardware also. A device used should be less than 1.5 times the body weight. And we should have any contraindication should be checked. Aspirin clopidogrel should be started. Retrieval material should be kept ready. A standby surgeon is required. And we put a catheter sheath, the appropriate size sheath to the femoral artery. Balloon sizing is required only if there is a floppy septum or multiple defects. Normally, regular ASD closure does not require. We should prevent air embolism by proper hydration and using a smaller sheath, removing the dilator slowly, underwater de-airing, and we should not, ideally we should schedule these patients early in the day so that later in the day if you do all the patient of complete all the cases and this patient is stable, so we do it as a last case, they will be dehydrated and air embolism possible. This is a normal LA deployment. Sometimes it can prolapse. In such cases, we require these are the various solutions to prevent or manage a prolapse. An REPV technique, when there is prolapse, an LUPV or the so-called rugby football technique, a balloon support, anything kept across the ASD, whether a catheter, a guide wire or a sheath or a dilator, if it is kept across the defect at the time of prolapse, it will prevent the prolapse of the RA disc, the LA disc will align and then the RA disc will align. So that we can prevent prolapse. This is an example of a balloon support. A balloon is kept through the contralateral femoral vein. You may have to use both balloon and dilator support sometimes. This is a dilator support. The same principle applied for dilator support, keep something across the ASD. So innovations can save on cost. These are special sheaths, Hausdorff sheath or Mullin sheath itself can be cut and modified so that it comes at another angle towards the atrial septum. The rhythm should be watched. And this is an important fluoroscopic alignment. This disc will be in profile in a patient properly devised in a LAO cranial view. If these two discs are aligned or seen en face, not en face, in profile in the AP view, this device has prolapsed. This should not be accepted. We should watch for other neighboring structures, whether there is any AR, MR. We should see for residual access and then unscrew. More importantly, if the patient has been under GA, we should avoid cough when you extubate, because we have had patients very well deployed device, intubated and then extubated, at that time cough, the device has embolized. So careful extubation should be done. Echo before shifting can often prevent problems in the ICU. And we should not, when we unscrew before unscrewing, we have to sometimes manipulate the cables. So when we manipulate the cable, it is important not to handle the cable. We should only do it at the sheath. The cable should not be manipulated because it can unscrew the device. The cable can unscrew the device and this can happen. If there is a TE, we can identify if there is a thrombus. And pulmonary edema is possible, especially in patients who are elderly and who are some other left heart disease like hypertension, coronary artery disease. In such patients, diuretics can reduce the preload. Inodrops may require. And this is a post-procedure follow-up. Embolization, if present, we should be ready to tackle. And these are the reasons or the risk factors for embolization. These should be kept in mind. Thank you for the organizers and for the listening.
Thank you, Dr. Krishnamurthy, for that wonderful presentation. Sir has the maximum experience of cases without fluoroscopy. He has done more than 500 cases without fluoroscopy, and it was selected for the CSI innovation. Sir, for the fellows, so which out of the rims, which rim you think is the most important in the sense that if you find that rim insufficient?
If you have to compromise on any rim, you can compromise on the aortic or the anterior superior rim. We should not compromise on the mitral rim at any cost. Even the IVC rim, sometimes we can compromise. The posterior rim extends superiorly if it is adequate. Sometimes it will be so-called recruitment. When the device goes posteriorly, the superior part of the rim can come down. It can get recruited. This is what is called. Whereas a mitral rim should never be compromised because it can produce mitral valve problems or even heart blocks.
And regarding the sizing, is there a difference in sizing? So if you identified some 20 millimeter device in a transthoracic and a transesophageal, is there any difference in selecting the device?
Transesophageal is usually more precise to give the size. If the transthoracic is usually take 2 to 4 millimeter, if transesophageal is done, we can compromise, come down a little 1 or 2 millimeter, come down so that a smaller device is possible.
You are doing a 3D. 3D has different dimensions. So which one will you choose? The 3D.
It depends on whether it is very oval. When it is a very oval, we can even average it. If it is more circular, a larger rim, larger diameter should be accepted.
So how much do you generally oversize? How much will you generally oversize? 4 millimeter or 6 millimeter?
It also depends on the size of the patient. If it's a very small child, we should be more careful because not more than 2 to 3 millimeter oversizing is accepted in a child, because in a child it produces more problems. The smaller the child, the higher the incidence of problem. In an adult, we can be more liberal. We can even go up to 4, even sometimes 6 millimeter oversizing if the patient, if the defect is malaligned, or if it is floppy rim, we can even go up to 6 millimeter if it is an adult.
Suppose the patient has deficient rims, will you oversize more? Or?
No, it's not required. It all depends on the size of the patient. If the very deficient rim and without oversizing you are not able to place, then this is not an indication to close by device. As I said, balloon sizing can sometimes be used to, if they're very floppy, extremely floppy, so that it will push the floppy rims and then make it a bigger, and that measurement can be taken. Similar. It's a different ball game, sir. Sinus venosus can now be closed, but it's a technique is more, we have not done it. A covered stent can be used to close it so that the pulmonary vein is directed to LA and the defect is closed. It is possible to close nowadays. A special covered stent has now been developed by Dr. Joseph Icck.
Yeah, thank you, sir. Because of the lack of
balloon sized, actually the
can
rim has tone.
Yes.
So I think it has to be there's a caution that you should not, you should be careful.
The earliest appearance of a waist should be, we should not dilate it.
Thank you, sir. We'll move to the next one.
So the next talk is by Dr. Arun Gobi. He'll be talking on the transeptal puncture techniques. Over to you, Arun.
Respected Chair, friends, a warm good evening. At the outset, I thank Ashish sir and Abhilash for the opportunity. And transeptal puncture is a skill which every budding structural interventionist should acquire. And although we are discussing about this now, this was actually discovered way back in 1956 by Dr. Rose and Braunwald and Morrow, where they used it for hemodynamic left heart catheterization. But in fact, the hardware refinement by Brockenbrough and Mullin actually made this procedure really safe. Initially, although used for hemodynamic assessment, but now you can see why this topic has come over here is because of the evolving indications of transeptal catheterization. From the need for PTMC to all left atrial ablations, LV ablations, all for all left-sided EP procedures, left atrial appendage closures, LV assist devices, paravalvular leak closures, mitral clip, mitral valve in valve, transcatheter mitral valve replacement. So the indications of transeptal puncture are evolving, and that is why this topic comes over here. There's only one absolute contraindication, that's LA cavity or septal thrombus or tumor. Rest all the lists that was earlier told to us are no longer contraindications with the advent of image-guided transeptal puncture in the hand of experts. For beginners, three important aspects which you need to know is the hardwares, the anatomy, and how you can use imaging to your best advantage. This is the most important hardware that is commonly used. This is the broken bow needle. It's an 18 gauge hollow tube with a 21 gauge needle at its tip. And this is the typical Mullen sheath with a 270-degree curve. 59 centimeter is the sheath length, 67 centimeters is the dilator length, and 71 is the BRK length. So BRK is available in typically two curves. The typical BRK has a 19-degree angle, which is typically used for the bulge septum that we see in mitral stenosis. You can curve it according to the anatomy. BRK1 is typically an accentuated curve. This is the BRK1, which has a 53-degree curve, which is ideal for larger right atriums and flat septum. A 98 centimeter BRK is also available if you're using Agilis sheath for transeptal. So typically these are 8 front sheaths and they go over a 032 wire. They don't go over 38, 032 wire. So this is the assembly. Before every transeptal puncture, you should assemble the sheath and the needle and see how they align together, at what length the needle reaches the tip and how much of the needle protrudes out. And this is the clock that we talk about, the 12 o'clock being the head end of the patient, and this is the clock that we talk about. And you need to align this outside the body and then see what is the length that is required. You have hardwares from the Schwartz septal sheets. You have Abbott transeptal kit available. You have the Baylis transeptal kit, Boston transeptal kit, many other hardwares which are available. After you understand the hardwares, learn the anatomy well. The typical site for transeptal puncture is the fossa ovalis, which is a true intraoral portion of the septum, the safest site for a transeptal puncture. It's located posteriorly at the junction between the middle and lower third of the intraoral septum. The thinnest part of the intraoral septum, in fact, has an area of 1.5 to 2.4 centimeters square. It's bounded posteriorly by a fold of pericardium between the LA and RA, superiorly by the SVC, anterosuperiorly by the non-coronary cusp, anteriorly by the septal tricuspid annulus, antero-inferiorly by the coronary sinus, and inferiorly by the IVC. Based on the indication, your site of puncture changes. If you're typically doing a mitral clip or paravalvular leak closure, you tend to puncture it postero-superior, higher for a medial leak, lower for a lateral leak. PTMC typically go mid-posterior. For LV assist devices, go mid-fossa. LA appendage closures go postero-inferior. And pulmonary veins, if you're trying to target, go antero-inferior. Typically, you go farther from the site which you want to target so that you have maximum working area in the left atrium. You have to understand the anatomy well. You have to understand where the fossa is on your RAO view and your LAO fluoroscopic projection well. And it's all basically fluoroscopic driven for the beginners. And the most important structure which you want to avoid is to hit the aorta. So always understand how your fossa is related to the aorta. In your RAO view, this is the RAO projection. This is the AP projection. Understand where the fossa is, where the aortic cusp is, the lower aortic cusp is. And this is the lateral view where the aorta is and the fossa ovalis is. Now, first step again is to have a right femoral venous axis and 8 front sheath taken in. Before that, just have a look at the echo, whether you have a PFO. 25% of the time, you might be able to probe the PFO and get across. Also look for intraoral septal aneurysm and things which might give you a surprise when you're trying to puncture. The second step is to have a 3-2 wire, O3-2 wire in the left innominate vein. Over the O3-2 wire, take in the Mullen sheath. And then take the needle in. Again, before that, again check the needle sheath assembly. Once the needle is fully abutted the dilator, at least 3 to 5 mm should be protruding out. While you're taking the needle, it's a good practice to flush with saline so that you can smoothly track the needle inside the sheath. And this typically in a normal sized atrium, you would keep the angle between 4 o'clock to 5 o'clock because this is the anatomical correlation. This is the typical angle that we keep for normal sized left atriums. And as the atrium becomes larger, the septum starts bulging and fossa ovalis starts shifting inferiorly and posteriorly. And so you might go from 5 o'clock, 6 o'clock, even up to 7 or 8 o'clock in large atriums. Typically, on the other hand, if you have a smaller atrium, you might actually shift angles. You might shift it more anteriorly between 3 o'clock to 4 o'clock. Typically, this is the way you take the needle in. You should at least have 2 finger breadth till which you stop taking the needle in. Fix your right index finger as a safety hub so that the needle doesn't protrude out. Attach a 5cc syringe with a contrast attached to it. Keep your pigtail in the non-coronary cusp, which is the lowermost cusp, as a marker of the aorta. And in the LAO or AP view, start descending down. So this is the fluoroscopy of the descent and the AP projection. So the first jump would be from the SVC to RA, and the second jump would be on the fossa. Again, you will actually see flattening of the pressure curves, and you might see atrial ectopics as you start descending down. The typical site of puncture is earlier described. Actually, you have to, from the non-coronary cusp, draw a straight line to the posterior most border of the atrium, whichever is the inner atrium. If you fluoroscopically find that, and on this line, midway through, draw a vertical line. So this forms the V line. And with this V line, you have to intersect the M line. M line is actually from the LV angiogram on the RAO view. So this M line intersecting with the V line, that's a site of TSP. So if you are not drawing the M line, even if you get this V line, at least half vertebra below or half to one vertebra below on this V line from this straight horizontal line of the aortic level would be the site of puncture. It should never be more than 1/3 the distance from the pigtail to the diaphragm level. That's your vertical limit of descent. So this is your RAO projection. This is the fluoroscopic anatomy, and this is the anatomical specimen where the fossa ovalis is. In the RAO, always ensure that your needle is away from the aorta and the CS. This is the the anatomical specimen and the fluoroscopic projection, where what is the relationship between your aorta and the fossa ovalis. Whatever said and done, always, and when you're changing position, check LAO and RAO. On LAO, the whole system should be perpendicular to the septum as seen here. And on RAO, it should be just en-face. The system should be en-face on the fossa, on the septum for the right side to puncture. And this is the lateral projection, which again correlates the aortic catheter and the site of puncture. In the lateral, always ensure that your needle tip is away from the aorta and your infraposterior third. On this part, your infraposterior 1/3 of the intraatrial septum. On the posterior 1/3 of the intraatrial septum. You can also inject and stain the septum. If you find a horizontal stain, it's optimal. Vertical stain means you are dissecting out. If you see aortic cusp stain, you need to abandon the procedure. Once you have found that your position anatomically looks good, just press the sheath in well. You might feel a septal bounce or the cardiac pulsations, and then release your stop finger and then give puncture at one go. Now, how do you understand whether you're punctured or not? You can find the flat from the RA. When you abut the septum, you will have flattening of the waves, and then suddenly you start seeing LA pressure tracing. If you are in doubt, aspirate, you will find bright red blood coming. And then if you find that, you can just inject contrast and confirm that you are in the LA. And always remember that the left bronchus forms the roof of the left atrium. That's an anatomical mark to how much you can take into the left atrium. The moment you puncture, always remember to counterclock the system so that you are not going and hitting the posterior wall. So this is you're puncturing the septum. And once you puncture, you can see, you can just give a small puff of contrast to see the LA roof. And then once you have the LA roof, you can just track a bit of sheath and then take the LA wire and then subsequently carry on with your intervention. For electrophysiologists, we don't need the arterial axis. We have a His catheter which marks the superiormost part of the intraatrial septum, which correlates with the non-coronary cusp, and so you don't need an arterial axis. The CS actually forms the inferiormost part of the intraatrial septum, and the typical site of puncture is about 15 millimeters in superior posterior on the RAO view and superior in the LAO view. Now, the newer generation don't even put the His catheter. With a single CS catheter alone, you can puncture. Take the 3 o'clock of the CS catheter as your site of vertical descent, then go on the RAO view with the 3 o'clock angle of the CS catheter and the posteriormost border of the atrium. Just go midway between that and puncture. So one catheter alone is sufficient for puncture. One venous sheath is alone sufficient for puncture. Now this is the EP transeptal puncture. This is actually a hybrid with both intracardiac echo as well as the anatomical reference from the His catheter and the CS catheter. So going across, puncturing and getting into the left atrium. Now if you don't want to press fluoro on, you can go echocardiography guided. Most of the structural interventions go TE guided. Two views essential is bicaval view, which gives you a supra-inferior idea, which you go from. So on the bicaval view, as you come down from the SBC to IVC, you understand a supra-inferior descent, and then go on the short axis. You can have an antro-posterior direction. So aorta is anterior and the other border is posterior. So the way you do is you start descending down in the bicaval view. You can see down, you start descending on the bicaval view. As you come down, when you see tenting, go on your short axis view. Ensure that you are away from the aorta. That's the most important step. On your short axis, ensure you are away from the aorta. So they have gone on the short axis view. They are away from the aorta. Go on the 4-chamber view. look at the height of puncture from the mitral annulus. At least for mitral canal, you need at least a 4 centimeter above height for the puncture, and then always puncture in the short axis view. If you use a 3D TE, so this is the fossa ovalis, this is the Mullen sheath. You can see the Mullen sheath descending down. This is the fossa where you want to target. And then here you go across the fossa ovalis with a 3D TE. Everything looks quite good. Now, intracardiac echo, this is the most common imaging that we use. Everything, you don't even need to press the fluoro. This is the O32 wire on the SVC. So over the O32 wire, you track the sheath. So, and then you descend down the needle. You can see the bulging on the septum. And once you see that, you can just need to puncture. So you can see the SVC. This is the thinnest part of the septum. Fossa, thinner part is very well seen. You can see the tenting, and then you go across. You don't need fluoro. Any difficult anatomy, you can use ice to puncture. There's no need for general anesthesia as like a TE-guided puncture. Only one venous access is required, and you can continuously monitor for pericardial effusion while the whole procedure is done. I'll just troubleshoot. And if you find an interrupted IVC or IVC filter in, you can always puncture through the hepatic axis or through the jugular axis. If you're doing a left femoral axis, you need to position the patient like this and need to give the needle a 40-degree curve. You can also do it from the transjugular axis. You just have to have a levo phase, get the roadmap in, RO view, just go 2 centimeter from the LA roof and then puncture. If you're finding that the septum is very floppy or you're not able to puncture the needle, you can use a bovine cautery. A 40-watt cut with a conventional broken bow needle itself will go through, or you can use a stiff end of a PTCA wire and puncture through, or you have a safe sept wire where the moment you puncture, it becomes a J and you can take it forward. Then future is going to be about RF needles. You can see the mechanical puncture, how much force is involved in there. The moment you puncture, it's a jump inside the left atrium. With the RF needle, there's no jump at all. The advantage is you can puncture any aneurysmal intraatrial septum, any fibrotic intraatrial septum can be punctured. When you say you want postero-inferior, antero-inferior, precisely you can puncture the site and there's least chance of perforation. And the best thing for the futuristic is the VersaCross system. This is the latest one where everything is integrated into one system. You have the starter wire, which is almost like the jalebi wire, and then you take the wire, take it to the SVC, take the sheath in, descend down, reach the septum, and then apply a RF current here. You puncture with the starter wire itself, and then over the starter wire, you actually track the sheath in. So there's no exchanges at all. One single system. So all the number of steps have been reduced to just 5 steps, and the whole workflow is actually reduced actually. And the future is to be about echo navigator, where you have the echo integrated. This is actually an echo integration with the fluoro, where you can see actually on the fluoroscopic screen itself the echocardiographic images, and you can clearly see where the fossa is and then puncture, and it's all very straightforward. The final thing is about complications. The major complications you're worried about is perforations, air embolism, persistent septal defects. Although too much have been hyped about this, the incidence of complications is just 0.8% and very less when you use TE or ICE-guided procedures. The complications are mostly due to a misdirected needle, or you're dealing with a complex anatomy. Stitch effect is one thing which happens typically in large left atrium, where you actually go from the RA to the pericardium and then from there to the left atrium. Typically, whenever you're punctured, ensure if you just put a needle, you can always get away. If you're through a BMV, just complete off the BMV, because decompressing the LA reduces the bleeding. Always, if you have a pericardial effusion, drain it, do auto transfusion, get the surgeon in and reverse the heparin. Aortic staining, you need to abandon the procedure and observe for effusion. There are heroics where people have punctured the punctured into the aorta and closed it with a device and come out. People have closed the stitch phenomenon with a device. They have closed the stitch with a glue. There are many things which are reported. Thromboembolism is a very preventable thing. You need to administer heparin prior to the transeptal, at least 2000 heparin and 200 unit per kg to be administered to ensure that at least the ACT is more than 300. Air embolism again manifests as coronary ischemia or stroke. Meticulous de-airing is essential, and saline infusion prior to procedure to increase the LA pressure tremendously reduces this. Atrial septal defects again typically is directly correlated size of sheath that you're using. And finally, to conclude, if you want to really do a safe transeptal puncture, only 3 things you need to go home and revise. Go very well and familiarize understand the hardware. Whichever system you're going to use, understand the hardware very well. Align the septum, align the sheath, needle, everything outside. Understand your hardware well. Go again through the anatomy. Revisit the fluoro images. Understand the anatomical fluoro correlation, and then always watch out for complications. Thank you.
Thank you, Arun, for that wonderful presentation. So, in a larger left atrium like mitral stenosis and a normal left atrium in an EP, so what are the modifications, or what are the for the fellows? Can you?
Yes, so basically, as the atrium becomes larger, you will actually need to go more and more caudal down. You will actually the fossa shifts down, And so you will be puncturing more lower down for a mitral stenosis, a larger left atrium. Typically, and you will also need to clock it more and more into 5 o'clock, 6 o'clock position. But typically, for the normal atriums, you will keep it at 3 o'clock, 4 o'clock. You won't, you will typically fall into the fossa the moment you are descending. And it's a very straightforward puncture in a normal atrium. Issue with the normal atrium is your margin is less. So you can't apply, your chance of hitting the posterior wall is high. So you need not apply too much of force. The moment you get into the left atrium, always counterclock, get to the anterior part and ensure that you're not hitting the posterior part and going through and through.
In dextrocardia, you have to
Dextrocardia, again, it's the same thing. You just like to do a PCA, you just reverse the options. The cath lab technician itself will reverse it to you, and then you can do it straight away.
Yeah, only thing is that 5 to 6 o'clock, 5 to 4 to 5, it will be 6 to 7. That is only thing.
Yes. And one thing is, if you want to just read transeptal puncture, the best chapter is actually on Hariharshan sir's book on how to do transeptal puncture. That's the best thing that I've read on transeptal puncture. I think it's very good for fellows. The chapter on transeptal puncture in your book is very good, actually.
Hari, I don't know, is the...
Yeah, so that's a good question. So people have done this. Earlier it was considered a contraindication. Now with the RF needle, you can do that. You can actually find the site. You can just ablate it through and get across. If you don't have an RF needle, our cautery can do that.
No, we have done 3 cases with already ASD device, surgical closure. We have done, gone through that and dilated and did BM in 3 cases. Pericardial patch. Yeah, you also.
You can use cautery, cut, go across, or even hardened of PTCA wire, go across, and then dilate it subsequently. So the device is a marker. That's a device's safest marker. You just avoid the device and puncture it away from the device.
Post device, I don't know whether somebody has done. I don't know.
Typically, we go below it, sir. We have done actually, but with ice, it is very easy. If you're using ice or TE guidance, it becomes very easy. You just stay away from the device and then puncture.
Okay.
Regarding the new catheter, new device to puncture the septum, is it available?
VersaCross is available. Boston has acquired the system, and VersaCross is available. Only thing is they have not decided on the cost actually. VersaCross is going to be available. It's going to be very easy because the jalebi wire itself comes as a starter wire. So you take that wire up the SVC, track the sheath in, and then you pull the wire into the sheath itself, descend it down, and then the moment you reach the fossa, the RF current gets delivered through the starter wire, and the starter wire gets into the LA. Again, it becomes a J-shaped wire. That's just like the safe sept, and then that can be tracked in. So the workflow is very easy. Moreover, now for cryo or for the LA appendage closure, they have integrated the VersaCross system into the sheath. Like for Watchman, there's a sheath. So the VersaCross system is integrated in the Watchman sheath. So the moment the VersaCross goes across, the Watchman sheath is tracked across. So they're just reducing the number of steps.
So I think it will be costly. Only thing is that broken burrow needle can be used 100 times or more. So that is, yeah. So thank you, Arun, for that wonderful presentation. We'll go to the next. So next is on left bundle pacing for the non-EP interventionalist by Dr. Nadarajan.
Respected chairpersons, seniors, colleagues and friends. The topic assigned is left bundle area pacing for the non-EP interventionalist. Whether an electrophysiologist does this procedure or a non-EP interventional does this procedure, for that matter, any procedure, it has to be done precisely and perfectly well. And in a procedure like this, precision is very important. So we will go through the following points. Physiological pacing, what is it? Why should we do physiological pacing? When should it be done and how it should be done? Physiological pacing can be defined as the following ways. Cardiac physiological pacing is to mimic the normal conduction system itself. It can be achieved by his bundle pacing, left bundle branch area pacing, or the conventional bi-V-CRT pacing. Conduction system pacing, either his bundle or left bundle. His bundle we already know. Left bundle area pacing is intended to engage all or part of the left bundle branch or the fascicular system. Various responses can be seen, selective as well as non-selective. Non-selective means in addition to left bundle capture, there is also nearby myocardial capture. So conduction system pacing can be his bundle pacing, right bundle branch pacing, left bundle, left fascicular. Whereas the nearby septal areas when they are paced, the QRS may be narrow, but they are not actually engaging the conduction system. So the very important thing to understand is all of us think that narrow QRS complex means things are good. But when you want to correct left bundle branch block, you should precisely capture the left bundle branch block. In addition to narrowing the QRS width, you should also have all the ECG parameters to confirm that you have indeed captured the left bundle. That is very important. So mere narrowing of the QRS complex is not sufficient. So these are the various conduction system pacing targets, the His bundle, the right bundle, the left bundle, LV septal pacing, left fascicular pacing, so on and so forth. All this comes under the ambit of left bundle branch area pacing. Why should we do physiological pacing? All of us know that conventional pacing from the RV apex in particular produces what is called long-term dysynchrony due to a wide QRS morphology that we have been seeing from ages due to RV apical pacing. This causes over a period of time mechanical dysynchrony, progressive LV dilatation, LV systolic function. That is why we have moved away from the RV apex as a pacing target, and now we moved into the RV outflow septum, then into the mid septum. Now we are even more precise. We wanted to mimic the normal conduction system itself by conduction system pacing. The RV apical location causes mechanical dysynchrony, systolic, diastolic dysfunction, AF, mitral regurgitation, tricuspid regurgitation, so on and so forth. What is the incidence of pacing-induced cardiomyopathy? Various definitions have been used for pacing-induced cardiomyopathy, and the incidence is between 6 to 25%, depending on your definitions. And what are the risk factors? Male, gender, history of MI, chronic kidney disease, AF, baseline LV ejection fraction being low, native QRS being wider, RV percentage of RV pacing. More the RV pacing, more is the dysynchrony. More than 40% means it is a high dependence on RV pacing. And of course, the paced QRS duration. And that is what makes conduction system pacing very attractive and different from RV pacing, because RV pacing traditionally has a very wide QRS complex and conduction system pacing has narrow QRS complex. So when should you do physiological pacing? These are some of the guidelines. This is the most recent Heart Rhythm Society, Asia Pacific Heart Rhythm Society guidelines on cardiac physiological pacing. If you see this, which I have circled here, patients with indications for pacemaker therapy for bradyarrhythmia, where you anticipate substantial ventricular pacing more than 40%, and if they already have a compromised systolic function, thus these patients become candidates for either BiV-CRT or conduction system pacing. The level of recommendation is 2A. If you look at heart failure as an indication for pacemaker, conventionally we know that any patient with heart failure with a wide QRS complex, it is an indication for BiV-CRT. If a BiV-CRT cannot be done for whatever reason, there is no good target vein, or you are able to enter the target vein, the thresholds are very high. The thresholds are not very high, but there is phrenic nerve capture even at low output. So you cannot use. So an alternative can be a conduction system pacing, that is a class 2A recommendation. How do you do, moving on from the subject of physiological pacing to left bundle area pacing, which is the focus of this particular session. How do we do left bundle branch area pacing? So that is left bundle area pacing. It is a little more distal to the His bundle location, about 2 centimeters below the level of the His bundle location, which was the earlier preferred target for conduction system pacing. His bundle pacing has strong points and has also a lot of drawbacks. You have to be very precisely addressing a very narrow target. High capture thresholds are a very common problem with His bundle pacing. You may have sensing issues. The R wave may not be tall. You may also sense far field atrial activity. All these are some of the negative points of His bundle pacing. And these are to some extent avoided by left bundle branch area pacing, which is a wider area. You have very good thresholds. You have very good sensing amplitude, so on and so forth. However, the data is not very robust in terms of lack of randomized control data with left bundle pacing. We are only having emerging observational data. So the key steps in left bundle area pacing are: 1, localizing the lead insertion site where you should keep the sheath. Penetrating the interventricular septum. Having taken the support of the sheath, you start drilling the lead. So penetrating the interventricular septum is a very important step. Determining the depth of lead penetration during rotations. confirmation of left conduction system capture and testing of electrical parameters. This is what is very important. Mere narrowing of the QRS complex is not sufficient. You should ensure that you have indeed captured the left bundle. How do we confirm? We will quickly go through some points. Of course, slitting like the way we do for biventricular CRT and rechecking the electrical parameters of slitting. These are some of the key steps in left bundle branch area pacing. And this is the lead that we use. This is the stylet-less lead, lumen-less lead of Medtronic, the 3830. And this is the preformed sheath that is used for you to gain access to the septum in a perpendicular fashion. That is the C315 his sheath. How to localize the lead insertion site? If you have an imaginary line from the summit of the tricuspid valve, which is the location of the his bundle, to the apex, the left bundle area is something like 15 to 35 millimeters from the location of the his bundle. And the LAO view is commonly used for you to have a perpendicular orientation to the interventricular septum in this fashion. Of course, it should be compounded by fine tuning in the right anterior oblique view also, not just the LAO view. Penetrating the interventricular septum, if you have this kind of if a torque quickly builds up, even with a few rotations, you'll have to remove it. You have to clean the screw from entangled material. Otherwise, you'll spoil the screw tip. What is recommended is a screwdriver, a constant screwdriver, a forward motion as you turn the lead outside is what is recommended. Determining the depth of lead during the depth of penetration of the lead during rotations. There are various points. This is very important. You can do continuous fluoroscopy to see the progression in the screw as you screw it in. The unipolar paced QRS morphology is very important. The QRS morphology is different from the RV endocardium to the RV septum to the mid septum to the left bundle. There is sequential change in the unipolar paced QRS morphology, which is very useful to know whether you have reached the left bundle area. Of course, as you reach the left conduction system, you create ectopics. Those ectopics also, like we relied upon the paced QRS morphology, will be very helpful. The unipolar lead impedances are also very useful. As you go towards the LV endocardium, there is a drop in the impedance. Sudden drop in the impedance is not a good sign. That means you are going to have imminent perforation into the left ventricle. So monitoring the unipolar lead impedance, initially rises, then falls. You don't want abrupt falls in the values. You look at the myocardial current of injury. The current of injury is very high to start with. It becomes progressively lesser. But if it abruptly comes down, you have to stop further rotations of the screw. That's very important. And of course, visualization of the bundle branch potential, if possible, not in all cases. If it is there, it's very good sign. A rocking motion of the lead tip means it is suboptimally penetrated. So this is an example of the sheath coming through the guide wire into the right ventricle. Ideally, it should fall into the right ventricular apex, as you see here. Then with a counterclockwise motion, you can pull it back. And that is how you should orient the sheath perpendicular to the septum. And then you start screwing and look for progression. And this is what I told you. This is very interesting. When in the RV septum, you have notches in the lateral leads, like the typical left bundle branch block, lead 1, AVL, V5, V6, they have that M pattern if you are in the RV septum. And this is something very important. The R wave peak time in V6, beginning of the QRS or beginning of the pacing spike to the earliest activation in V6 is called the R wave peak time. It is more than 120 milliseconds here. As you progressively move forward, the QRS becomes narrower, the V6 R wave peak time progressively becomes shorter. And when you reach the left bundle, you have a deeper S in a lead V5, V6, as you see here. The QRS is narrow. You have deeper S in V5, V6. You have a very prominent R in lead V1, as you see here. Something like an RSR dash pattern in V1. And of course, the quickest time, the V6 R wave peak time is the lowest here, 80 milliseconds. So these are some of the ECG parameters for ensuring left bundle capture. These are the ectopic beats that I earlier told about. They are almost like when you have ectopics like this in V1, a QR pattern, you can be reasonably sure that you are close to the left bundle. And this is the current of injury that I spoke about. Progressive decline. You don't want this kind of a reduction in the injury, but it's because you are going to have imminent perforation into the left ventricle. Angiography also can aid confirmation of left conduction system capture. There is something called transition. If you pace at low output and high output, if you are only pacing the myocardium, the QRS morphology will be constant. Whether it is 1 volt or whether it is 10 volt, the QRS morphology will be the same if you capture the myocardium. Unlike this, if you are engaging the conduction system, as you reduce the output, you will see distinct changes in the pattern. At high output, there will be associated myocardial capture. At a lower output, you will have exclusive conduction system capture. So this transition in morphology aids in understanding that you have indeed captured the conduction system, which will never happen if you have isolated myocardial capture. So these are some of the algorithmic approach to ensure that you have indeed captured the left bundle branch. Splitting and some quick images I'll show you. We always do a subclavian vein angio to ensure extrathoracic punctures. This is the CS sheath in a given case. We started with the CRT. The QRS did not become optimally narrowed, so we converted into a left bundle optimized CRT, as you can see here. That is the CS sheath in the RAO view that is coming here. You can see the screw-in lead being advanced into the sheath. That is the LAO view with the perpendicular orientation to the septum. Then you start screwing in the lead and you look for progress, as you can see here. That is the screw coming out of the sheath and it slips inside. These are signs of adequate penetration. So that is the RA lead, the RV ICD lead, the bi-V CRT lead in the posterolateral vein, and an additional left bundle pacing lead. And that is the QRS morphology. You look at V1, you have an RSR dash pattern, you have a deep S in V6, and you have a narrow QRS complex. All evidences to the fact that you have indeed captured exclusively the left bundle branch in this particular case. So I'll conclude by saying that in the course of this particular session, we defined what is physiological pacing, the various potential target sites for conduction system pacing from his bundle to left bundle to deep septal pacing. What are the advantages for left bundle branch area pacing as opposed to the earlier preferred his bundle location? The technical steps in a left bundle branch pacing. Mere narrowing of the QRS is not conduction system pacing. You have to look for markers of exclusive left bundle capture. And the importance of ensuring left bundle branch capture is very essential, especially if you have a patient with LV dysfunction with left bundle branch block, wide QRS, and thereby left ventricular dysfunction. Unless you capture the left bundle, you will not have the desired resynchronization result. Thank you for your kind attention.
Thank you, sir, for the wonderful talk. So I would like to ask you, in which scenario would you go for a biventricular pacing, an LBB pacing, or the LOD CRT?
See, as per current guidelines, based on the wealth of information that you have with all the randomized controlled trials, the class 1 recommendation for a patient with a wide QRS, left bundle branch block, QRS with more than 150 milliseconds, LV dysfunction, ejection fraction less than 35% with class 2, class 4 symptoms. It is a class 1 indication for bi-V CRT. So by that definition, you should go for a bi-V CRT. If for some reason you are not able to engage the CS, etc., you can convert into what is called a left bundle CRT. You are not having a bi-V lead at all. RA lead, RV lead, and a left bundle lead. You call it left bundle CRT. The case I showed you, we were able to enter the posterolateral vein, but the QRS from 180 only became 145, and the EF was 15%. So we wanted to fine-tune the result by further narrowing the QRS, and that is when this LOT CRT, left bundle optimized CRT, previously it used to be hot CRT, his bundle optimized CRT. So now people have done in resource constrained settings a dual chamber pacemaker with an atrial lead and only a left bundle lead. That's not in the guidelines.
So what do you think the future?
No, we do not. No, we use it also. No, it narrowed, not to the extent you wanted. So a combination of the CS lead, epicardial LV pacing plus a left bundle pacing is even better. See, the lot of uncertainty about left bundle branch pacing. You don't know. You don't have long-term follow-up. You don't have randomized controlled trials. So these are all issues. Whether it can be extracted in case there is an infection, lead fracture. These are all unanswered questions. So we are having a wealth of emerging observational data. This data has now propelled the class of indication from class 2B to class 2A at the present. So a time may come when depending on the outcomes, as you correctly pointed out, we will have whether it is more favored or it is disregarded. We don't know. The time is not right to answer that question.
What is the cost of the lead? Is it compared to?
Not really. About some 40,000 rupees.
40,000 extra.
Yeah, if you're having a BIV lead, also 40,000. But most of these companies are quite happy to give you at a low cost. If you do an extra CRT LBB lead, they may even give it to you free. Especially if you ask in your institution, they may give you a considerable discount.
So,
Thank
thank you, Nandarajan, for that wonderful talk. So, we had a very good session. Thank you, everyone. We're already running short of time. Thank you, everyone.
For that informative session. I would now like to call the chairpersons for the next session on complex interventions. I invite Dr. Bahulian, Dr. Beno Bijamin, and Dr. Pratap Kumar onto the stage as chairpersons for the next session.
We'll call upon Dr. Baiju.
Good evening, dear friends. So the topic given is CTO angioplasty for beginners. I will just start looking at the steps of a CTO intervention. First is a simultaneous coronary angio, then scoring of the CTO lesion with a JCT or any other score, engaging with properly selected guides with good support, shaping of the guide wire, delivery of the microcatheter into the proximal stump, enter the proximal cap, negotiate the wire to the body, exit to the distal true lumen, change the workhorse wire, remove the microcatheter, ballooning and standing, and rule out complications. Now, read the angiogram and make plans. What will we look for in an angiogram before we start? Proximal segment, origin of the vessel, that is especially on the left side, the takeoff angle of the LAD or circ, proximal disease, the disease proximal to the CTO segment. Whether the cap is ambiguous or well-defined, microchannels are there or not, are there any islands of normal lumen? Because some of the CTOs which appear as long CTOs may not be really long. There may be normal segments in between. You just need to connect between the two. Tortuosity, calcification, and length of the lesion, distal target vessel disease, branch at the distal cap, exit angle, and intervention collaterals. JCD score, as we know, length more than 20 millimeter, angulation or a bent more than 45 degree inside the lesion, blunt cap, calcification, and previous failed attempt. One important thing is that if the score is between 0 to 1, almost 80% success rate. And this is the one a beginner should start with, a low JCDO score. Strategies are antegrade wire escalation, retrograde wire escalation. Though it is known as escalation, de-escalation is also a very important part of this. Antegrade dissection re-entry, retrograde dissection re-entry, or a combination of this. So there is no ideal wire. That's why we use all these strategies. Now, if a wire can go from here, from the proximal part, and negotiate all the way down till here, we don't need to have much strategies. So there are challenges like blunt cap, calcium, bend, exit angle disease. So if a confianza is used here, it will go out. Now a fielder will not go beyond this. A Gaia may not be able to exit here. So we need to have multiple techniques, and in the usage of those techniques like microchannel probing, loose tissue tracking, and penetration, or the combination of the above. In this talk, I'll be talking mostly about the antegrade wire escalation only, as it is a beginner's session. Now, this is the structure of the plan.
Most important thing is to remember this always when we start the CTO. All CTO interventions are limited to this part, external elastic lamina. We need to, our work is behind the external elastic lamina, never outside. This is the most important thing. Now shaping of the wire, very, very important thing. Now see this is a NXT R wire which is shaped. You can see a very around 30-45 degree, around 0.5 to 1 mm from the tip. And there is a very small bend here. This is shaped for a microchannel probing. When you shape this, don't use the introducer needle for shaping this. Use a small needle, a needle which is used for giving the local is enough, because using a introducer needle it is sharp and the wire would be damaged. Gaia is a series of wires come with a pre-shaped tip, so and with an excellent shape retention, so you don't need to do much of the work here, especially in shaping. So now we will examine all the three important strategies. First one is microchannel probing. Probing is not just seeing the microchannel and negotiating it. Most of the microchannels are invisible. Even in ambiguous terms, entry into the invisible microchannel may exist. And keep the tip of the wire always straight and avoid buckling of the tip. And visual cues, this is very important. Visual cues are more important than tactile feedback in microchannel probing. Now this is an LED flush occlusion attempted from once with Gaia's second wire from outside. This patient is, now see, this is the simultaneous angio. Now if you see the simultaneous angio, this is one important point. Now we are taking the simultaneous angio with a guide catheter on the other side. This wire is put to just to prevent an injury to the donor vessel. So this would fill the collaterals completely, and you would be able to see the real extent of the CTO lesion. Now this patient has an ambiguous stem, length more than 20 millimeter, and it's a previous attempt, JCT square of 3. Now this is the approach with the next year. It is slipping into the circ. Now this picture is very important in microchannel probing. Initial visual cues which we see, initial two figures, tip is straight. When the tip becomes like this, we should stop. This is buckling. This is entering the subintima. This is how we start the subintima dissection. So this is the most important thing. Now this tries to engage. Microcatheter is being pushed. It is getting slipped into the this is another frustrating moment. Most of you might have experienced this. How to overcome this? Slowly pull on the wire while you are advancing. Very slow pull on the wire while you are advancing the microcatheter. Very slow pull, it will engage like this. Now if you see here, the wire is actually, the tip is facing up. Slightly rotate it. It is facing towards the catheter side. Slow push. Slowly. Then slow push. Then at one moment you may feel there is something, and then you just rotate it. It enters. See, this failed with the Gaia second. Now we are doing it with this thing. So it is possible. Invisible channels exist, and we need to probe it, but very fine work. Now this is wire has crossed, multiple check. You have to check in multiple views. Now another tip: confirming the true lumen position of the microcatheter. Never inject into the microcatheter to confirm whether it is the true lumen. Aspirate blood, but here also you may not be right, because if it is in the subintima, it's a large subintimal collection of blood will come. So connect transducer to the microcatheter and see. And importantly, check whether the wire goes easily into the branches. It is tended. Now penetration. Now this is an LED ostium being penetrated. Hard taper tip guide wires are used, and you need to have excellent support. Here a double lumen catheter is being used, and the movements are straight. No rotation of the tip. Only the left hand moves. Push this out. Now third strategy is a redirection with the Gaia. Now you can see this is a diagram which is showing the wire is coming and it is hitting here and finding a resistance here. wire is pulled back a little bit and then turned. The tip is now different. Toward, it is pointing towards this side. Slowly push. This is how a reader is subtle movements, subtle changes. Tip has to be observed. Visual cues. Now, Gaia, when it encounters resistance, this part will bend. So when you start wiring with wire, keep the microcatheter a little away so that you can observe this. If the microcatheter is more towards the tip, you won't be able to appreciate it. Now, this is an RCA CTO. Gaia is encountering resistance. See this? This part is bending. Very important to recognize. Not just push here. If you push here, you have lost the case. Just take it back a little bit and then turn the tip. Now, the tip was facing towards the lateral side. Now it is facing towards the medial side. Push it. It goes. Distally, it is entering a little bit into that branch. Pull back and redirect. Wire exchange and then extended. Now, when the CTO wire goes into a bad distal segment, bad means bifurcation, angle, or disease, exit segment. It usually goes into the subintima or it goes outside. Options are parallel wiring, redirection of the wire, or star, ADR, or reverse cut. Now, we will just show the parallel wiring. This has gone distally outside. We have got another wire along with it. So, usually the second wire, the first wire is kept there, second wire taken is a little harder wire, and the direction of the tip is different and the shape of the tip is also different. Now, wire exiting into the subintima, redirection of the Gaia. Now, this wire has gone out here. With Gaia, you don't need to have parallel wiring. Most of the time, you can just pull it back, redirect it most of the time slowly, and goes as standard. Now, routine intentional distal de-escalation or RIDE for bad distal segment of the CTO, which we have been describing for the last few months. Now, this is a bad distal segment, bifurcation, angle, and diseased exit. Most of the time, we fail here. We cross up to there and the wire goes outside here. Favorable factors, two favorable factors exist here. Like loose tissues are common here and then this part is softer. So, concept of RIDE is to make use of the fact that distal cap region is often softer. So, we go up to here with harder wires, but distally we don't use hard wires. We use softer wires. Here a fielder XTR is coming, it is hitting here using a confidence approach 12 to puncture into the possible microchannel, but we don't go beyond that. Take an XTR and connect through the loose tissue here. It won't go out, it goes into the lumen. This is one case, again an ISR CTO which again once failed. Now here if you analyze the distal exit segment, if you see it is very narrow here. We just need to connect here. This part is very hard. So the wire comes, this is an XTR, we start with an XTR always. Gaia second, finding resistance. Now this is a puncture with a confidence approach 12. You can see it is facing up. If you puncture more, it will go out here, outside the vessel. Now this is taken back. This is removed and this is RIDE. XTR is taken slowly. See, it negotiates the distal part without much of a difficulty. We would have gone out. It is negotiating. Now we are just pushing it down. It has crossed. It took 5 minutes. See, the difference is that to recognize that the site of failure is usually the distal end. Now this is another usual failure when you start cases. This is a case, again attempted once with a normal wire from outside, thinking that it is a channel. But if you see, this is a CTO. There is a large epicardial collateral here. And this part is very short. So it is easy? No. I am just showing this to show that things can go very, very early any time during the CTO intervention. Now this is the occlusion site. This is the enlarged version. Now this I have drawn. This part, it is ending bluntly here. And then there is some small connections, bridges. And then this part is very difficult to enter. We started sometimes shorter distances are hardest to cross. Fielder XTR coming, it goes out. Gaia going out. Gaia and Gaia 3 It again goes out. Again fielder XTR. It is outside. Out. Now we lost the case. Now we had an initial plan that either an ADR may be done in this or a retrograde. ADR is preferred because it is the same side. It is coming from the same side, the collateral. This is just to show that things can turn very complicated at any moment. Pushing down, knuckling. This is how you make a knuckle, not for the basics, but just showing that things can go very short. CTOs also are very challenging. We need to understand that before we start. This is, we are dissecting in the subintima. This is a work inside a subintima. This is a microcatheter. Now we are bringing in a Miracle 6 wire and brought in a Miracle 6 wire here and delivered the stingray. This is a stingray catheter. Two dots you can see. This is re-entry being done. Re-entry into the distal lumen through the proximal port of the stingray. After the re-entry, wire changed, stented. To summarize, when you begin the CTO career, read the angio well. Always do JCTO scoring. Antigrade wire escalation using 3 of the techniques: microchannel probing, or redirection with a Gaia, or a penetration. And failure, always identify that failure is closer than success. And never shy to reattempt, especially if you fail once, reattempt after 2-3 weeks or maybe a month later. Take time to slowly learn all the CTO techniques. Realize that takes years, but you will reach there. Thank you.
Baiju, actually, when you just put the wire down, what time you push the microcatheter down? How much millimeter of wire crossing down will you push the microcatheter also down?
You mean during the wiring with the Gaia?
When you put the wire down, you actually cross the CTO segment. You just putting the cross. It's a long CTO of 30 or 40 millimeters. You push nearly 10 millimeters down. Will you push the microcatheter down, or till the wire reaches the distal segment?
No,
Only you push the
I keep it around 10 mm away from the tip. If it is long, go 10 mm, because we just need to have a 7 to 10 mm just to see the behavior of the wire. Then push, because you need the support also. The long CTO, maybe it's a 30 mm CTO, 40 mm CTO, we enter 10 mm, then you push at this thing, and then you enter 20 mm with the wire, again push 10 mm more. So microcatheter would be around 8-10 mm behind the tip of the wire. This is how I keep it.
Second question is, what time you change the wire? Actually, how much time will you prop the lesion before you switching over to the next one?
This is the most important question, excellent question, because now I had shown 3 drawings here. One, now we are trying with a next year. Wire tip starts buckling. Time to change. There is no way there. It is going out. Come back and try a minute more. I don't waste much time. Minute more, and then it's again buckling. No, change the wire. Now with the Gaia, you do go there, and then I have shown one picture in which the tip is straight and that around 7-8 mm there is a bend coming in. Then come back and then rotate and then try to push. It's not going. I try once more, and then I change to Gaia third. Then if still it is not there, then maybe we use a convex probe for some time, enter through that part and then take it back and then again change. But I always...
You change over to the previous wire or you change over to a new wire?
Previous wire.
12, you just...
I'm happy to change over to a new wire, but previous wire. But this is very important. Distally, I always de-escalate. Always. Even nowadays, I have started de-escalating in all cases. Especially unless and until the distal exit is big, which we hardly get.
Actually, de-escalation is a must. Many people actually will not do that. But some of the people, if you're 100% sure that you are in the virus and totally in the distal segment, if you wanted to push the microcatheter down, take a Varco's wire and finish it off. Otherwise, de-escalation to a comfortable wire for you is an ideal choice. But my choice is actually, what are your choices of wires? You take one wire. What are you have a choice of wires?
I have a choice. I think everyone has a choice. I have only 3 wires. One is fielder XTR for microchannel probing. Second is Gaia series for second and third. And confidence support 12. That's all. And obviously pilot series of wires. That is for the work in the subintima, making the knuckle.
You told filter exterior, then Gaia second or third, then Confianza.
Yes.
When will you take Gaia second to Gaia 3 or Gaia second to Confianza Pro? Can you tell what conditions will you change like that?
Yes, absolutely. See, one is a straight segment in which actually a very hard straight segment where you're trying a penetration. Obviously, I change into a Confianza Pro 12. Gaia second versus third, obviously, hardness of the lesion. And when you are, trying for something sort of a puncture, you may use a Gaia third, but obviously not. Like a penetration is always done better with a Confianza series of wires.
But some of the time, the Gaia second to Gaia third is actually, if you feel that the CTO is not severely fibrocalcific, you can change or try to Gaia 3 and then do it.
True.
If it is, you are feeling that it is severely fibrocalcific lesion, you have to use a hardened wire, where it is a Confianza Pro 12, or sometimes I take a Miracle 6 or a Miracle 12 wire to cross the CTO. Then subsequently I switch over to Gaia.
Yes.
My another question is, Gaia second actually or Gaia third have a pre-shaped wire. What time you will make another one more shape, or will you shape the wire?
I won't shape. Maximum shape I will give in Gaia second is from the tip around 3-4 mm, maybe 15 degree, not more than that.
Especially only in the LED ostial CTO, where if you are actually, ideally you should take a microcatheter to go down, but sometimes if you want, you can make a smallest, only minimal switch wire shaping only is possible. Otherwise, ideally not to do a shaping, because we don't have a Gaia next wires in the country.
Yes.
Once you have a Gaia next wires, it will be very good.
Gaia next, yeah. It is very, very, you can manipulate it very nicely, Gaia next series. I've tried it in Japan.
How many times you got the wire trapped in the CTO segment, the Gaia wires?
Gaia wires, maybe I don't know. Because I used to get it very frequently with cross-it series of wires. Very frequent.
Cross it now you use?
No, I never use it.
No, you used it, now you are not using it.
Yes.
So any
Previously we used to have cross-it series of wires.
Actually, I took 5 minutes. Any questions for me?
Any questions?
I know that he is actually, he got distinction, but I just ask questions for the people.
Ostial LED CTO, could you have used the angled microcatheter so that all the time this will be.
See, I have a principle. Yeah. Keep it very simple. We don't need all these things. We may need once in a while. That is mostly not for ostial LED. It's ostial circ. This angled microcatheter would be of very much use in an ostial circ, because ostial LED, you can always point the guide towards there and do it. And you can use this. I was using as Crusade, because you park the wire into the the wire into the circ, then you can aim. But how can you do it in a circ which is bending like this? This is very useful. But most of the time we use other methods, like a retrograde entry or something like that.
I think angle microcatheter is mainly used for the septal entry rather than for entering to the major vessel. The major vessel entry, if you have a difficulty, always take a dual lumen catheter.
Yes,
than
absolutely.
anything else, and otherwise you make a bigger curve to enter inside. I don't think that is that is why that is not successful now. That catheter itself is not. Sir, any more questions? I actually wanted to make questions, but the time.
No, I think I'm not now very much into, as you have listened into these things. He presented it very nicely, but I'm only seeing that the fellows are much less. It's all for the consultants, the discussions. So I think one question I will ask for the fellows, Baiju, why don't you tell, do you go escalate the wires or in the sequence fashion, or you study the proximal stump and then select? If that is your choice, what are the sequences you go by?
Yeah, I think this is a very, very important thing. That previously we used to tell that escalate in a sequence. It is never like that. Now, but one thing is there, always start or feel or the lesion with an XTR. This is now I have shown an LED ostium. This is failed with a Gaia second from outside. But we did it with a, there would be at least 30% of cases, there would be something. Try that, nothing is lost because you can use it later also. Then the strategy comes, whether it is a hard, blunt stem, just poke it with a confiancer. Then enter and then try with the Gaia. No point in wasting time, a lot of time. This is inside the lesion also, wires have to be changed.
I will not make that comment because don't waste time. You just put a lot of effort. You try. You have to see Japanese. They try with the wire for nearly 15, 20 minutes. I also do like this 1.5 minutes, 2 minutes. I go to the next wire. But that, if you can spend time, you spend.
What I meant was actually, no, but changing the wires gives a lot of.
Thank you, Baiju, for a wonderful speech.
Thank you.
And
Thank you.
we will call upon Dr. Deepak Davidson for the next speech. And he has two talks, even though he came late. The one is actually for an accommodation purpose because Mahesh is not there. He will be giving an overview of the OCT after this talk. Thank you for the first talk.
Good evening to all of you. First of all, let me thank Pratap sir, Ashish, Ramakrishnan, as well as Abhilash for the opportunity given. Well, over the next 15 minutes, I shall take you through something on calcium management in coronary intervention. Well, I in fact prepared this for the fellows, but I do not see any fellows over here. So I think I should move very fast with these initial slides. Well, we all know that in this particular image, we are seeing mild calcification. That is, you tend to see multiple areas with small islands of calcification. In the second image, you could see that it's a moderate calcification. There are areas wherein you can see that on both the sides of the vessel, you are seeing calcification. Here, if you concentrate on either sides of the vessels, you are seeing adventitial calcification. So this you would classify as moderate calcification. And the third one, you could see that it's an extreme form of calcification. You would call it as a severe calcification. So the mild and moderate would not create much of trouble during routine interventions, but then this sort of extreme severe form of calcification is always troublesome, and you would classify this as CHIP interventions. Now, what is the importance of identifying severity of calcification? We know from whatever data that's available at this point of time, when you have severe calcification, it translates into a lot of MACE during the follow-up of these patients. So we need to do proper work, we need to do debulking, we need to do plaque modification for managing these subset of patients. Well, we also need to identify whether there is adventitial calcium or it's more of intimal calcium, because intimal calcium is more difficult to manage compared to adventitial calcium. This is the left antidescending artery. You could see that there is significant calcification in the proximal and mid segment. If you look at the green arrow, you are seeing that the calcium is actually on either sides of the wire and it's away from the wire. So you could see that it's more of adventitial calcification. But then when you look at the mid portion of the left antidescending artery, you could see that the calcium is very close to the wire, which makes us understand that it's an intimal calcification. So when we have severe calcification and more of intimal calcification, it's always difficult to manage with routine devices compared to adventitial calcification. So in order to identify this, you don't have to be super brilliant. You just have to be you need to be street smart so that you can identify that this particular patient has severe form of calcification. It's more of intimal calcification, and I need to be more aggressive in managing this particular patients. Well, I'll start with the case history of an 83-year-old gentleman who presented with an inferior myocardial infarction. He had an old inferior MI around 10-15 years ago. Now you could see that the right coronary is totally occluded. The circumflex, that's a large OM over there. That was the culprit at this point of time. We had to open up this OM branch. We were working with an EBU 3.5 through the radial approach. It was extremely difficult for us. We opened up the circumflex artery, the OM branch, but then it was extremely difficult for us to get the stent into that particular vessel. So we had to switch over to EBU 4 for a better backup support. Then we had to use a guide plus support. We had to get you could see in the second image that the guide plus catheter was taken across the lesion with a balloon support in the balloon anchor in the distal portion. And then through the guide plus catheter, we were able to get the stent across. We were able to stent it and achieve good result in the circumflex artery. Now looking at the left antidescending artery, you could see that there is a heavy calcified left antidescending artery, and you also could see that there is a very critical stenosis in the mid portion of the left antidescending artery. Now how do we manage this heavily calcified left antidescending artery in this particular 83-year-old man. Most importantly, as Baiju has mentioned, always you need to plan, strategize. What are the things probably one needs to go through? Try to avoid ad hoc procedures when you decide on an heavily calcify vessel intervention. Always try to avoid ad hoc procedures. Keep going through the angio images many times so that you tend to modify your thought process so that on the table you will be more happy managing these patients. Again, always try to keep them on good dose of beta blockers so that the heart rate is quite good. Its heart rate is very well controlled once you start the procedure. Reduce antihypertensive agents couple of days prior to the intervention so that you have a higher blood pressure on the table. Keep the blood ready for these patients. Keep the surgical team informed. Keep the anesthesia team informed. Start as an early morning case, nil orally. Also keep the intra-aortic balloon pump and ECMO ready for your patient. Well, we decided on LED angioplasty at a later date. So once we were done with the primary angioplasty, while taking out the catheter, we had a shoot of the radial artery also. That was in preparation for the next procedure. We wanted to see whether the radial arteries are good enough so that we could get a 7 French catheter through the radial approach. And secondly, we also felt that the initial intervention was done with an EBU4, so the second intervention also should be done with an EBU4. We decided that we should be doing an EBU4 so that we will get a proper backup support. So these sort of planning is extremely important for managing these patients. So again, going through femoral approach, it's always good to have a long sheath, better support, a 7 French guide catheter. You could either go through the radial or femoral, and always a 7 French guide catheter if possible. Temporary pacemaker when you have a right coronary, if at all you're planning for a rotablation, and a new guide without any kinks, start off fluid so that you have a good blood pressures during the procedure. Well, we started off through the radial approach, had a look at the circumflex. It was looking good. It was done after 3 weeks, and you could see that the guide catheter is well engaged. We had planned for a 4 guide catheter, but then we had a junior technician. He took us got a 3.5 guide catheter for us. We were happy. It was sitting well inside the coronary artery. So we thought that we wouldn't switch over to a 4 curve. We'll continue doing with the third catheter, 3.5 EBU. So again, to keep in mind that we had planned that we should go with a 4 catheter, but ultimately this is how we started off in this particular patient. We wired this patient. Now, how do we manage this particular patient? We have 2 options. We need to have an ablation strategy. We need to have a cracking strategy. We need to have an ablation. Probably ablation can be done with either a rotablation. You can do it with a orbital atherectomy or even with a laser, and cracking with all the balloon-based technologies. So volume reduction could be achieved with this ablation technology. That is, it could be rota, orbital atherectomy, or laser. That is, you can improve the lumen of the coronary artery, reduce the calcium so that you can reduce the volume of the calcium. Now, when you have an extreme case, one technique wouldn't help us out. So you need to have a volume reduction strategy, and you would always need a cracking strategy also. The cracking could be done with a non-compliant balloon. It could be done with an OPN, the cutting scoring balloons, or IVL, or even a super non-compliant balloon, the OPN balloons. So these are the options that we have: the ablation with rotational atherectomy, orbital atherectomy, excimer laser, and the balloon-based strategy, the cutting, scoring, OPN balloons, and the lithotripsy balloon. We started with an 1.75 millimeter burr. You could see that in the first image that the burr is not going through the proximal segment of the left antediscending artery. We managed to get it across, and we started off with 180,000 RPM. You could clearly see that it was a 3.5 guide. The guide is moving out. It's not providing any backup support. We kept on trying with that, but then we were not able to go through the lesion, the area where we have significant intimal calcification. Became impatient. We increased the rotational burr speed to 200,000 RPM, started pushing it across the lesion. It wouldn't go through 220,000 RPM. Again, it wouldn't go through. So at that point of time, we decided that we would downsize the burr to 1.5 millimeter burr, and then we switched over to an 1.5 millimeter burr. Again, the same thing happened with an 1.5 millimeter burr, and you could see that at some point of time, even the wire started coming out as we are burring it. Again, we got the wire across, and then again continued to do that. Ultimately, we thought that we would have a better backup support. We had to switch over to an EBU4 catheter, then started with an 1.5 millimeter burr, and you could see that it has gone across. So it took quite a long time just because of the planning was not proper. Even though we had planned properly, we couldn't execute it properly. We ultimately ended up having an EB4 catheter, good backup support. We were able to push the burr, ultimately a little bit of force. It's a judicial pushing, not just pecking. Ultimately, in these sort of extreme calcification, you need to have these sort of judicious pushing across that particular lesion. So we went across that with an 1.5 millimeter burr, then we upsized size to 1.75 millimeter burr, and then we were able to get across. So we understood that we had done enough of volume reduction in this particular patient. Now what else do we do? What should be the balloon strategy? For deciding on balloon strategy, it's always good to have an imaging done. So we had an OCT done. You could see in the upper images, the green one, you could see here that it's in this particular area, the shaved off polished area with the rota burr is very clearly seen. This is the area where you have a polishing done, the polishing of the calcium done with the rota burr. Then you could see that there is significant amount of calcification, thick calcification, 270-degree arc of calcification, almost 360-degree arc of calcification is seen. And you could also see that there is a proximal nodule over here also in the left-hand listening artery. So we decided that we'll go with the non-compliant balloon, OPN balloons. We opened it up, and finally we went ahead with the stent implantation, and that's the final stent implantation. Now, based on this particular heavy calcium, we decided that an OPN should be used in this particular patient, because when you have heavy calcification, thick calcium, it's always good to have OPN or IVL, and when it is little more thinner, it's always good to have a scoring or a cutting balloon in most of these situations. So went ahead with stent implantation, and finally we were able to achieve reasonably good result. You could see that in the OCT images, subsequent OCT images, you could see that these are the areas where you have the fracture of calcification based. So primarily what has been done in this particular patient was we had some volume reduction strategy, we had a cracking strategy. Ultimately, we were able to open up the stent properly in this particular patient. Now, when do we decide on orbital atherectomy? We decide on orbital atherectomy when you have heavy calcification and not so extensive calcification, because it takes time for burring with orbital atherectomy, and when you have a nodule also, orbital atherectomy would be useful. This is a patient who present with effort angina, and he had an impaired renal function also. 7 French guide catheter, femoral approach. In the first image, you could see that there is a bifurcation stenosis. In the second image, you could see clearly identify the amount of calcification in the left main, the calcification in the circumflex, the calcification in the LAD. All those things can be very clearly seen. We did an saline OCT. You could see in the initial images, the left main luminal area was almost 2 millimeters square. You could see that there is more than 270-degree arc of calcification here. Again, the calcium is almost 1.1 millimeter thick. And those are the information that we got with the OCT. And again, you could see here that this is the circumflex ostium. There is a nodule there at the circumflex ostium. The nodule can be clearly identified in the 3D image. You could see that this is the nodule over there. And the thickness of nodule also could be measured. That's the nodule. This is the circumflex ostium, and that's the nodule there. So the nodule was more than 1 millimeter in thickness at the circumflex ostium. It is almost 1.7 millimeter in thickness. We did orbital atherectomy at low speeds and high speeds into the LAD, both into the LAD as well as into the circumflex artery. And then again, the OCT images, you could see that the left main luminal area, which was 1.98, became 3 millimeters square. You could also see that the calcium at the ostium of the circumflex, that's a nodule sitting there at the ostium of the circumflex, it could be shaved off with the help of orbital atherectomy. That's the area where you had the calcium there. And then again, you could see that this was the thickness of the calcium in the left main, 1.1 millimeter square. You could see that it's polished out there. There has been some amount of volume reduction. It has become 630 microns. So all these things were done with the help of orbital atherectomy. Again, you could see that in the initial image, there is a nodule there at the circumflex ostium, and following the orbital atherectomy, you can see that the nodule has been shaved off. So these are the information that we got, and finally we went ahead with a balloon-based strategy. That was an angiosculpt over there, and following the angiosculpt, you could again see that there is a break in the calcium. So we did a volume reduction. We had a balloon-based strategy for volume reduction, and finally we went ahead with DK crush stenting, and that was the final result that we could achieve. Now, when do we decide on laser? When you have an uncrossable lesion, when you have an underexpanded stent, those are situations where laser would be beneficial for us. A patient who had an angioplasty long ago, 2 stents in the right coronary artery, had a restenosis, a third stent in the right coronary artery, again a restenosis, acute coronary syndrome. You could see that there is a very tight stenosis in the mid-right coronary artery. You could see in both these images, the stent at that particular area is underexpanded. There are 2 stents there, overlapping stents, and again it's an underexpanded because of calcification. So again, we went ahead with further evaluation. That was a laser. We were not able to get the OCT catheter across, so went ahead with a 0.9 fiber lacing was done, both with contrast as well as with saline. We did the lacing, and finally ultimately we were able to get the OCT catheter across. You could see that there is significant amount of calcification behind the stent, preventing the expansion of the stent over here. Again, you can see the 360-degree arc of calcification. Finally, lacing was done with contrast and saline with an 1.5 1.4 millimeter catheter also. Then we decided not to go ahead with a third stent over there, and that was the final result that we could achieve. These are the pre and post fluoroscopic images. You could see that the stent is very well expanded. The previous image, you could see that the stent was not expanded properly, and that was the final result. We could achieve a 5.4 millimeter square with the help of lacing as well as non-compliant balloons. This was an elderly man who had an anterior MI. We did an angioplasty to the LAD, and there was a hazy looking lesion in the right coronary artery. We thought it was a thrombotic lesion. We thought that we'll go ahead and stent that particular lesion also. Direct stenting was done for that, and you could see that we were not able to get any other balloon across to post-dilate that particular area. We went ahead with a lacing catheter 0.9 as well as 1.4 millimeter catheter, and finally we were able to dilate it, and this was the results pre-lacing and post-lacing and followed by balloon dilatation. This was another patient who had an angioplasty to LAD almost 1 year ago. Proximal LAD stenting was done. 5 millimeter was left alone. He presented with effort angina. You could see that there is a proximal ostial new lesion in the left anterior descending artery. In both the cranial as well as caudal views, you can clearly see that. We thought that it's a very simple case. Started through the radial approach 6 French guide catheter. Wire would go, nothing else would go. You could see that the imaging catheter wouldn't go across. So we decided on lacing. It was a 0.9 millimeter fiber, and following lacing, again we increased to 1.4 millimeter laser catheter, and finally you could see that the lumen is enlarged. Then we were easily able to get the OCT catheter across, and once the OCT catheter was across, you could see that there were multiple. So can I take just one more minute? I'll just finish this and conclude. Okay. So in these images, you could see that these were the areas where you have eruptive nodules. You could see the eruptive nodule there, and these were the areas that was polished with the laser fiber. And you could also see that there is a nodular eruption also there. So there was eruptive just in the 5 millimeter with the proximal LAD, proximal to the initial stent. You could see that there were eruptive nodule, there was calcific nodule just 1 year following the initial angioplasty in this particular patient. We decided that once we were able to get the imaging catheter, we thought that a Wolverine should settle the issue, but then we were not able to open it up. Then we went ahead with an IVL, and with the help of IVL, we were able to open it up. You could see that with the IVL, we were able to deform the nodular eruption. We were able to crack the nodules also. You could also see that there are multiple cracks made on either sides, and finally stent implantation, and we were able to achieve good results. So this was an uncrossable lesion. That was the reason why we started off with a lacing, and again it was done with a 6 French guide catheter through the radial approach, and that was the final result that we could achieve. Now, when do we decide on Wolverine? And I'll finish off with the last couple of slides. When do we decide on Wolverine and angiosculpt? When you have a thinner calcification, when you have an extremely thick calcification identified with OCT or IVUS, then in those situations, Wolverine and angiosculpt may not really help. So when you have a less thinner calcification, more than 270-degree arc, those situations, Wolverine and angiosculpt would be helpful for us. And also following rotablation, following an ablation therapy, when you want to have a better luminal gain, rather than using a non-compliant balloon, a rota cut, that is using a cutting balloon or a angiosculpt would fetch us better results.
Deepak,
And
can we?
yes, sir, I am done with that. This is the
so
last
that we
slide.
can have some discussion.
That's the last slide, sir. Thank you so much. Thank you so much.
Thank you, Deepak. I think excellent illustrative cases. Few comments on the illustrative cases which you have shown. The first case was quite good. There is a feeling, at least in the early part, that guide catheter is of not that great in rotational atherectomy, which is not correct. Yeah, guide catheter support is very important, as
Yes.
you have shown in this case, changing from 3 to 4. In fact, your case would have been failure if you don't have changed, because it will never, because rotational atherectomy is a antegrade propagating cut, unlike the orbital. So it requires that push. So your cursive support, that has been illustrated very nicely. Second thing is that it was not crossing. You have stepped up the rotational speed to 200,000. That is one step. Some people are afraid of that because it may invite problems. So there are some methods Japanese people have designed of accelerating and decelerating suddenly so that it cuts and then crosses the lesion. That's another important thing. The third thing which you showed that rotational atherectomy alone is not enough to go ahead with your stenting. Please don't do that. You check whether the preparation is adequate or not. And for that, then you have to have used the balloon technology to dilate it volume expansion. So that you have done always that, you use your rotational atherectomy, go with an imaging device, either OCT or IVUS, to see how much cut it has made. Nicely, you have shown that the type of, curvilinear cut on the plaque. Now, after the cut, if the plaque remains to be thick, then your choice goes to either IVL or OPL. So choice of balloon is decided by that single pull back of the imaging catheter. If the cut is wide angle and if it is thinned down, then probably cutting balloon may be better. Because cutting balloon, multiple blades, it gets into that crack, that point of angle, and then breaks it nicely. So it has been shown that compared to ordinary NC balloon, cutting balloon in such situations, it does better. And fourth thing is that the gain of the volume or gain of the lumen is an important determinant of ultimate stent expansion. So that is also achieved by one more run of imaging. If you have a better gain, and IVL gives you better gain rather than usual balloon, even though both may work sometimes together. IVL, apart from having a good cutting potential, it gives more lumen. And then stenting placement gives us a better lumen. Cutting balloon also compared to the usual balloon gives it lumen. Whether it results in a real endpoint reductions is not probably not known.
Yes.
So I think this is a highly illustrative part of those cases. The rest of the cases are of orbital and other things.
Actually, these are all for the rich people, For a fellow, what are the things to be done for a calcium lesion? You told laser, you told orbital atherectomy, rotational atherectomy. I'm just asking for a fellow, what is our
So you always start off with mild to moderate calcification. You start on with balloon-based technology, then you graduate to extreme severe calcification. Start off with ablation, then probably a balloon-based technology. That should be the.
I just wanted to ask this question because Natarajan told it is rich people only should do calcified lesion. Okay.
Sir, is OCT a must? What I understand from your presentation is if catheter is negotiable, you always do an OCT to further plan how to go about.
We always try to start off with imaging, but then in moderate calcification, the imaging catheter would go through. But then when you have these sort of extreme calcification, severe calcification, you invariably will not be able to get the imaging catheter across. So start off with an ablation technique. Then in order to decide on what more has to be done, and imaging is always good.
Especially when you see that intimal calcification
Yes,
with very tight, it's a good idea to go for rotational atherectomy first, followed by an imaging. You need not have the imaging first. That is one option in that particular cases. Right, I think we have had a good one simple thing. Those who do not have imaging at hand, when you have in the fluoro, if you find a lesion with calcium on either sides of the vessel lumen, please try not to attempt without adequate devices. You will end up with an expanded stent. So when you have heavy calcium, fluoroscopy, the sensitivity is less, but specificity is good. So if you find that two hard lines of calcium on either sides of the vessel, in the lesion which you are going to tackle, if you don't have any of the calcium tackling methods with you, please don't attempt in that particular case. Thank you very much. Thank you. Yes, it was an excellent discussion. I think one more task is for Deepak Davison. He's going to cover on basics of OCT. Deepak.
Yes, sir. Thank
Yes,
you
for that
once
he's only
again.
giving 9.5 minutes.
Thank
Because
you once
after
again,
this,
sir,
I can buy.
Mahesh sir and Abhilash for having me this, given me this opportunity. Well, I shall take you through just the basics of OCT. Late night, I had to prepare few slides, and then I shall go through that slides very fast. Well, this is the most important slide that I have to take you through. Looking at the images, you could identify fibrous plaque. This is the fibrous plaque. When you have bright looking areas in the vessel, you could classify it as fibrous plaque. When you have darkish looking areas, diffuse looking areas, you could classify it as a lipid plaque. And when you have a well delineated areas like this, you would classify it as a calcified area. So this particular area, the initial fibrous plaque, it looks brighter with diffuse borders. The lipid pool, it looks low backscatter, that is darker with diffuse borders, and the calcific plaques, it looks darker with well delineated borders. Well, this is how a dragonfly optis catheter would look like. You have a catheter, and inside the catheter you have a small sleeve, and inside the sleeve you have a optic fiber which moves inside and outside. It moves up and down, scanning the vessel. So this is how the image would look like. You have the initial, you have the sleeve, and inside the sleeve you have the optic fiber, and there you have the lens marker over there. So this is how the catheter moves forward. The optic fiber moves forwards and backwards, scanning the entire vessel. Now, how do we start off with the procedure? The catheter is taken out of the hoop, then it's connected to the MDU, and then subsequently you need to de-air the catheter. Basically, you have a sleeve. Then inside the sleeve, you have the optic fiber. Between the optic fiber and the sleeve, you have a potential space. In between this, inside this potential space, there is always a possibility that blood can seep in. This is the area where you have this is the potential space between the optic fiber. This is the optic fiber, and this is the sleeve, and you have a potential space over here. And if blood seeps in between this particular area, the image may not be properly acquired. So you need to purge that particular area so that you do not have any air inside that. So I'll take you through a quick case. This is a patient who has a critical stenosis of the right coronary artery. When you want to do imaging of the right coronary artery, you cannot have such a very critical stenosis. You need to dilate it with a small balloon. We always try to dilate it with a 2 millimeter balloon before we take the OCT catheter across. So we dilate it with a 2 millimeter balloon, and the catheter is prepared. Once the catheter is prepared, we make sure that we purge it outside. The most important reason why you need to purge it outside is if you get the catheter inside the coronary and unknowingly if you purge it inside the coronary, you will end up having air embolism inside the coronary. We had it a few years ago in our cath lab. So it's extremely important step that you need to purge the space between the optic fiber and the sleeve. Then you need to activate the catheter because it's got a hydrophilic coating. You need to activate with saline, and then you need to connect it to the MDU. Once you connect it, then you need to calibrate it. Calibration is simple. You're seeing that green dots over there. These green dots actually should be over the catheter. So the catheter needs to be calibrated. Once the calibration is done, you need to connect the pressure injector cable over here. That's the pressure injector, so that we always try to use pressure injection to flush the blood from inside the coronary while doing an OCT. So then the next step would be to get the OCT catheter inside the coronary artery. You can see three markers inside the catheter. That's the most distal marker. This is the middle one is the lens marker, and the most proximal one. The lens marker should actually cross the area of interest, the point of interest. Then what you do is, in case you find it difficult to negotiate the catheter across the tight lesion, you can pull back the wire a little bit and then push the wire as well as the catheter together so that it can cross the lesion. Now you could see that this particular marker, the middle marker, it has crossed the lesion. So you position it distal to the lesion, and then if you have some amount of blood inside the potential space between the optic fiber and the sleeve, you can purge it into the coronary artery because you do not have any air there. So that's the purging being done. And once that is done, you are ready with the imaging protocol. Then the catheter needs to be kept straight and make sure that the guide catheter is well inside the coronary. It shouldn't be deep inside the coronary. It shouldn't be outside the coronary, because when you purge the contrast inside the coronary. If you do not purge it properly, you won't get proper images. You tend to see blood artifacts like this. So the guide catheter should be positioned well inside the coronary artery, should not be deep inside the coronary. And how do we understand whether we are well inside the coronary artery? Once the catheter is inside the coronary artery, make a small purge of contrast so that you are sure that you are clearing the blood from inside the coronary artery, as seen in this particular image. Once you are done with that, then you could acquire the image. So that's the image acquisition. What happens is, as you inject contrast into the coronary artery, when the blood is out of the coronary artery, you can activate the catheter. It runs backwards and it scans the entire vessel. And once the procedure is done, you can take the catheter out and then analyze the images. Well, this is how the final image would look like. You have a cross-sectional image, the B mode, wherein with the help of this image, you can identify the morphology, you can identify the width of the vessel. And this is the L mode image. With the help of this L mode image, you can identify the length of the lesion, and you can see any dissection flaps or things like that could also be identified with the help of this B mode as well as M mode images. You could also use some saline flush instead of contrast in patients with renal failure. Here, this was a patient who had a bifurcation lesion. And when you use a saline, it's always good to have a guide extension catheter. That's a guide plus catheter, which is positioned well inside the left antidescending artery, so that you are selectively injecting contrast into the, selectively injecting saline into the artery, so that during the imaging, you tend to get this sort of good images. So even with a saline OCT, you could achieve these sort of excellent images. That is how the final images would look like. You could see that inside the blood vessel, there are dots like things. This is the typical blood swell when you see when you do a saline OCT compared to the contrast OCT. While doing this particular OCT, one has to be extremely careful, because as I mentioned earlier, the guide catheter should not be lying outside the coronary ostium. You wouldn't get proper images. The guide catheter should not be deep into the coronary artery. You might end up having problems. So here in this particular patient who had a mid-calcified left-hand descending artery, we did an OCT, we did a rotablation of the mid-left antidescending artery. And as we are doing the OCT imaging, this is what has happened. I hope you can identify that. As we are injecting contrast, the patient developed an ectopic, then the patient went into ventricular fibrillation. Now, if you carefully see, you could see that the guide catheter is deep inside the coronary. It's deeply positioned inside the left, into the left main coronary artery. So keep in mind that it should never be deep inside the vessel. It should not be lying in the aortic sinus. It has to be well positioned inside the coronary, but not inside the vessel. Always make sure that the pressures are seen properly before you start injecting, so the patient develop ventricular fibrillation during this contrast injection of OCT imaging. And finally, we had to defibrillate him and then complete off the procedure, and we were able to achieve good results. Similarly, one should always keep in mind that the guide catheter should also be very coaxial while doing OCT imaging. In the first image, you could see that this was a calcified left antidescending artery with a left main. You could see in the first image that the guide catheter is not sitting coaxially inside the left main coronary artery. In the second image also, you could see that the left main is diffusely diseased. Even though the guide catheter looks coaxial, you could see that it's snugly fitting into that particular coronary artery. We went ahead with rotablation inside that particular left antidescending artery, and then we did an OCT run to decide on the balloon-based strategy. You could see here that this was the OCT images. You could see that there is significant amount of calcification. It's all deep calcification. You could again see that this was the polished area with the help of rota run. That was also well appreciated. Again, you could see that the area of nodular calcium, which was polished with the rotablator. And now again, as we came near the proximal left main, you could see that there is a huge area of hematoma over there. That's the hematoma in the left main, which can be better appreciated in the L mode image. You could see that this is the guide catheter, this is the left antidescending artery. In the left main, if you concentrate, you can see that there is a huge hematoma over there. So what exactly had happened was, during the contrast injection, as seen in this particular image, you could see that we had dissected the left main ostium because the catheter was not coaxial in this particular situation. So that was the reason why we had the dissection. We quickly went ahead with balloon dilatation, further stent implantation, and that is the final result that we could achieve. You could see that we could achieve a reasonably good flow, and we also did a final OCT, made sure that there was some intramural hematoma, but it was very well sealed and patient had a good uneventful recovery. So just to highlight the fact that while doing OCT, one needs to be careful. Make sure that the guide catheter is coaxial. Make sure that the guide catheter is not too much deep into the vessel. Always always make sure that the pressures are properly seen. It's not snugly fitting into the these are just to highlight the fact that during OCT imaging one needs to be careful. Then looking at the images, you could have you always have this B mode image and you have the L mode image. In the L mode image you can measure the length of the lesion. In the B mode you can look at the morphology, you can look at the diameter of the vessel, and looking at the images you can always see the three layers. That is, you have a bright intima, you have a bright adventitia, and in between you have the dark median. That is how you would normally identify a vessel wall. And again, this is the magnified view, the bright intima, the bright adventitia, and the dark media. And again, regarding the tissue characterization, as I mentioned earlier, the bright areas, it looks like this is the fibrotic area. This is again a lipid pool, and again you could see the calcification over there. And again, this is just to highlight the fact that this is these bright areas are fibrous areas, the calcification, and you could also see the lipid pools. These are how the images would look like. This is red thrombus, this is a white thrombus, and this is a recanalized thrombus, a lotus root appearance, and finally you could also see a spontaneous coronary artery dissection there. That's the hematoma well inside the media of the vessel. That's the spontaneous coronary artery dissection. And you could also identify vulnerable plaques with the help of OCT. Vulnerable plaques can be identified when you have a thin cap fibroadenoma less than 65 microns. You could, when you have huge amount of lipids occupying more than 2 quadrant, when you see microvasculature, when you see spotty calcification, macrophages, all these things would say that this particular patient has got a vulnerable plaque and likely to have problems in future. I think I'll stop now. Thank you so much for the patient.
Thank you, Deepak, for the wonderful talk. I think, Ronnie, you should understand patient can get LM dissection, ventricular fibrillation, all by OCT. Nothing is produced by IVUS by Sergeant Narayan. Thank you for.
I also have problems, complications with those IVUS catheters too.
Thank you. We will wait for tomorrow.
Chairpersons and the speakers for that wonderful session. Next session will be on cath lab bailout, and I would like to invite the chairpersons for this session onto the stage, Dr. Baiju R, Dr. Praveen S, and Dr. Ramesh Natarajan.
Good evening all. So the next talk is on bailout strategies in the cath lab, and we have Dr. Matthew Icck giving us a lecture on that. Over to you.
Respected chairpersons, dear colleagues and friends. We learn from failure, not from success. That is exactly the crux of this talk. PCA is like cycling. While learning, we will surely get hurt, but we should never give up. Rise up and continue your good work. So, how do you go about it? While learning PCA, we should learn not only about the hardware, the procedure, but also we should learn how to manage the complications. Because of the lack of time, I will be confining myself to coronary interventions. We have the coronary mechanical complications, we have the coronary vascular failure, we have hardware malfunction, we have stent failure, systemic complications, and access site complications. And it requires time, and I hope the chairpersons will give me time, and you can see that I've taken the hands off the clock. So coming to the coronary mechanical complications, we have the coronary perforation, dissection, and rupture. Coming to coronary perforation, can be a perforation in the main vessel or in a small branch. How do you recognize that? Before we should recognize it before the TAMRate sets in. This is you can see the fluoro, AP view. You can see there is a clear space. You can faintly see there is a margin here and the pericardial margin. There is a large pericardial effusion. This occurred in our lab 2 months back. One of our patients. So main vessel perforation, we use a covered stent. We have two different covered stents. We have the most common is the Graft Master, which is available. It is available in 2.8, 3.5, and 4 sizes, available in different lengths. Usually compatible with 6F guides, but difficult. And it should be remembered that the deployment pressure is 15 atmospheres, manufactured by Abbott. Then we have the Papyrus PK stent, which we don't have in our lab, different sizes. It's a stainless steel stent, again compatible with 6-inch guide. It is deployable at 8 atmospheres, manufactured by Biotronic. What do you do when you don't have covered stents, or we are run out of covered? If it's a very large center, when you are run out of covered stents, what will you do? We can make it in a lab. That is by using, if you don't have a stent, you can take a vein, harvest a vein from the leg, small vein from the leg, and tie the branches and mount it on a stent, bare stent, suture it at both ends, and you have a covered stent in your lab. This is a mid-LED lesion. Was stented. Post-stenting, you can see there is a perforation. A Graft Master stent was taken, deployed, and you will see the good result. Side branch perforation, small branch, you can embolize that small vessel. Classically, we use the microcoils or gel form. Microcoils are usually what that is used. Gel forms are they are cost effective. If you don't have these things, what will you do? You can use subcutaneous fat. You harvest fat from the subcutaneous abdomen and subcutaneously from the abdomen and use that. Or you can take blood clots or silk sutures, you can cut it and use, or even from the tip of the coronary guide wire, you can cut and use. So if you don't have, if you exhausted your supply, you can use these. So you can see a perforation, a distal LED small branch perforation. Another view, a microcatheter was taken and embolization coils are done. So you have to prevent, how do you prevent perforations? Very important. Keep the wire tip in sight always. Do not let the wire tip be in a small branch. Advance wire slowly and continuously while doing continuous rotation. And be careful when you are using polymer jacketed wires. The dictum is all wires are potential perforators. Coronary ostial dissections, a very important thing, commonly seen, more common with Ambler's guide, and RC is more commonly affected. And it's important that once you recognize it, you stop further injections because that can extend the dissection. And you should not lose your wire position. Keep the wire there at all costs. Immediately stent the ostium to seal off the entry point of dissection, and that should be okay. If there is a pericardial effusion, in addition, it is recommended that you use a covered stent. Say RCA proximal lesion was wired, then suddenly this ostial perforation occurred. A covered stent was used, a long stent was used to seal the proximal RCA. The stent should protrude into the aorta. Coronary rupture usually occurs with the use of an oversized stent. Management, do not lose the wire access. Quickly put in a covered stent. Coronary vascular failure, the second part is coronary vascular failure. You have the stent thrombosis, air embolism, and no reflow. Air embolism can result in vessel cutoff due to vessel occlusion, can result in no flow, slow flow, can cause angina, hypotension, myocardial infarction. It's very common complication. What do? You open the 2E valve and allow back bleeding from the catheter. Anticipate cardiac arrest. Alert everyone. If there is air persisting in the proximal part, you aspirate it. Or there is air in the distal part, you inject saline or blood to dissipate the air. If you get persistent slow flow, you use vasodilators like adenosine. Coming to stent thrombosis. Hyperacute stent thrombosis can occur rarely during the procedure. The treatment is thrombectomy with aspiration catheter, glycoprotein 2B3A inhibitors. And after the procedure, when you tackle that, you should look what caused the stent thrombosis, whether there was under-deployment, under-expansion, malapposition, and whether there were any significant inflow or outflow obstructions to the valve. Slow flow is usually seen when you do a PCA for the ACS patient, more common in thrombotic lesions. We all know the drugs treatment. It's basically drugs like adenosine, adrenaline, sodium nitroprusside, nicotinic, etc. And if we usually give it through the guide, but we may have to give it more at the site of the problem. So perforated balloon is a practical option. You put some perforation on a balloon and inject it. How to avoid do direct stenting whenever possible? When pre-dilatation is required, use smaller balloons in ACS. If post-dilatation is required, post-dilate focally, that is in ACS. If a large amounts of thrombus are persisting, consider deferred stenting for myocardial infarction. We have an important problem that is acute vessel closure, pre-stenting and post-stenting. Pre-stenting, it could be due to air embolism, coronary spasm, slow flow. Post-stenting, it could be due to aortic stent edge dissection, stent thrombosis, again slow flow or no flow. We have to find out what is the reason. First is to give a vasodilators. If it is due to spasm, it will be relieved. Edge dissection has to be ruled out by using the imaging. If imaging is not available, you put in a balloon catheter to take an image. If it is a dissection, the dissection will be tagged up and you will see the distal flow coming up. Hardware failure is another important thing. You have different hardware failures like catheter knots, guide wire breakage, stuck guide wire, balloon shaft breakage, stuck balloon, balloon ruptures. Radial knot, you have all encountered this thing. You unravel it by turning it by giving an opposite torque. If it is not torquing, what will you do? That is the most important thing. You will have to hold the upper end of the catheter by getting an access from the femoral side and holding the distal end with a snare and then give the torque. This will unravel. Another important thing is the stuck guide wire. Especially this occurs usually with the Gaia wires, as already Dr. Baiju has already spoken. There are different techniques of removing the stuck guide wire. One is using a microcatheter. You pass a microcatheter as far as possible and try gently pulling it out. But it should be gentle. We may break the wire. Second is mother and child method. You use a smaller catheter, mother and child technique. You advance another catheter down and try to pull it out. Third technique is a dissection technique. When all these methods fail, you dissect. You take a harder wire. This is an RCA catheter, sorry, this is an RCA CTO. A Gaia wire was introduced and it got stuck. So another harder wire was taken parallel to the Gaia wire and smaller balloon, 1.5 millimeter balloon was taken and multiple dissections were done around the Gaia wire. And this occurred about 1 month back in our lab. We were able to take out the wire and we could complete that thing. That was the wire which was actually drawn out. Guide wire breakage is an RCA angioplasty. The broken end could not be taken out, it had to be stented. Then one important thing is the balloon breakage. You can have, sometimes the balloon may break in the shaft. If the end of the broken end is still in the guide, you can take another balloon, 2.5 millimeter balloon, and try to inflate the balloon and try to trap the broken end of the balloon and try to withdraw the whole assembly and take out the balloon. Another technique is to pass another wire, put another small balloon distally, inflate it, and try to take it out as an entire system. Then using a coronary stair, that's another thing. Then another important thing is the stuck balloon. Can I continue?
Please.
Yeah. Stuck balloon. Stuck balloon in the coronary is another emergency. The first thing you can do is to force aspiration with a 50 ml syringe. Second is you reduce the viscosity of the contrast by injecting saline through an inflator, and then again try deflating it, because usually the stuck balloon may be due to a high contrast inside the balloon. Second is you try to overinflate the balloon to rupture it. However, but this carries the risk of coronary dissection. Another thing that can be done is rupture the balloon with the hard end of a stiff wire, or with the end of a coronary wire. And the final thing, you cut the hypotube, pass the stiff end of the pass the stiff end of a coronary wire into the lumen of the catheter, and try to optimize the patency of the lumen. Then the balloon may deflate by itself. Rotawire stuck. Give adequate vasodilators and try to pull back the device. Deep intubation of the guide and try pulling it back. Increase the rotablation speed and try to advance the burr into distal lumen and then withdraw. And finally, there's a dissection method. Again, pass another wire, try to dissect out and take it out. Then snare, you can cut the system. The final is snaring. You cut the system, pass a snare around and pull it out. Child catheter can also be tried, mother and child system, and finally is the surgical removal. Stent issues, stent thrombosis, stent loss, stent deformity, stent loss. One is the most important is stent retrieval with a balloon. You pass a small balloon through the lumen of the stent, inflate it, then pull it out. Then you pass another second method is retrieval by distal guide wire tolling technique. You pass a wire alongside the stent, go to the distal part and try to entangle the wires, then you pull it out. Then retrieval with the snare. Then, which if you cannot take out the stent, you can deploy the stent. And finally is the stent crushing. You crush with another stent. Systemic issues, we have the hypersensitivity, contrast hypersensitivity, contrast-induced nephropathy and stroke. Hypersensitivity could be minor, moderate, like bronchospasm, and severe. That is most important. Patient going to shock, laryngospasm, respiratory arrest. You identify it early. The most important thing is the antidote is adrenaline. Give it early.
Matthew, if you can summarize some of these.
So finally, if you have hypotension during PCA, what are the important causes? You should know the list. One is vasovagal, second hypovolemia, contrast allergy, air embolism, acute vessel closure, coronary perforation, and bleeding. Try to identify what is causing the hypotension and try to salvage the situation. So what are the toolkits if you have in the cath labs you should have? You should have covered stents, peripheral covered stents, microcatheters, gel form, microcoils, and snare. And the most important is we should have a composed mind. We should never lose hope. Try to fight till the last. My time is over. I hope you gained something.
Thank you, Matthew. It was a very extensive topic. In fact, 12 minutes was very short for Matthew to cover it, but you have done justice to your talk. You have covered most of the things, and the last final slides were, I think, that summarize the, what should be your the toolkit, and the flow chart which he showed was excellent. Just one question about the stuck wire which you are saying, and how often do you find it, and is it actually getting stuck in the lesion? Because I'm not.
It can occur. This occurred with a Gaia wire, especially when the Gaia.
How do you recognize?
It is not coming back. It is not coming back. And the proximal part had unraveled. First thing we can do is you pass a catheter over that. But if it is unraveled, you cannot pass it. So in that situation, you have to dissect and take it out. We used a Progress 80 wire.
It's used on a microcatheter. So you have the microcatheter already there.
In that patient, there was no microcatheter.
Any question from the fellows? Then we can close the session.
Thank you, sir. Thank you, chairpersons. We are moving to the next session. That is the bifurcation stenting. We are already late by 40 minutes, so we are slightly shuffling the schedule. We'll have all the lectures first, then we will try to demonstrate some of the techniques with the simulator as the time permits. So we would like to invite Dr. Ronnie Matthew, Dr. Madhu Sridharan, and Dr. Sajan Ahmed as chairpersons. Sirs, please.
While Ronnie is coming, we'll ask Dr. Shiv Prasad to kind of start the talk.
Thank you, Dr. Pratap, Dr. Ashish, and Dr. Abhilash to giving me this opportunity. How many fellows are here actually? I see mostly junior experts here who has already been doing DK crash, and I see very few fellows here whom this talk is intended. It's actually what is basically important in deciding on a two-stint strategy that would DK crash. You have to study the anatomy well. What type of lesion, bifurcation lesion is it? What is the size of the main vessel? What is the proximal vessel size? What is the distal main vessel size? Which can be attributed as a side branch? Sometimes there is, you see some statements like ASB in my talk coming. The ASB means assigned side branch. Sometimes if you take LCX OM, you see that LCM continues as a major OM, and then you see a small branch with that is a circumflex which is continuing. Then you can assign the side branch as the left circumflex as the side branch and the OM as the main branch. So that is an assigned side branch. And here you have to identify the distal vessel, look for angulation, calcification, thrombus, and then classify the lesion based on the most commonly used one, Medina 111. You know what the classification is. I'm not going into the details due to lack of time. In this case, it is Medina 111 lesion, which is involving the proximal LAD and the diagonal. And now, the lesion you have to assess how much is the lesion in the side branch, how severe it is. If it is severe in left mainstem bifurcations, 70% stenosis is enough to consider as a major criteria. And if you have non-LMCA, it is 90% lesion in the side branch is considered a significant side branch disease. And the lesion length should be more than 10 millimeters to consider that as a very significant lesion in the side branch. And another important criteria which has come up, if the side branch is more than 70 millimeters long, then that is considered as a major side branch, and the size is around 2.25 or 2.5, considered as a major, which should be protected. Now, once you decide that it is a two-stint strategy, DK crush is preferred if you have a narrow bifurcation angle. Now, axis can be radial with 6F or femoral 7F or 8F, especially if there is calcification tortuosity and you are planning to do more gadgets. Guide for right, it can be AL 0.75 or AL1 for RCA, and EBU for left coronary artery. You assess the vessels for angulation, calcification, and tortuosity, and basically both vessels should be wired, and prepare both lesions. This is very important point. Prepare both lesions very, very well using optimally sized balloons. If possible, prepare the vessels, especially if you see that there is a fibrotic lesion or calcific lesion, use NCB balloons. If that is not trackable, you can use a semi-compliant balloon, or sometimes you may have to use atherectomy devices, which should be 0.25, 0.5 millimeter lesser in size. Now, after preparing the vessel, or if you can pass the imaging, you can pass the image catheter earlier, but this is very essential in left main bifurcations. But for non-left main bifurcation, this has not come up a class 1 recommendation. So if you have non-LM bifurcations, it is optional to do a imaging. And here, what are the important informations? You know about the type of the lesion, morphology of the lesion, lesion length, and also is there any calcification at the junctures where you have to act more aggressively. Now here the lesion length is in the LAD is nearly 40 millimeters, and you see largely a fibrotic lesion with less of calcium. You see the dissections which are induced with the balloon, and you have decided the lesion length is 39.2, that is around 40. This is the pre-run lesion, and you can see that the lesions are basically fibrotic and not calcified. And now similarly, you prepared the side branch. You can see that the catheter was not, OCT catheter was not passing in, so I dilated it, and we are now having the side branch run, which gives you an idea about the length of the side branch lesion and the morphology of the side branch lesion and the vessel diameter. Here the length, the diameter is around 2.95, it comes to 2.5, 2.5 and 2.89 in the proximal segment. And first thing you should do is, after preparing the vessel well, plan for the first step is the side branch stenting. 2 to 4 millimeters stent should preferably be pulled back into the main vessel, and the main vessel you should have a balloon, preferably a non-compliant balloon, which is matched to the size of the distal main vessel diameter, placed across the point where you are going to pull back the side branch stent. After placing it well in all different views where you see the ostium of the side branch well, you place the side branch stent, deploy it. After deployment, next important step is to optimize the side branch ostium very, very well. Pull back the side branch balloon, go to high pressures, so that make the optimal sizing of the ostium of the side branch. If you think that you have not optimized it well, you can use a non-compliant balloon and optimize the side branch ostium. After that, you remove the wire and the balloon and crush the side branch stent which is jutting into the main vessel. This is the first balloon crush, and I have added one more step here, that is the first pot. In case you think that your optimal crushing is, the crushing is not optimal, you can use an NCB balloon, little higher sized, and place it exactly at the point where the stent is jutting into the main vessel and crush it. This is to optimize the crush in the proximal main vessel. After that, you have to side branch rewire. You go through a non-distal or a proximal rewiring. I will tell you, if time permits, why this is important. Now here, after wiring it, I have done the OCT, and see that is going through the non-distal strut. It's not working. Anyway, can you help me with this? Okay, it's not working now. Now, after that, that shows that OCT was showing that it is non-distal wiring. Now, this is the first kissing balloon inflation, where you use a sized balloon which is matching to the side branch and the distal main vessel diameter. You crush the stent, you give the kissing, and after the kissing, you plan for the main vessel stenting. Main vessel stent, in this case, intentionally I remove the wire and the balloon from the side branch and use only the stent in the main vessel. In some operators, keep the wire inside the side branch and you can stent it. They say that you can remove the wire, there will not be a problem, even after stenting the side branch. But by practice, I don't usually keep the wire or the balloon in the side branch. It is preferable to avoid that thing, because there is a possibility of trapping the wire inside between the two metal struts. So place it, and after placing the main stent, most important thing is to place the pot balloon. Pot balloon should be adjusted such that the distal marker should be just ahead of the bifurcation carina. And then you give optimal pressures and pot, then you go for a side branch rewiring. Again, this should be through a central strut. This should not be too proximal, too distal. It should be through a central strut, and then prepare the side branch and the main vessel, and for the second kissing balloon inflations. Here also the distal main vessel diameter is taken for the balloon in the main vessel, and the 1-to-1 balloon for the side branch. Give adequate kissing and then give the final pot. Final pot, again, the pot balloon should be placed in such a way that the distal marker should be before the carina. And the final run of OCT is done to see whether what you have done is right. Whether there is edge dissection, stent is expanded well, opposed well, And this is what the final picture is. You see that in this main proximal LAD by D1 bifurcation, we have done a good job in placing this proximal stent as well as a side branch stent, and you can see the very patent, widely patent side branch ostium, and with good expansion, that is 91%, and good lumen area gain. And this is the final picture. So this is the summary which is given in ESC article. This is the summary of the steps which I have gone through. Step 1, step 2, you know, the balloon crush of the distal main vessel. If there is an incomplete crush, you can use a port crush, that is step 4. Then step 5, proximal or non-distal wiring. Here I will tell you, here if you take this, that is the if you go through the proximal distal strut, there is a likelihood that you become abluminal, and when you dilate, the stent can get crushed like this, and the proximal part of the side branch may be devoid of any stent. So that is the problem why if you go very distal. If you go through the proximal wiring, there can be also subluminal. So if you go to non-distal wiring, that is the importance. And this is step 7, you deploy the main vessel stent, optimize it. Here also you make it a point that you don't cross to the across the carina. If you cross across the carina, you have deformed the side branch stent. So that point is also important. Then you go through the centralized the crossing, and you should not cross through too proximal where it can be abluminal in the main vessel stent and can crush the main vessel stent if you when you do kissing balloon. So go through the central strut, which will not cause any problem, and you should not have, you should not have a port balloon which is extended beyond the carinal angle, which I stressed earlier. So that is a summary of DK crush. If you plan well, the results are very good. And there are difficulties in which recrossing through the side branch strut stent. This is basically because you are not prepared the side branch ostium very well after implanting the first stent. So that is why that point becomes very, very important. Preparing the side branch ostium after deploying the side branch stent. Thank you very much.
Yeah, no, I think you have described it extremely well. I don't think there is any doubts. I think those points that you said is very important. First time, what we call as the step crush. Not only crush the side branch stent, what you call it as the pot, they call it as a step crush.
Step crush.
There is 0.5 millimeter larger step crush. And then once you place the second main vessel stent, always do a pot, very good pot.
Thank you.
Crossing is very good. And I think all the steps very clearly said.
Just 2 questions. Is there any bifurcation where you would prefer any other technique rather than the DK crush? And 2, what kind of wires would you use for crossing into the side branch?
Now, there is an issue regarding that. I'll ask the second part about the wires. Previously, jacketed wires were not used, but now it is not an issue. You can use any type of wire for recrossing and also for this thing. And some
what
people,
would be the wire use? Your choice of wires? Your choice of wire?
Which? I didn't get
your choice.
My choice. My workhorse wire is actually this Versatone or run through, and for recrossing I may go for a polymer jacketed wire FC for easy access and more friendly with me.
And any reason where you would not use a DK crush?
Any
case where you would not use a DK crush?
All
right. Yeah.
When the side branch is not big enough, yeah. I think that's a good point, which you also said. Under the side branch is about 2.5 at least. It's not worthwhile doing a DK crush because it really...
Yeah, only 2.5, only on that situation decide on DK crush. And if the vessels are of same size, I prefer for culotte.
Thank you, sir.
DK culotte.
Yeah. Only just one thing, it's Mr. Prasad, he did a very good case, but only when you have a very early diagonal.
Yeah, that is one point. One point which I failed to mention, can I add? When you place the main vessel stent, make sure that you have around 6 to 8 millimeters of stent jutting into the proximal segment. Otherwise, you will not be able to perform a pot. Because our pot balloon minimum length is 6 millimeters. So you have to have at least 6 millimeters of stent in the proximal segment. Here we were doubtful, but finally we were managed with 6 millimeter balloon.
Yes, thank you. And the dedicated port balloon would be useful in such situations.
Very useful, very useful.
And thank you, sir. Fondly remember doing such cases with you during our PG days.
Thank you.
Just for discussion's sake, you said when you stent the main vessel, you don't have wire or balloon in the side branch. No?
I don't keep balloon or wire. I don't know any operators here who keep the wire inside.
It is
While-
recommended not to keep the wire in the side branch.
But
when
in
you're
the
putting
in
the
the ESC diagram cartoons, they have kept the wire.
Yeah, I think it's a mistake there. I also saw that there because they have very clearly.
But when
recommended-
I asked Brelek, he said some people do it. It is not a problem.
No, it just listen to Dr. Chen, Xiaoling Chen, but he says he keeps a wire. So I think it's each individual preference.
Not only that, the wire is between two metal, and therefore it can get.
Now, is there any benefit in keeping the wire? No, because there's a discussion that some people may keep a wire. But is there any benefit in keeping
Just
that
to know
wire?
where the wire is.
I think there should not be any wire. There should not be any controversy on that.
Yes, see, I think once at the
Say,
ABC this discussion took place, and some people said you should keep a wire there because you are doing a proximal or a mid cross and not a distal cross. So there are a lot of people who do the crossing without imaging by just going and seeing where your previous wire position is, because the previous wire position is in the proximal part of the carina. So you can decide on your crossing depending on your proximal wire position. But because there is two metal, you are not supposed to keep a wire. But I think, again, as you said, you can do anything you want.
Sir, in kissing balloon inflation, in which
Your mic is not on.
kissing balloon inflation, in
Yeah.
which sequence you will inflate? Side branch first, then
No,
main
that
branch,
is
or
also very
simultaneously?
important. See, when you are optimized a side branch, it is only side branch. When you are using kissing balloon, you raise the pressure simultaneously. Where also when you step down, you bring it down simultaneously. Don't make any asymmetry there, so that this can cause an asymmetrical expansion of the stent and can cause problems in the alignment of the struts. So it is important to do simultaneous going up, simultaneous going down.
Suppose if you are not
Coming down. Yeah. Which one?
Now, it's sequential to high pressures.
No, this is about kissing balloon.
No, it's sequential. Each one you can go up to 20, 22 atmospheres, whichever atmospheres, fine. But the final one is, as Dr. Prasad said, at the same pressures and come down at the same time. That will be the classical.
Small correction of the confusion. When you go for individual dilatations, go with the high pressures. But when you do the kissing, go simultaneously up and down. Otherwise, it will deform the whole geometry which you have made.
okay, first we have to go sequential, then simultaneous, like that you are telling. First sequential side branch, then main branch, then simultaneous, then deflate simultaneous.
Yeah.
Okay.
Thank you, sir. That is nice case, and we had lots of discussion. Now we'll have Sudha ma'am talking about culotte standing.
At the outset, I'd like to thank Dr. Ashish and Dr. Abhilash and the whole organizing team for giving me this opportunity. The bifurcation PCI forms about 16% of all PCI. In fact, it's a very challenging lesion subset. And the optimal sending strategy, as you have just seen, is still debated. Now, a layered provisional side branch intervention after the main vessel stenting is still regarded as a standard technique, or even currently regarded as a standard technique for majority of the CBR, as a coronary bifurcation lesions. Now, when will you consider upfront to front strategy? Now, if you have a severe stenosis extending more than 5 to 10 millimeters into the side branch, if you have a very tight lesion with a TIMI flow which is reduced, and if it is a meaningful side branch, that means the side branch is more than 2 millimeters, 2.25 to 2.5, most operators will agree. And if it's a difficult to wire side branch, where you have somehow gotten into the side branch and you don't want to lose the side branch, you have to secure it and stent the side branch first. So in that case, I think the technique would be most likely, it can be a decay crush or a reverse culotte. Now, what is culotte? It's an item of clothing worn on the lower half of the body. You can see this is King Louis the 16th flaunting his culottes. It's a split skirt like thing. And culotte stitching was first described almost 25 years ago by Dr. Bernard Chevalier. And the types of culotte stitching, it can be the true culotte stitching where the main vessel is stented first, and then you do a provisional stenting of the side branch into the proximal main vessel, depending upon what you find after the stenting of the main vessel. You do stenting of the main vessel and you find that the side branch ostium is not optimal, or the side branch is, the result is not optimal, you can do a provisional stenting of the side branch into the proximal main vessel, or you can do an inverted culotte. Now, here, this is a true two-stent strategy where you stent the side branch first into the proximal main vessel, and then the main vessel is stent is placed concentrically through the side branch struts which are dilated. And now we have the double kiss mini culotte stenting also. We'll come to that. Now, this is the principle of culotte stenting. The can be a main branch stent, and then the side branch stent may be placed in a provisional manner, or it can be a true two-stent strategy where you first place the side branch stent into the main branch, open up nicely, and then open up the struts of the side branch stent, and then place the main branch stent. Now, what Dr. Chevalier feels is that this is a very ideal technique because you have nicely opened up the ostia of both the the daughter vessels, and you have a good approximation of the metal in the proximal main vessel, and you find that the carina is also very small, and there's only a single layer of strut, metallic strut beyond the carina. So these are the advantages as envisaged by Dr. Chevalier. Now, which patient to do culotte stenting? If you have a Y-shaped bifurcation with 70-degree or less angle and diffuse disease in side branch, and most important, more or less similar sized daughter vessel, because they have to take up the size of the main vessel. So both the stents in the daughter vessel have to grow into the size of the main vessel. So, and ideally you should have the same type of, the same stent also to be used, because and we should know the expansion characters of each stent, because which stent will grow to which size. Now, this is year 2015 when I was in LAP. Now, this was a 55-year-old male, hypertensive diabetic, class 3 angina. And you can see that there was a distal mainstem lesion, and there's a tight lesion in the circumflex ostium, and also the LAD was also deceased. Now, this was done under Ivar's guidance. Dr. Babu was with me at that time, but I don't have the pictures. Now, we decided on an upfront two-stent strategy here, and we used a 7 French guide. Those days, we were afraid of bifurcation, so we used to take 7 French guide. Today, we know that we can do most of the bifurcations with the 6 French guide itself, provided it's New York material. And both the branches are wired, and the circumflex ostium was pre-dilated. Now, there's a confusion as to whether all the side branches have to be dilated. Now, only if it is very tight, it needs to be dilated. And if you know the anatomy, if you know the plaque composition, you can avoid pre-dilatation. But here we had pre-dilated the circumflex ostium. And then we have placed a stent from LMCA to circumflex. 3x38 Promus element stent has been placed. You can see a sizable length of the stent has been placed into the main stem, which is not what is currently practiced. You can see here. And it is actually jailed the LAD wire. LAD. Okay. Now, after the stent is implanted, the port is done. Now, for the sake of the juniors to know what is port, when you're doing port, we, the coronary geometry is such that it follows the fractal principle, in the sense that the two daughter vessels, if you sum up the two daughter vessels, that 0.6, that is 0.66 of that would be the size of the proximal main vessel. So that is important, so that because you have to take up the proximal vessel to that size. That's very important. Now, the stent balloon, the port has been done. Now, the jailed wire is removed from the LAD, After rewiring the LED, there's a certain difference of opinion whether you need to keep the wire there or not. And after dilating the struts of the circumflex, the second stent is delivered into the LED. And this is a 3 into 33 science prime. And then again a port was done. And then now the side branch is jailed. So rewired into the circumflex through the distal strut. We'll come to that later. And then a kissing balloon dilatation is given. You can see that. And then proximal optimization. So here you find that there's only single kissing which has been done so far. And that's the final result. The wire out picture is not there. And you can see that the lesions have been very well taken care of and patient is doing well. Now in contemporary keloid stenting, we try to minimize stent protrusion into the main vessel as much as possible. We minimize the stent layers at the neocarina and minimize the stent layers at the side branch ostium and avoid incomplete stent coverage at the side branch ostium. So these are the aims of contemporary keloid stenting. So here, what we do is an inverted keloid. What I'm trying to show is an inverted keloid step by step with double kiss. So here what we have done is, these are all the steps which I have shown earlier, the side branch stent which has been implanted into the main vessel, and then the port is done, and then it is the main branch is rewired through the distal strut. And after that, again a port is done. And before the port, you find a kissing balloon dilatation. So that is very important. In the double kiss keloid, kissing balloon dilatation is done before the second stent is implanted. So we have nicely opened up the ostia into the main vessel also. And here you can see that so that is a second stent being deployed. And then this is the port and then the kissing balloon. And that's the final result. So with double kiss mini keloid, there's a minimal protrusion of stent into the proximal main vessel. And before the second stent is deployed, a kissing balloon dilatation. It gives complete crush of the neocarina and less significant malapposition has been seen in OCT and less accumulative maze at 1 year. Now I'll come to a case, this is actually borrowed from Dr. Madhu. It's a 42-year-old male, non-STEMI, strong family history of CAD, hypertension and diabetes, and presented with NSTEMI. Now this is the anatomy. You can see that there's a borderline lesion in the LAD. And the ramus is a big vessel and the proximal main vessel has around 60% lesion. And then 2 equal sized daughter vessels and the angle is probably around 60 degree. And there's a fibrotic lesion in the ostium of I would assign the upper one as a side branch. And the lower division you find another ulcerated plaque. And the circ gives rise to a PDA, so it's a dominant vessel. So bifurcation lesion, 2 similar sized side branch, angle less than 70, and therefore the planned strategy was a DK crush in this. So here, this is done with imaging. The side branch was wired. It was wired and found a very tight fibrotic lesion, and it has been dilated with a Wolverine balloon. You can see the cuts here into the fibrotic plaque very nicely. And after that, the lower division, the lesion in the lower division has been pre-dilated with a 2.5 balloon, NC balloon. Now, the first stent is deployed. There is a 2.75 into 28 sines alpine in the side branch, extending into the main vessel, but not too much. And after that, after the stent is deployed, post-dilatation followed by port with a 3.5 balloon has been done. Now the rewiring through the distal strut into the main vessel. Now the rewiring always has to be done through a distal strut. This is extremely important. That is again basically because this will give a complete crush of the carina. That is very important. Whereas if you do a proximal wiring, what happens is the crush will be incomplete. So you have an incomplete crush of the carina. And but you have to be very careful when you're doing a distal rewiring. Basically because if you go abluminal in this situation, if you go abluminal and then enter into the main vessel, what happens is, and then you do a kissing balloon dilatation, the stent will get crushed in the distal main vessel. So that you have to be careful. And after this is the kissing balloon inflation that has been done. So this is the intermediate sequential balloon dilatation, which is being introduced here in the double kiss technique of Culotte. So the first balloon goes up, and then the second, both at high, sequentially at high pressures, and then simultaneously at lower pressures. And yeah. And after that, so now you have a good opening into the main vessel, and through which the 3 into 48 science expression has been introduced, and it is deployed. And then you have a port followed by rewiring of the upper vessel. Again, it has to be a distal wiring. Again, stepwise kissing balloon dilatation at high pressures, and then the final OCT run. You can see the white, which shows that in the L mode, you can see very nice apposition, and the final result is good. The patient did well and is doing well. Now, sequential intermediate kissing balloon dilatation. What happens is oftentimes after the classical Culotte, you find that there is a haziness or a gap or a metallic ridge or a napkin which is seen at the side branch ostium. And probably the stent is not fully covering the side branch ostium, and this increases the TLR. You know that the DK Crush 3 trial showed that the the Culotte stenting was inferior to the DK Crush. Okay, it was inferior. However, the EBC study, that is the EBC2, showed that provisional stenting and Culotte was the same results. So I think this modification of the Culotte stenting has improved the results. And the port alone, as I mentioned earlier, gives only incomplete crush of the neocarina. You do distal rewiring and sequential intermediate kissing balloon dilatation before the second stent implant, gives a good complete crush of the neocarina and facilitates complete coverage of both the ostia and less late loss and restenosis of the side branch. And the mini Culotte, that is in the proximal main vessel, you have only very little overlap. You should have only very little overlap in the proximal part. That is extremely important. And numerically, you get less accumulative maze at 1 year and lesser TVR and TLR. Now, this is the imaging result which has been shown. Now, the procedure time maximum is with DK Crush. With DK Culotte, it is 18 minutes, and with Culotte, it is 21 minutes. And moderate apposition is again 8.1, malapposition is 8.1% with the DK Crush and 2.1% only with the DK Culotte, and significant malapposition 0.4% only with DK Culotte, whereas with DK Crush it is 3.7% and it is 1% with the Culotte. And restenosis of the side branch, this is another study comparison at the end of 5 years, 23% for Culotte and 17.56 for DK Culotte. So tips and tricks: fully expand the stent in the proximal main vessel using the Finesse law and limit the overlap of the stents as much as possible in the proximal main vessel, and port with a short non-compliant balloon. And distal recrossing is important because it removes the extra metal in the carina and also makes it central. Intermediate kissing balloon dilatation after the first stent gives complete crush of the neocarina. Port and final kiss essential after the second stent, and imaging should optimize long-term results. DK mini Culotte might give almost equivalent results as DK Crush. And this, I think, would be a more elegant technique in the sense that DK Crush, we begin as a two-stent strategy, whereas with the Culotte, you have the opportunity to convert it into a two-stent strategy if required. Thank you very much, and thanks, Madhu, for that picture. Thank you.
Yeah, I think both the techniques, DK Crush and DK Culotte, are very good for bifurcations. The only difference between the two is, I think, DK Crush can be done when you have size
Dissimilar,
disparity.
yeah.
For DK Culotte, you must have size parity.
Correct. Yeah.
Is any other question?
This napkin problem is
Yeah,
there
napkin
with the
problem.
previous DK Culotte. But after this DK Kiss Culotte,
This double kiss culotte, that is not a big problem.
No, I think it's a problem with the type of the stent also.
yeah.
All stents cannot be overexpanded.
Yeah,
So the
You have
stents
to
which
select
can
the
be
stent which
expanded.
can expand.
Yes.
The napkin ring is generally always a problem when you try to expand a small side branch stent, a 2.5 stent to about 3.8 or 4, because it just doesn't take it. You got to you'll have a metal fracture.
In fact, what they say is only 2 millimeter into the main branch is required. The side branch stent need to go only 2 millimeters into the
Yes,
main vessel.
and,
But
and
then
it is-
your pod becomes difficult.
Yeah, it
But
is-
you are anyway implanting another stent. So the overlap would be minimal.
Yeah, I'll tell you two things about it. One is they've given different terms to it. There's a mini culotte, there's a nano culotte. But the first stent in a culotte should be from proximal, not the mini. The mini should always be the second stent. The reason is because you got to do a kiss before you cross to the side branch. So if you done a mini the first time, when you do the kiss, you will cause a proximal dissection. So the first stent should be the longer stent, should not be the mini. The mini should be the second stent. I hope you understood that. If you do the mini the first time and you do a kiss, you
Yes,
have got you got to do a pot
Yes,
before you cross.
Yes, sir.
So you will make cause a proximal dissection.
Yes, sir. That's anyway, it's bound to happen, sir. It's said that when you do a DK mini culotte, the first stent, let's say you have a LED D1 bifurcation, you have the stent coming from the diagonal back into the LED. So you come back in such a way that it doesn't protrude more than 5 millimeters into the proximal LED. So it has to be less than 5 millimeters, not 2 millimeters, ma'am. It's less
I
than
was
5
going to-
millimeters.
yeah.
Now you take a pot
No,
balloon.
it's not my statement.
Yeah.
I was repeating from the
less,
webinars. PCR
yeah, ma'am,
webinars.
less than 5 millimeters. So then you take a pot balloon, which can be 6 millimeters or 8 millimeter. So you're bound to expand in the area where you haven't had a stent in the proximal LED. Then the next stent has to cover
Correct.
the dissected
Mm,
area
correct.
well into the LED. So the second stent comes much proximally into LED. The first stent, it comes only less than 5 millimeters into LED from the side branch, and then you recross into the side branch, you do a kissing balloon dilatation. Then the second stent, you're covering the entire area of geographic miss, a long one from the proximal LED well into that. Then again recross and do the kissing balloon. That's the DK mini culotte.
In fact, Dr. Ronnie was talking about the nanoculotte also. I purposefully did not mention it because it involves the
So again, the
technique.
DK mini culotte, they made out that the fluid dynamics as well as the micro CT studies mention that it's much better. As you mentioned, the napkin ring will not be there with the DK. That the reason
Yes,
being
the only
less of
difference is which is the stent that goes more proximal.
more
It's
proximal is
always
the second one.
First
Second one.
No,
No,
sir.
the
To
main
prevent
branch, the main branch stent.
The first one comes only less than 5 millimeter into the main vessel. The second one, it covers the geography.
Deepak, you're talking about a two-stent strategy. Two
No,
stent
but would
strategy.
that really make a difference, whichever it is?
It
That
prevents
is
a
how this is
dissection.
explained, sir.
And we can always go from a provisional to a two-stent strategy.
Where?
See, the advantage of a culotte over a DK crush is also the fact that in a DK crush, you have gone psychologically or mentally with two stents. When you're going with a culotte, you're always going psychologically with a single stent. And the second stent is always kept as provisional.
And
That's
not
why I
always psychologically is a single stent. Depends upon what is there in the side branch.
So therefore, if you have if you put only a small protrusion in the first stent, you're decided that you're going to go with two stents.
Yeah, in any case, I think the overlap should be minimal. That is the take home.
No, sir.
Yeah, it is.
Yeah, in the DK crush, it is a mid-stud crossing initially.
It's a non-distal stud.
If it is culotte, it is distal.
Yes.
That is basically for the carina.
A culotte is like a provisional. You can, as Dr. Ronnie was saying, it can be made into provisional. So in all provisional, it has to be distal cross. And only in DK crush, you need to have a non-distal because, as Shiprasad sir was saying, if you go distal, it can be the whole thing can be crushed towards, and you can have a part of the vessel which is not covered with the stent.
I'll
So
try
it'll
to
be
explain another way. When you do a culotte like this, you go distally. So at the end of it, you do not have metal at the neocarina. Your carina is V-shaped. So if you take a proximal cross, that much metal remains in the carina. You understand? So you're metallic neocarina. The aim of a DK kilowatt is to decrease the metallic neocarina. That's why you take the distal cross.
But two distal is when you have to be very careful. You can have abdominal wiring, as I was
That's
mentioning.
only that's only when you have a side branch stent
Correct,
in.
yes.
So here we don't have that.
Thank you, madam. It's a very elegant description.
Thank
There is a branch stent which is available, no, which can be done, which is similar to the inverted culotte by its mechanics. So, do you think it is useful in certain specific situations?
Maybe. I generally don't like this dedicated bifurcation. Anyway.
Okay.
Thank you.
Thank you, madam. We'll go on to the last talk. Mangalanathan.
Good evening, everybody. Thanks, Ashish and Abhilash SP, for giving me this opportunity to clear out all the problems created by my previous speakers. So, thank you. So, bailout techniques in bifurcation PCI. See, need for a bailout strategy in bifurcation stenting can occur in a provisional side branch strategy, and also you can end up with difficulty in planned two-stent strategy, even in DK crush or culotte. This could be due to a compromised side branch flow, which could be resulting from a dissection, or patient has gone into a hemodynamic compromise. In a planned two-stent strategy like DK crush, you can have difficulty in rewiring, balloon crossing, and even a stent delivery. So this has been previously alluded into by Professor Shivaprasad sir. The Bifurcation Academic Research Consortium has defined a side branch as a significant side branch as which is either 2 or 2.5. Some textbooks say it is 2.5. It's more than 73 millimeters in length, supplying 10% of the myocardium. And if you believe that the side branch is relevant, then steps should be taken to protect it upfront. So the definition study has defined what are complex bifurcation lesions. I am not going into the details. You have major criteria, minor criteria. And a complex bifurcation lesions, you have to plan probably a two-stent strategy upfront, or you have to use methods to protect the side branch to begin with itself. This is the same. So what are the predisposing factors of a side branch occlusion after a simple single-stent crossover strategy? You have angiographic criteria. Basically, all these criteria talks about the amount of the length of the lesion, the percentage of stenosis, the TIMI flow, the bifurcation angle, the diameter ratio between the main vessel as well as the side branch. Then whether you are using any side branch protection, in CTO type of lesions, whether you are using any dissection re-entry, and one clinical parameter is reduced left ventricular ejection fraction. You can have IVUS features, the famous eyebrow sign, and the main vessel plate thickness at the junction site, and side branch diameter ratio again. The OCT can also give some clue whether your side branch is going to develop problem like high lipid content, the main vessel lesion, the contralateral location of the lipid in the bifurcation area, narrow carina tip angle. So like that. You can have 3D volumetric CT angiographic volume rendering as well. This will also give an idea regarding whether your side branch is going to develop compromise. The mechanism of side branch occlusion is a carina shift and longitudinal plate shift. But you should remember this point. The most prevalent cause for side branch occlusion is over dilatation of the distal part of the main vessel stent during the initial implantation. And how to prevent this? Implant the first stent according to the diameter of the distal main vessel, and a final port is always has to be done. So when you are doing provisional stenting, follow all the steps, especially the port, and using non-compliant NC balloon, 1:1 ratio with the main vessel and port for kissing balloon, and a mandatory use of kissing balloon inflation in two-stent strategy, and always finish off with a proximal port. The failed provisional stenting, what are the strategies that we can use? So the proposed strategies are the T stenting, tap and culotte, and even inverted T and crush. That's a very rarely used technique. I will explain that. And before proceeding to that, you use adequate use of nitroglycerin, perform report, and always try to keep the jailed wire in place until you rewire the side branch through the distal strut and then pull out the jailed wire. And the stent crossing should be through the distal strut except in plant Icck crush. And if the side branch is still compromised, proceed for a two-stent strategy. So these are some of the techniques that can be used to perform a successful side branch crossing. Always maintain the jailed wire until rewiring is performed. Always perform port in main vessel, and minimize the passage of wire behind the main vessel. That I will come to that. Actually, this pictures diagram illustrates the most important mechanism and how to identify these things. So when you are passing the second wire, if you are feeling resistance, there is a possibility that you are going abdominal or behind the stent. So retake the wire, reshape it. I have said again I am telling that in Icck crushing always perform the port. And as I mentioned, in Icck crush, it has to be a proximal cross, whereas in other situations, it has to be a distal cross. And you can use the main vessel wire can be pulled with a J tip and can be used to cross into the side branch. Then the successful balloon crossing can be confirmed with the confirm that the side branch wire is not behind the main vessel stent by the previously mentioned angiographic and intracoronary imaging. That is ideal in this situation. We should have a low threshold to rewire the side branch to improve the crossing location. If you are not sure that you are not distal crossing, always rewire. Reperform port in the main vessel. Again, I am again coming back to this port. And use a smaller size and low profile balloon. Now you have a variety of choices are available. Or if this is failing, you can use a microcatheter across, because that can facilitate, create a channel for so that a subsequent balloon can be passed. Or you can use a stiffer balloon. A jailed wire is the most important thing when you are using a provisional stenting, because it will help to keep the side branch open. In case of side branch occlusion, a guide wire is the only marker for where to cross the side branch for its ostium location. And it facilitates the side branch favorably by changing the angle if the side branch wire is there. And it can also provide an anchoring for the guide catheter. This picture in the Euro intervention gives a detailed method of what all things can be done when you are having a side branch, a crossover stenting. As a preventive strategy, you can use pre-shaped wires, reverse wire technique, dual lumen microcatheter, angulated microcatheter, or deflectable microcatheter to cross into the side branch. Another technique is a jailed balloon. This jailed balloon can be just simply kept uninflated, or it can be balloon stent kissing, where you are dilating it fully, or modified, where you are only keeping it in the ostium, or semi-inflated. You will only give minimal pressure so that only the side branch portion of the balloon get inflated, or you can use a jailed crosshair. So these are some techniques to prevention. And for troubleshooting, you can again use pre-shaped wires, angulated microcatheters, or double lumen catheters, or deflectable catheters can also be used for this distal crossing. And rescue jail balloon dilatation can also be done if none of this works. So I will show a few cases which is done in our lab using few of these cases. This is a 52-year-old lady. It's a diagnostic angio. It's actually a case of my colleague. He simply did a crossover sending from LMCA to LAD. He was so confident that the side branch will be preserved after seeing the first angiogram. But this is what happened after the main vessel stenting. The circumflux got significantly compromised. So luckily we could pass a wire into the circumflux, pass a small profile balloon, dilated, then bigger size balloon, dilated, and finally a stent. And this is the final result. Satisfactory result. We didn't use any imaging, which would have been used ideally. So this is another case. Recently, 1.5 months back, a patient has come with NSTEMI. You can see the LAD is totally occluded. He has a significant diagonal just prior to the total occlusion. So he wired the LAD. The vessel didn't open up. So we did a balloon daughtering and a balloon dilatation. So now the vessel opened. Surprisingly, there is one more large diagonal, which also looks important. So we wired and subsequently did a pre-dilatation of the ostium, and we kept the wire there. Then we stented the main vessel. Since it is being an acute coronary syndrome, we wanted to keep the things as simple as possible. So our idea was to put a single stent, crossover stent across both diagonals. We didn't expect the first diagonals to cross off because there was no ostial lesion. But after stenting, you can see that the second diagonal again got completely occluded. So this is the, you can see that in the first panel, we are passing a small 1x8 balloon, that is a Ryuri balloon, into the side branch behind the stent, in the stent. We thought that by passing the balloon, the vessel will open up, but that didn't happen. Then our idea is to recross into the side branch and dilate the strut. But before doing that, you have to do the port. Because when you are taking another balloon or wire, there is every possibility that you can go subintimally or behind the stent. So we did the port first, so that the proximal portion of the first main vessel stent is approximated to the proximal portion of the main vessel. But we were unable to cross into the side branch with whatever techniques we were using. Then we took this particular technique. There is a balloon block and support technique. So what we used was we took a 2.5 into 10 millimeter balloon into the main vessel, into the stented segment. This was partially inflated at 6 atmospheres, and the wire was taken. And with that inflated balloon, we could pass the wire down into the side branch. So this is an excellent technique. Patient didn't have any problem. So once the wire crossed into the side branch through the strut, the vessel partially opened up. Then we did a balloon dilatation, opened up the strut. Then another stent was put, the tap and protrusion, dilatation, final kissing dilatation, and final port. And this is the final result, which looks excellent. This is another patient, lady, unstable angina, accelerated angina, left main, wire into the LCX, single stent into the LAD. There was some port, there was some compromise of the circumflex. So we recrossed, dilated the strut, we didn't put any stent. Having done the dilatation, we did a final port as well. This is the last technique I want to demonstrate. A critical stenosis. We wanted to protect the side branch. Main vessel dilatation, side vessel dilatation. This is the balloon trapping technique that we have used. Sorry. Yeah, this was the balloon trapping with the simultaneous kissing. And we could avoid a stent into the side branch, and it looks excellent result, final result. And we can use different modification of this technique, as I have mentioned earlier. And this is one last resort, that's an inverted crush technique described in the literature. That is, you use the, keep the side branch behind the main vessel stenting. And if there is, all of your measures fail, what you can do is, you can take a stent balloon or microcatheter behind the stent, crush, pass a small balloon, dilate, pass a bigger balloon, and crush the main vessel stent, just like what we do, and recross and do a final kissing. So in conclusion, dear friends, when you are doing bifurcation stenting, evaluate the bifurcation, anticipate difficult, and strategize. Be ready to convert to two-stent strategy at any time. Ideally, you should upsize the sheath and guide catheter in planned provisional stenting. Don't hesitate to change the route to femoral if engagement and support is inadequate. Always do meticulous port. Use intracoronary imaging, IVUS, OCT, or at least NBOS to study the bifurcation. Always try to use a new wire every time, and always a new balloon for recrossing. Learn the art of wire shaping according to the main vessel size, main vessel angulation, and side branch takeoff angle. Be ready to sacrifice the side branch, as maintaining the flow in main vessel is of paramount importance. Thank you.
Excellent, Dr. Mangalanand. I don't think I've heard a better talk than this for bailout bifurcation. I think it'll be of immense use to all the fellows, not only fellows, I think it's immense use to everybody. I think good tips for bifurcation.
Thanks.
Excellent. I only wanted to add one point. I think for most of your preserving the side branch, which are these small side branches, I think drug coated balloons have come in a
that's,
big way. And now that we have, other than the Magic Touch, we have Prevail from Medtronic. I think Agent has come in from Boston. I think side branch maintenance or side branch access with a drug-eluting balloon and a stent in the main vessel is I think will catch up as time goes by. That's what my feeling is.
Yeah.
Yeah. And
Yeah, nice
actually the need for side branch stenting itself is being now because many trials didn't show any advantage.
Drug-coated balloon, sorry. By the way, it's not supposed to be drug-eluting balloon. It should be drug-coated balloons.
Thanks for the great session.
Yeah.